We would like to start our first session for the second meeting for the Egyptian Pediatric Arrhythmia Conference, and starting by our first speaker, an elegant electrophysiologist from Egypt, Professor Rudaina Sobhi, and she will talk to us about red flags in pediatric ECG.
Good morning, everyone. We're happy to have you. Okay, so my talk will be about the red flags in pediatric ECG, that's recognizing the critical finding in children. Pediatric ECG interpretation differs from adults. We have in the pediatric population, we have age-related changes which make the recognition of the pathology more challenging. And of course, early recognition of the red flags can prevent a sudden cardiac death. In general, as in adults, ECG interpretation requires that we have a structural, systematic approach for ECG interpretations, going by the rate, rhythm, axis, calculating the intervals, and knowing the morphology. We need practicing, repeating and repeating to recognize the patterns. And a very important thing is to always correlate with clinical history and symptoms. It's important to know the differences between adults and children, to know when to ask for further evaluation and to avoid unnecessary further investigations, and of course not to miss the real red flags. And as a rule, we keep repeating it over and over. Remember that children are not small adults. They are a unique population. Rapidly, I'll go through the normal variants. I think my colleagues, some will talk about them more extensively, but children, they have various range of heart rates from the neonatal period till the adolescence. Generally, infants have shorter intervals, and we have in neonates and infants right ventricular dominance pattern. They have commonly sinus arrhythmia, and we have a juvenile T-wave pattern. That's the T-wave inversion in the right precordial leads. This is a normal finding in children under 12, and some even papers say under 15. Of course, these must not be confused for pathology. Rapidly, the ECG for respiratory sinus arrhythmia showing the heart rate variation with respiration. And this is an ECG showing the inverted T waves in V1 to 3, and this is a normal juvenile T wave pattern, of course, knowing the age of the patient. So, red flags are findings that suggest a serious or a life-threatening condition, and they require urgent evaluation or refer for further evaluation. Common things are common. Ventricular pre-excitation pattern, the WPW pattern, or the Wolff-Parkinson-White syndrome. They have on the ECG a distinct pattern of short PR interval, wide QRS complex, and delta wave. Why is this? Can this be a red flag? Because of course, it risks having an AVRT, that's a type of supraventricular tachycardia, atrial fibrillation, and sudden cardiac death. It requires further assessment and, of course, considering ablation. These ECGs are ECGs for WPW, showing the triad, short PR, wide QRS, and a delta wave. Why is it dangerous? Because it can lead to this. This is an pre-excited atrial fibrillation, and this can lead to this ventricular fibrillation and sudden cardiac death. Okay, so our second red flag is the prolonged QT interval, or the long QT syndrome. It's defined as having a corrected QT interval more than 460 milliseconds in children. What are the risks? Risks of having torsade de pointe, which is a type of polymorphic pulseless ventricular tachycardia associated with sudden cardiac death. وأهم حاجة طبعا, the most important when we diagnose such a condition is to know how to properly measure the QTC interval, and using the commonly used formula is the Bezet's formula. This is an ECG showing a long QT. You can see the T wave of the beat coming almost immediately before the next beat. And also there is another pattern that can be seen in those patients, which is the changing T wave axis. It's sometimes positive or negative. This is the T wave alternance. Long QT can lead also, as I said, to torsade de pointe. It's a polymorphic VT, which is pulseless. Without prolonged, it can lead to cardiac death. Short QT has been in the modern years also described to be associated with sudden cardiac death. That is a QTC, our corrected QT interval that's less than 330 milliseconds. It may indicate short QT syndrome, and it's also associated with sudden cardiac death. ECG is characteristics. They have a short QTC, a tall pointed T wave in the precordial leads. The Brugada pattern, the Brugada syndrome, it's also another channelopathy that's associated with cardiac death. They have a characteristic pattern. Of course, my dear Professor Maria will talk about this more extensively, but the pattern is having an ST elevation in V1, V2 with a downsloping of the ST segments. That's the Brugada type 1. And type 2, that's the ST elevation, looks like a saddleback. Okay. This is the pattern. Okay, you can see the downsloping ST segment. It's elevated at the start. Arrhythmogenic right ventricular cardiomyopathy can have they have signs on the ECG, and it's associated with ventricular tachycardia, and also associated with the risk of sudden cardiac death. What signs can we see on the ECG? Of course, this is complementary with other investigations, but on the ECG, we see the most specific sign is the epsilon wave. It's a small activation seen after the QRS complex in V1. We can have a T wave inversion in leads V1 to 3. طبعا بس beyond يعني لو هي لوحدها within the range of a juvenile لا مش هي دي criteria. QRS widening in V1 to V3, prolonged ST wave upstroke with the QRS widening. They have PVCs or episodes of VT with left bundle branch block morphology. Okay. Also can lead to cardiac death. What else can be alarming on the ECG? When we see multifocal or multiform PVCs, they need further investigations. Or non-sustained runs of VT, we need to investigate to know whether this is associated with a risk or not. Like, for example, with catecholaminergic polymorphic ventricular tachycardia, it's a characteristic tachycardia that has a changing axis of the QRS. You can see in the you can see some, it's obvious in V2, one QRS looks something and the other is pointing downwards. It's an up and down. Also, if we see signs of ventricular hypertrophy, they definitely need further investigations, because conditions like, for example, hypertrophic cardiomyopathy can be associated with cardiac death, or it can denote that we have a structural congenital heart disease. So these signs need further investigations. For example, the hypertrophic cardiomyopathy ECG shows increased voltage في precordial leads with non-specific ST and T wave abnormalities, and also can see the deep narrow Q waves in the leftward leads, lead 1, AVL, V5 and 6. ST segment and T wave abnormalities, طبعا ST elevation or depression may signal myocardial disease like myocarditis, pericarditis, or ischemia, like for example in Kawasaki syndrome, Kawasaki disease, or anomalous coronary artery. So when we have them, we need to go after them and investigate. And T wave inversions beyond the expected age, as we said, not a juvenile. Okay, and we have the bradyarrhythmias. Having a bradyarrhythmias that's below the age-based norms can be alarming sometimes. We have to correlate this with the clinical status. Is this patient stable with this bradycardia, or is he symptomatic? Definitely sinus poses beyond 2 seconds are alarming. Can point to sick sinus disease, sick sinus syndrome, and heart blocks, namely the second degree heart block type 2, Mobitz type 2, or the third degree, the complete heart block. They suggest a conduction system disease. This is a second degree heart block where you see for every 3 P waves, 1 is conducted. And this is a complete heart block with complete AV dissociation between the P waves and the QRS complex, and they have a narrow complex, a suprahisian escape. Of course, the tachyarrhythmias, SVT and VT can be, especially VT, can be life-threatening in children, and they require further evaluation, especially the wide complex tachycardia. They require thorough evaluation. And it may be the first sign of a structural or electrical heart disease. This is an example of a narrow complex tachycardia, a narrow complex SVT, and a wide complex tachycardia. So we can have some red flags from the history as well. When these red flags are present, even with a normal ECG, we need further evaluation. History of syncope, especially when it's during exercise, especially if during swimming as well, can be very, very alarming. Or while in supine, he's resting, they may indicate arrhythmogenic conditions. If we have a family history of sudden unexplained cardiac death in young individuals, or, of course, if there is a family history of a known inherited arrhythmia, Brugada syndrome or long QT syndrome, other relatives need to be screened. Okay, to conclude, pediatric ECGs require careful interpretation. We have to know what's normal by age, and it's very, very important. My advice is to always interpret ECGs in clinical context, and look for the red flags, because they can indicate a life-threatening condition, and early recognition and referral can save lives. Thanks to my wonderful team, and thank you.
May I continue? Thank you, Professor Dr. Rudaina. Very nice, comprehensive presentation as the tip and tricks for our frontliner even. Thank you, Professor Dr. Rudaina. First of all, I would like to congratulate Pediatric Cardiology Division, Cairo University, headed by Professor Dr. Sahar Shakir. Amazing gathering. And our EP team, Professor Dr. Wael Lotfi, Professor Dr. Rania Higazi, Professor Dr. Osama Abdelaziz, and a great team, Professor Dr. Rudaina, Sobhi, Dr. Al-Husseini. I listened that your workshop were amazing yesterday, And I would like to present Dr. Isra Surur. She will present benign arrhythmia in children.
Thank you, dear Professor. I am honored to chair in this conference. I will begin my presentation by demonstrating this scenario. This is a girl presented for routine checkup, and accidentally there is irregular rhythm. So the question, is this a benign arrhythmia or not? This is my objectives to define which is the mean by the benign arrhythmias, how to differentiate it from harmful arrhythmia, and situations where we can see benign arrhythmia, common benign arrhythmia, and how to manage it. Of course, benign arrhythmia doesn't cause any significant cardiovascular risk, so no need for advanced investigations or management or close follow-up. We consider benign arrhythmia in patients when or usually the patient is asymptomatic or just mild symptoms can be seen and infrequent symptoms, while if we see our patient has significant symptoms like syncope, we should exclude other cause of this manifestation. Also, during the arrhythmia, the patient shouldn't have any significant symptoms or shouldn't be hemodynamically unstable. The ECG, of course, should be free of any malignant ECG pattern like WBW, long QT syndrome, Brugada syndrome, and if you see such pattern, you should expect your patient is not safe and there is not just this benign arrhythmia. The benign arrhythmia occur in the form of infrequent arrhythmia, non-sustained, or arrhythmia with appropriate heart rate, so there is low burden on the myocardium, and so when we evaluate the patient by echocardiography, the cardiac function is normal. We can see benign arrhythmia in healthy pediatrics in different age group. Also, if there is underlying systemic condition like electrolyte disturbances, anemia, thyrotoxicosis, commonly the patient may have benign form of arrhythmias, of different arrhythmias. In different cardiac problems like congenital heart disease, cardiomyopathy, and cardiac surgery or post-cardiac surgery, benign arrhythmia are common. We can classify it into supraventricular arrhythmia, arrhythmia from the ventricle or ventricular arrhythmia, and we can talk about bradyarrhythmia and AV block separately. This is the different form of benign supraventricular rhythm. Benign supraventricular rhythm may occur in the form of extrasystole or junctional or atrial extrasystole. We consider it benign if it is infrequent, isolated without any other congenital or cardiac or systemic problem. Infrequent BECs during Holter monitoring, if we can describe it if less than 10% for the recording. Also, benign supraventricular rhythm may be sustained, but with heart rate appropriate for the patient age or near to the sinus rate, the normal sinus rate, like respiratory sinus arrhythmia, ectopic atrial rhythm, and wandering atrial pacemaker, accelerated junctional rhythm. All of this sustain the arrhythmia, but consider low burden on the myocardium. Supraventricular arrhythmia with tachycardia as physiological sinus tachycardia, which has normal daily variation proved by appropriate or proper heart rate variability, may be normal and benign. If there is short, non-sustained, and infrequent, non-recurrent attacks of SVT. It also could be benign. It is important to note that even if the arrhythmia or supraventricular arrhythmia is benign, and you diagnose it as a benign condition, you must exclude any underlying cardiac or systemic disease, and you must follow up some patients, like patients with frequent BECs or some sort of recurrent non-sustained supraventricular tachycardia, as this condition may progress to SVT or symptomatic SVT. So more workup may be needed for such patients. It is important also to mention that sometimes we find bradycardia even with extrasystole, and at this condition, the extrasystole are in the form of blocked atrial extrasystole, so bradycardia may be present and may be misdiagnosed as bradycardia or AV block. For the ventricular arrhythmia, it may be in the form of extrasystole or sustained ventricular arrhythmia, but with a rate appropriate for the age, which is accelerated idioventricular rhythm. It is a benign finding and can occur in the neonates, and it is usually resolved without any significance. But it is so important to differentiate ventricular arrhythmia and to know if it is benign or not benign. For the benign BVCs and ventricular arrhythmia, it is infrequent. The burden of it less than 10%, usually single, monomorphic, and suppressed with exercise. While not benign or red flags BVCs, more frequent, and if the burden is more than 20%, the patient has more risk to develop myocardial dysfunction. It is more complex in the form of pairs or runs and polymorphic, and not usually aggravated with exercise. Also, if you see BVCs in a patient has significant family history, like sudden death in the family, or like malignant ECG pattern as long QT syndrome or Brugada syndrome, you should follow your patient because it is not just benign BVCs. As we can see, it is important to differentiate both benign and not benign BVCs, because our patient will need more workup and more follow-up, and even he may be in need for further management. For the bradyarrhythmia, it may be in the form of bradyarrhythmia from the SA node, like sinus node dysfunction, as in physiological sinus bradycardia with proper heart rate variability and with normal daily variation. And you can be sure this sinus node dysfunction is not a malignant if you do stress test and it is chronotropic competence of SA node to the exercise. Junctional escape rhythm is a form of bradyarrhythmia, but it should be not sustained, infrequent, without symptoms, and with normal daily variation. Also, some form of AV block may be benign, as in first degree AV block and in Winckbach AV block or Mobitz type 2. But remember to exclude any cardiac or non-cardiac causes in pediatrics, like hyperkalemia, acute rheumatic carditis, and so on. What is how we can manage patient presented with different types of benign arrhythmia? You should make proper clinical evaluation, including history and physical examination. ECG is mandatory, and selected cases may be in need for Holter or prolonged recording to see something like frequency of the ectopy or the arrhythmia. Some cases may be in need in exercise ECG, like selected cases with BVCs and in sinus node dysfunction. Echocardiography can be done, and basic investigations to exclude any systemic problem. If your patient, or if there is no significant finding, no underlying systemic or cardiac disease, so the condition is benign and tolerated and usually resolves spontaneously. No need for further investigations and no need for special precautions or treatment. While we have some special consideration, like if your patient has any systemic condition, you must correct it. If there is structural abnormalities in the heart, like congenital heart disease and cardiomyopathy, extensive or more follow-up may be needed, and the patient may be progressed later on and may need further management. In post-cardiac surgery or patient with post-cardiac surgery, usually if the arrhythmia is early and benign, it resolves spontaneously. But for the patient with persistent and latent late arrhythmia post-surgery, it may need more follow-up. Again, please to remember, if you have significant symptoms, it is not expected to be related for just benign arrhythmia, so you must correlate the symptoms with ECG, and you must search for other causes for the significant symptoms, further investigations like echocardiography, and even we may need AB study. Also in patient with malignant or red flags ECG pattern, or if there is significant family history, your patient should be more follow-up, and he is not safe or risk for non-benign arrhythmia. So my home message, some irregular rhythm can be benign, but proper clinical evaluation is mandatory to decide the proper decision for your patient. Thank you.
Good morning, you all. Congratulations to our amazing electrophysiology team for their dedicated work, and wishing all the best for their amazing and unique conference. Thank you very much, Dr. Isra, for your excellent presentation, and I am happy to introduce Professor Rana Ihab, Assistant Lecturer of Pediatric Cardiology, Alexandria University. Her topic is non-conventional ECG for detection of pediatric arrhythmia.
Good morning. It's a great honor to be here today. Thank you for the invitation. We're going to talk about non-conventional methods for ECG recording in the diagnosis of pediatric arrhythmias. We all know the 12-lead ECG that we do in the daily practice, but we're going to explore more other placements for the electrodes. We're going to explore more positions where we can do the ECG. We're going to exclude new methods or technological methods for remote or non-conventional recording of ECGs. Regarding the non-standard electrode placement, there are well-known procedures or placements like the modified chest leads that we use mostly in the cath lab, 5 electrode systems for the Holters, Lewis leads for better P-wave viewing, high precordial leads, easy recording, esophageal or intracardiac leads. The first one is modified chest leads, where we encounter this on daily basis in the cath lab, where we change the position of the lymph leads to be on either infraclavicular, which is known as the Mason-Leaker system, or on the shoulders, which is known as the Lund lead system, while the bilateral lower limb leads will be on both hips or the lower rib cage. The second non-conventional method is the 5 electrode system. It's well known in the ambulatory ECG recordings. They record all the lymph leads and only single unipolar chest lead. Usually it's a V1 placement, but it could be changed according to the clinical scenario. it better visualizes the white complex tachycardias. It has been extensively studied in order to exclude myocardial ischemia in the adults, and it was not proven satisfactory, but regarding the white complex rhythms, either bundle branches, brady arrhythmias, or VTs, it is considered to be fine. According to most of the pediatric arrhythmias, we always look for the P waves. Like in the SVT, in the JET, in the VT, we usually need to perfectly visualize the P wave in order to properly diagnose or properly localize the origin of the arrhythmia. There's been multiple changes in the placement of the Lewis leads, but it's only 3 leads to better visualize the P wave. It shows the VA relationship, either there is dissociation or normal VA relationship, and it's best used in a diagnosis of atrial tachycardias, atrial fibrillation, and atrial flutter. The high precordial lead placement, we usually encounter this also in our clinics, where the nurse misplaces the V1 and the V2 leads in the second intercostal spaces, where we can find T-wave inversions not appropriate for age. So we pick up that the nurse is misplacing the leads. But we have to know that whenever we need to put the leads up here in the second intercostal spaces bilateral, it's very, very important. In cases where we suspect Brugada syndrome, we should at least have one high precordial lead for each patient with syncope, a red flag, family history of sudden cardiac death, premature sudden cardiac death, and especially with fevers, because it's usually precipitated by fever. So we ask the patient to have a recording during fever to exclude, or at least put aside that there is a possibility of Brugada syndrome. There are multiple published sites or numbering for the leads, but it doesn't matter. Sometimes it go like V1, 2, 3 on the right, 4, 5, 6 on the left, but we don't care. There are multiple others, but we have only to know the placements. The best one is the one on the left, where V1, 2, V1, 3, and V1, which is in the regular position. And on the other side, it's V2, 2, V2, 3, and V2, the regular one, in the position. But it's important just to be the person supervising the nurse doing the ECG, to know where each one was put. Another one of the non-standard ECG placements are the right-sided chest leads. They are just a mirror image for the left-sided chest leads, and we use them in the congenital heart patients where there is dextrocardia. And we have to also know or name the leads that they are right-sided. So we put an R right next to them. Esophageal leads are not present so much or not well known for many of us, but it looks the same like anyone who's practicing electrophysiology. It's a lead which is introduced like the temperature lead done during the cath into the esophagus. It's in the posterior part of the heart where the atria are more pronounced. The atrial signal is more pronounced than the ventricular segment, but it depends on where we're putting the esophageal lead. And it gives a signal just like this picture here. It's different from the regular ECG. It just shows an A signal and a V signal, not a P and QRS. And it's very important for also VA relationship, VA dissociation, the number of 8A waves and the conduction, the variable rates of conduction and so on. So they can be used very minimally invasive, can be used post-operative if we do not have atrial or cardiac wires. This is very well known for physicians who work in the post-cardiac surgery units, where patients after open heart surgeries will have atrial or ventricular leads or both. The leads, mostly they are epicardial leads. They are left after the surgery in order to monitor, in order to treat post-operative arrhythmias, either to overdrive in cases of atrial arrhythmias or for pacing in cases of transient heart block post-surgical. So the most important point is for pacing or overdrive, but we can use them for diagnosis also, not only for treatment, where whenever we have an atrial lead, we can connect it to an ECG electrode or a channel, and we record it and we report that this atrial lead is connected to the V1 electrode, and it causes amplification of the P wave, where we can see a bigger P wave. this spike here is the P wave. And we can know the VA relationship, as we said, the conduction, either there is block or no block, and we can track the case. So in this case, there is complete VA dissociation and complete heart block, although the rate is fine here, but this is pacing. This is a paced rhythm. In this case, the P is just directly after the QRS. As we see, this is the regular ECG leads in the 12-lead placement, and we can hardly see the P wave because it's of a very low amplitude. And we connected the atrial lead to the V2 here in order to amplify it, in order to see it. So we can diagnose the type of arrhythmia. This is another example. On the other hand, we have non-standard positions. It's not non-standard placement, it's regular placement, but with a non-standard position. The most well-known position is an abrupt standing position. We usually do this in cases with suspected long QT syndrome. Right before the stress ECG, we have to look for, whenever the patient is connected, we're having the resting ECG. Whenever the patient stands up, abrupt standing, there should be QT shortening, but whenever the QT prolongs, this is a characteristic for long QT syndrome. And of course, the stress ECG afterwards would give us more information. Recently, there have been like a huge advance in the telemetry monitoring, either on the smartphones, smartwatches, event recorders, or wearable patches, and they send the ECG either to the patient's phone or the physician's phone to be monitored. It's very, very simple to use. It's very worth the cost because it diagnoses the infrequent arrhythmias easier. It records the event where the patient presses a button or a mark button in order to record it and then view it to the physician later on. Our take-home message is that non-conventional ECG techniques expands the diagnostic accuracy beyond the 12-lead system, and we all have to be aware about different methods according to the clinical scenario. They clarify the AV activity and aid in the diagnosis of some channelopathies, just like the long QT, the wearable and digital ECG tools, the real-world continuous monitoring for more precise diagnosis of infrequent arrhythmias. Thank you.
Thank you, Dr. Rana, for your highly informative and simplified presentation. Many new information for me, at least.
You applied this in your practice?
Oh, the high precordial is a very important. Standing QT مع السبورتس participation القريب ده بقينا نعمله اكتر لان بقى في long QT on baseline and we have to look either it's a red flag or not. فلong QT او اي arrhythmia clinic.
يعني at least for children with syncope.
بالظبط. The less commonly encountered هو الاتريال lead ده بس isolated في البوست cardiac surgery يعني مش حاجه applicable in the clinic بس otherwise بنستخدمهم في الديلي practice. شكرا.
I have the pleasure to introduce one of our promising and dedicated members of EP team, Dr. Al-Hussein Ahmed, will present Bridging the Gap in Medical Management of Common Pediatric Arrhythmias.
Good morning. I'm really honored to be presenting in this prestigious conference. My talk today will be on bridging the gap in medical management of common pediatric tachyarrhythmias. I have no conflict of interest. First of all, burden of pediatric arrhythmias. Actually, in the neonatal and the fetal period, we have around 1 to 3% of the patients that's having actually fetal arrhythmias and proceeding to hydropes. Atrial flutters, we see it in the neonatal period, although we are a tertiary center, so we get a lot of these cases, but actually it's in the population around 0.1%, but actually it is a very significant cause of fetal tachycardia and fetal heart failure, and it's very easily treatable. Congenital heart disease also, up to 50% of them develop arrhythmias. 1 to 5 of the children in the population will experience a clinically significant arrhythmias. Supraventricular tachycardia is the most prevailing one, with an incidence of 1 to 250 to up to 1 to 1,000 children per year. So this is a large sum of patients. Regarding the morbidity and mortality, 0.5 to 5% of the pediatric arrhythmia cases can go into sudden cardiac death. Sudden cardiac death is a leading cause in pediatric deaths due to arrhythmias, actually long QT, Borgata syndrome, CPVT, and actually post-operative arrhythmias increase the mortality rate from around 2 to 3% in very simple procedure to 10 to 15% if not properly managed and properly treated. So risks of using adults' algorithm in pediatrics, first of all, we have different incidents and different mechanisms. We have a dosing differences. We have safety of some drugs, and this is a major issue. We have a problem of delayed recognition. A lot of the kids will not tell you that he is having palpitation. And we have a higher incidence of ICU, longer stay, so we are more prone to complications. So drug-related adverse effects, antiarrhythmics like amiodarone has a very high toxicity in children. Although this is one of our main drugs to use, we have also pro-arrhythmic risk of it. Procedural complication, unfortunately, CAS ablation, if it is in very young children, carry risk of 10 to 20% complication in comparison to older children and adults, which get around 5 to 10% complications. DC cardioversion, if it's not necessary or for an automatic tachycardia, it carries a risk of myocardial injury with no significant response to this tachycardia. Regarding re-entrant tachycardias, in difference to adults, we get a lot of AV re-entrant tachycardias rather than AV nodal re-entrant tachycardias. Children with manifest accessory pathway and WPW have a higher incidence of sudden cardiac death. So emergency management, in conjurance with the adults, we do vagal maneuvers, but actually our vagal maneuvers differ in very young children. We put ice bags on their faces and not just carotid massage. Older children get carotid massage and Valsalva. Adenosine is a drug of choice, and alternative drugs, actually, you don't use diltiazem or verapamil below the age of 1 year, and we actually defer it to below the age of 6 years. Cardioversion, we are weight-based and not just an arbitrary dose-based. Why is the difference? Actually, adenosine metabolizes very rapidly in children, so you need larger doses to control. Calcium channel blockers make kids significantly hypotensive and bradycardic, and sometimes they go into complete heart block after injection, and this is tough to deal with if you do not have a transvenous or temporary pacing service at your institute. On this panel, we get the 2019 ESC guideline. Okay, on the right, there's the 2019 ESC guideline, while on the left side, we have the 2013 position statement on management of the pediatric arrhythmias. Actually, vagal maneuvers, we do it, adenosine, and then verapamil. You see that beta blockers, it's not mentioned properly in this acute management, and we usually don't give esmolol or metoprolol IV in the emergency situation. While in chronic management, the first line of therapy in adults is beta blockers or flecainide or propafenone. We use propafenone or sotalol. If the patient is not having a structural heart disease, you can use flecainide if it is available. The third option is amiodarone. CAS ablation is a class 1 recommendation in the adult guidelines, while in our guidelines, class 2A only if this recurrent, drug-resistant, or very high-risk WPW patient, and often defer to age more than 5 years. Regarding asymptomatic WPW, actually in the adults, you do an EP study for risk stratification. In our patient population, we do an exercise testing and EP study if it's a high-risk feature. Regarding the chronic management, beta blockers in the adults, we use beta blockers and calcium channel blockers. CAS ablation is still a first-line therapy, while in our population it is class 2A. This is for AV nodal re-entrant tachycardia, and actually it's better that you have a cryoablation setup is present if you are going to cryoablate a child. sorry, if you're gonna ablate that child with AVNRT. Follow-up, there is no long-term monitoring if asymptomatic post-ablation, while in pediatrics you need regular ECG and Holter follow-ups even after the ablation. Regarding atrial tachycardia, this is the least common but the most challenging of the regular SVTs. It's usually persistent and incessant tachycardia, and actually a lot of our patients present with tachycardiomyopathy rather than the original tachycardia. In the management, according to the ESC guidelines, first drug of therapy is beta blockers. Regarding pediatrics, beta blockers or amiodarone in refractory cases. Also, ablation is deferred to older children and if there is poor control on medical therapy. And the follow-up is usually by Holter monitoring in adults, while in pediatrics you do Holters and you do regular echocardiography for the fear of developing tachycardiomyopathy. For atrial flutters, immediate cardioversion, we stand with the adults. For acute stable, this is for acute unstable cases. For acute stable cases, also we can arrange for cardioversion. If the patient is refusing, we can give amiodarone or procainamide. The chronic first line is ablation in adults, while in our pediatric population, ablation is delayed significantly if the patient is young. So we defer this with beta blockers. We manage it with beta blockers and sotalol, and actually we do not anticoagulate them unless he is a congenital heart disease or he's having an actual stroke or a thrombus that's seen in the transesophageal echo. Regarding atrial fibrillation, actually what I'm saying from this slide is AFib managed in congenital heart disease medically and not with ablation, because it has very high recurrence and you have a very high incidence of causing pulmonary venous stenosis on the long run, because you're actually isolating the pulmonary vein orifices, so this will result in pulmonary venous stenosis. So the master drugs in our arsenal is amiodarone, sotalol, beta blockers, propafenone, and flecainide. PVCs, children are more likely to have idiopathic PVCs, require closer monitoring, but actually it goes away by itself. Children are often treated conservatively unless they are heavily symptomatic or severely cardiomyopathic on presentation with PVCs. When to worry from PVCs: if it is increasing with exercise, if there is a significant echo abnormality or family history of sudden cardiac death. So the pediatric management, if there is no history of sudden cardiac death, you can use beta blockers or flecainide. If you have a structural heart disease, you can use beta blocker as the first line. If it failed, you can use amiodarone or sotalol. And the ablation rarely and reserved for very high burden patients above 20% with a cardiomyopathy risk. Regarding wide complex tachycardia in pediatric population, still we always think an antidromic SVT. However, we cannot confirm it with special lead placement or maneuvers or adenosine. You manage it as a monomorphic VT. Arrhythmic syndromes that can lead to wide complex tachycardia include long QT syndrome, CPVT, and Borgata syndrome. Cardiomyopathies, especially genetic ones, can lead to a wide complex tachycardia. Structural disorders with a special annotation for post-operative tetralogy of Fallot repair. Adults lean more for procainamide in acute setup and ablation and ICD in chronic management, while pediatricians lean more for lidocaine and defer ablation and ICD as much as they can. So if you have a monomorphic VT and the baby is stable, amiodarone or lidocaine. If it's unstable, you cardiovert. In polymorphic VT, torsades, you get magnesium sulfate and isopretorinol if it is induced by significant bradycardia. If it is SVT with apparency and you make sure that this is an SVT, you manage as SVT with adenosine. With a structural heart disease such as hypertrophic cardiomyopathy or arrhythmogenic RV dysplasia, you can use beta blockers and ICD if high risk. If no structural diseases, beta blockers, and then ablate as much as you can when the child is in the adolescent period. So my take-home message is children are not small adults. We have different mechanisms of arrhythmia, and not all drugs can be used in children. If you use this algorithm, you can do a proper and safe management. Thank you.
Thank you, Dr. Hussein, for the comprehensive talk, and thank you to all the speakers of the session for the precise, comprehensive knowledge and informations. First, I would like to congratulate the AB team, Cairo University, not only for the conference, but also for the strong steady step they are taking in the AB field, changing life of a lot of patients. Congratulations, and of course, the cooperations with our dear Peter. Always wonderful having you. We will have 5 minutes for discussion. If any of the ground have a question for any of the speaker, previous talks. Just a minute. في حد في الجراوند عنده اتفضل دكتور وائل. ممكن ايدي النور؟
وحصلت complications calcium IV يعني it might be life saving يعني I've witnessed cases يعني كان فعلا كده دي حاجة. وفي الحاجة التانية for the atrial flutter for those who refuse DC whenever possible overdrive pacing يعني سهل وبسيط يعني ما بنستعملوش عشان الدي سي يعني متواجد في كل حتة. الاوفردرايف محتاج بس قسطرة عشان نشوف بنحطه فين. كنا زمان مع دكتورة حنان بنعمله ترانس اوسوفيجيال بس يعني it's an option للي مش عايز دي سي. Thank you.
Thank you, Dr.
And
وائل.
عندي one observation, one comment كمان حسين على your talk. You mentioned the intrauterine arrhythmias. Now we do see patients with tachyarrhythmias more than the bradyarrhythmias, but we do know that the bradyarrhythmias are more of a worse prognosis, and the earlier they present, the worse the prognosis is. And we had a series of patients now that I would like to alert the knowledge about, that when they come to us, they present with fetal bradycardia, and we diagnose retrograde a mom with having a systemic lupus. And so any mom that we do the anti-Ro, anti-La antibodies is of prime importance. And in our country, she might not be diagnosed even before getting pregnant, having very minimal symptoms of arthritis, and then presenting her first baby with a very early fetal bradycardia. And usually they don't have a good prognosis, because the earlier they are, the more we want to maintain a good heart rate to keep the pregnancy as long as we can, so we can deliver later on the baby. But if they present very early, they were not able to do this. So I would like to share this with our international colleagues. If you have it in your country, just moms presenting and they were not previously diagnosed by rheumatoid or systemic lupus disease.
One last comment for دكتورة إسراء. أنا بس عندي شوية تحفظ على عنوان التوبيك بتاعه. كلمة arrhythmia for anybody means abnormality which is significant. So I hate to make it benign. Any arrhythmia is important, should be taken seriously. The word benign might give the impression that it's something that to be taken lightly. So either to change the benign or to change the arrhythmia, make it benign, irregularity of the heart. But arrhythmia per se is something important and something we had to take it seriously. Yes, that's why any irregularity of the heart should be taken seriously, because you know you mentioned a lot of variety that is not serious but should be taken seriously.
Proper evaluation will lead for proper management.
Yeah, just highlight that benign does not mean forget it or leave it alone. Okay. For the sake of the juniors only. Dr. Rodaina, also you mentioned a lot of red flags, many red flags. If I ask you to choose 3 the most important red flags that you highlight for the junior also not to miss, what 3 you will choose? And I know this is difficult.
Actually, all of them are red flags because they can all, they all need further evaluation. And because if we miss, they can lead to a sudden cardiac death event. I mean, if we go after them and they prove not to be lethal, that's okay. But if we don't go after them, it can end in death. So they are all important. It's worth further evaluation.
Yes, the most important red flag, in my opinion, is to make them make an ECG in the first place.
Yeah,
very very important.
Yeah, sure.
Thank you all, and we will move for the next session, which will talk about the career and building up an AB team. Thank you so much.
Thank you, Corso. So I call for chairpersons of the second session, Professor Maria Gonzalez, Professor Taufik Garagos, Professor Michael Sobhi. Please come up.
أنهي؟
زي حضرتك.
Session is this.
So it would be my pleasure to present Dr. Peter Aziz, Professor of Pediatric Cardiology and Electrophysiology at Cleveland Clinic, Ohio, USA. He will be talking to us about Pediatric and Congenital Electrophysiology Society, the PACES, and the global opportunities.
Thank you, Rodina. It is a pleasure to be back in Egypt, joining the team here in Cairo and Abu Rish. And we've always been met with hospitality and love and kindness, Dr. Shadi and I. I'd like to thank the EP team here, Dr. Osama in particular, and Dr. Hussein and Dr. Rodina for all their hospitality while we've been here, and the entire team. It's been an absolute pleasure to work with you all. We've learned so much. Thank you for having us, and we hope to be back. Okay, we're going to talk about the PACES organization.
العظماء كلهم.
Okay. Great. So the organization, for those of you that don't know, PACES was started in the early 1980s. And really it was just a collaboration of like-minded pediatric electrophysiologists at the time. In the early 80s, in the United States at least, there were maybe a handful, probably less than 10 electrophysiologists in the country. In the early 90s, they became an organization, which is essentially meaning that they were incorporated, so it became official as a PACES organization. And today, we have just over 300 current members. This is a breakdown of who we are. More than half of the PACES membership consider themselves to be trained physicians. There are a fair amount of trainees. Draw your attention to the it doesn't project well, but the 14% or so are international, and of those 14%, just a tiny, tiny slither is from lower income countries, and we'll talk a little bit more about that. But this really is predominantly an American organization, and I think, of course, that needs to change. This is data by Mitch Cohen, one of our colleagues in PACES, taking a look. What we'll look through in these next slides is how the globe really is distributed in terms of who is a PACES member relative to the population of that region. This data is from 2022, so it's certainly not contemporary, but it is the newest data that we have, looking at the demographics of PACES as a whole. In 2022, in North America, there were 202 active pediatric electrophysiologists, and about 30 of those were practicing on their own in institutions by themselves. The population of North America at the time was about 590 million. So this is the amount of pediatric EPs per person. This is not per pediatric person, this is just per person. And we're going to go through this by region. There's one pediatric electrophysiologist for every 2.6 million people. If we move to Australia, there are 8 electrophysiologists in pediatrics in Australia. And in 2022, the population is 26 million people, which gives us one pediatric EP for every 3.3 million people. If we take a look at Europe, the pediatric electrophysiologists active were 91 in 2022 for a population of 746 million people. That is one pediatric EP for every 8.2 million people. South America, there are 20 that identified as pediatric electrophysiologists. The population there at the time was 430 million people. That is one pediatric EP for every 1 in 21.5 million people. In Asia, 39 pediatric electrophysiologists, a population of 4.75 billion people. That is one pediatric EP for every 122 million people. And then lastly, here in Africa, just to highlight the 2 dots in Egypt, Dr. Osama, you are one of those dots. I'm not entirely sure in 2022 who the other one was, and there is another one in South Africa. But the population of Africa at the time was 1.4 billion people, and that is one pediatric electrophysiologist for every 470 million people. So clearly the biggest discrepancy here we see is in Africa. Looking at this graphically, I'm a visual person and I like to see data in charts. If we take a look at the bottom right, those numbers highlighted in red show the 3 continents with essentially the lowest ratios of pediatric EPs per population. And then graphically, of course, we see the same on this bar graph. The orange is how many persons live in that continent per one pediatric electrophysiologist. And again, Africa, Asia, South America, you see the orange graphs there. So this is a clear mismatch. So PACES is the largest pediatric EP organization. There are, again, 300 PACES members. That includes medical physicians, nurses, and trainees. There are approximately 500 pediatric EPs globally. So clearly, as an organization, we're incomplete. We are not engulfing all of the membership that I think we need to, and I'm sure there are reasons why that we should explore. So let's start with what the benefits are of being PACES, why I'm a PACES member, for example. One very easy thing that we can do is if you're a PACES member, I can find you by simply typing your name, your first and last name, in a query search on the PACES website, and it provides me with your contact information and your email. This is incredibly important for us as an organization because we oftentimes, as I'm sure you all do, and I've seen in the last 2 days, that we all reach out to one another to rely on each other for the purposes of patient care, ask each other questions, get mentorship. Research participation is the reason why I joined PACES. I was the vice president of research for the last 3 years before becoming president, and what we've tried to establish here is in the website links to every PACES funded research program and research study that's out there. So the top is PACES research, below that PACES and IS-ACHD, that's adult congenital research, and below that is highlighting our new relationship with the Fetal Heart Society. So the Fetal Heart Society research team and PACES have also teamed up to combine a collaborative research network. Quality improvement initiatives, this is Ron Tennell and Doug Ma, both are chairs of our Quality Improvement Committee, and they lead PACES and really pediatric EPs globally in terms of their quality improvement initiatives at their relative institutions. Trainee education is also an important arm that probably is about 3 or 4 years old. So some of our young physicians have teamed together and come up with several projects that are available on the website, real-life training courses that talk about relatively simplistic things to the more complex. This has been an incredible resource for our young physicians in training. What it's meant to me personally is mentorship. So when I entered as a pediatric electrophysiologist at Cleveland Clinic, it was myself, and I had a senior partner that was not very involved in research, and I needed research mentorship at the time, and PACES really provided that for me. This is the reason why I became an electrophysiologist. This gentleman's name is McDonald Dick, one of the first pediatric electrophysiologists in the United States. He trained in Boston and ended up in Michigan, and we overlapped there. And of course, Molly Shaw is the person that trained me at Children's Hospital Philadelphia. I'm certainly indebted to both of them, and I think PACES was part of the glue that got us together. The core mission, though, I believe, is research collaboration. The iSprint is the name of the early PACES research organization. I was attending the first meetings. This was in 2010, and Shu Sanatani, who's in Canada, was the person that led these meetings. And there was a small group of us, and there was no coffee, no donuts, nothing. It was just us and our willingness to collaborate for research. And that morphed into, this is our research meeting in Boston last year that I led, and there were about 200 people in this room, all again looking to collaborate for research purposes. So this arm of PACES has grown tremendously, and I'm very proud of that. Where is PACES research now? We have teamed up with the SADS Foundation, which is an organization in the United States. It's international, though the largest flag is in the United States, and we collaborate with research, and they provide us research awards to support investigation. Heart Rhythm Society, of course, and PACES have teamed together for years. Last year, we have developed the Young Investigator Award with Heart Rhythm Society. There's a David Brooks Memorial Endowment. This is open to all PACES members. They can submit grant protocols, and it's a fund for 25,000 United States dollars a year to support research for 3 years, which is quite a large amount of money. The Patrick Joyce Scholarship Fund is something that I run. The proceeds go to PACES research, and it funds the Young Investigator Award. And there's an adult congenital arm. I highlight this is Jeremy Moore, who is committed to adult congenital research. He's the current vice president of PACES research. And I think the next endeavor here is to look at adult congenital. I think that is wide open, and I think he's going to help us do that. So what opportunities do we have, and how do we move forward from here? As we said, I think the organization and pediatric EPs, and I don't have to tell an audience like this that we need to think globally. And I think the problem we have in the United States is we have a large amount of pediatric electrophysiologists that probably see a relatively small patient population, and I think that is a problem. Whereas in Africa, there are a large population with a small number of pediatric electrophysiologists. We haven't struck that balance, I don't think, yet, and we need to figure that out. The disproportionality really causes inequities in access and care, and I think globally that is a problem. And I think I would admit that even in Egypt, there are lots of patients that need a lot of care, and there are a few of us, I think, that can help. The other arm of this that I think is easier to resolve is the education piece. This is effective. It can be broad-reaching. It can be inexpensive. I'll show you an example of this in a moment. But education, I think, is our obligation. This is what we're all trained to do, is to educate the next generation coming up. One way to do that, and I'm very grateful to Dr. Balaji, who's presented there up on the right. He's at Oregon Health Science University in Portland, and he has come up with the Children's Heartbeat organization. And what what he has really accomplished here is quite amazing. He has a fellow or a trainee present a difficult case every month on a Friday. And that difficult case is presented to a group of experts. And the group of experts, after each slide presentation, will discuss their insights on the case at that point in time. They'll show an ECG, provide some history, talk about the family history, talk about the next steps in clinical progression. The clinicians and the audience members don't know where the conversation's going. We get to hear how experts in the room think about cases like this. This is a case on the top left of a patient with an NKX25 gene variant that presented with varying degrees of heart block, and then below that, atrial tachyarrhythmias. And the bottom right is a picture of Balaji, Pete Fishbach, who's presenting the case. And then below it in that panel are all of the 100 or so participants across the world that, that provide inferences and their unique insight. I think this is a nice way for all of us to get together, and it costs very little to do this. I think we can start doing this tomorrow. So what are the key takeaways here? I provided some examples of what the problems are and perhaps how to resolve those problems, and I lean on all of you to help me with the next steps. But what are the opportunities for global integration, research, education, and beyond? What is EPAC's role, Dr. Osama, and how can we think about this in terms of collaborating with PACES as EPAC grows and grows here, even in the last year? And what's next? And I'd love to hear the panel discussion and thoughts on that. I appreciate everybody's time. Thank you so much.
Thank you very much, Peter. It was a very nice overview of the work you are doing, and we see how many work is still awaiting to resolve and problems. So I hope that in the audience now there will come some appointments, memberships, and thanks a lot to be here and to help. I have heard you come always here to make some cases, and I think this is the main topic that we all have the intent to educate or to show others and to change our ideas, and changing ideas and asking questions and leads to new ideas and progression. And this is the main thing, and this is what I think it's the beautiful when we meet all together and talk together. Thanks a lot. So I want to introduce now as next speaker Dr. Mohamed Ibrahim. He's Associate Professor of the Department of Pediatrics and Pediatric Cardiology and Electrophysiology in Kuwait. And he will now talk about establishing a pediatric EP program. Thanks.
Thank you. Okay, so thank you for the invite. It was a pleasure to be coming and to Abu Rish Hospital. Thank you, Pediatric EP physicians that invited me. I was really impressed with the cases that we did over the past 2 days. And it was lovely meeting Pete and Shadi and Professor Tawfiq and everyone else here. I am an associate professor at Kuwait University. I was tasked to present how did we establish a pediatric EP program in our country. I do have a couple of educational platforms that is free, open for the public. The Instagram platform is in Arabic, but otherwise YouTube channel and X or Twitter is in English. Like I said, we will talk about how we established the pediatric EP program in Kuwait. So it started in late 2018. And I will walk you through how we hopefully established what we believe a successful EP program. So first of all, we'll talk about my background, and then what are we doing now. So first of all, I did my residency at Miami Children's, and then I did my cardiology fellowship at UCSD, and then I did another year of EP fellowship at UCSD, and another year of EP fellowship at University of Alberta. And then I joined the Faculty of Medicine in Kuwait University in late 2018, and I was seconded to the only cardiac center in the country that deals with pediatric cases, and which offers all pediatric cardiology services except for EP. There was lack of EP physicians and services in the country. So this was before 2018. So what people used to do was that there was limited EP services, like we said, and the hospital was inviting experts in the field every now and then to perform EP procedures, pediatric and adult congenital EP procedures, and our adult EP team tried to ablate significant burden of arrhythmia cases in people who are above 8 years of age with probably some access help from the interventional cardiologist. So non-invasively, adult EP attended urgent matters or device checks. The main adult EP in the country were Dr. Ali and Dr. Fawzia. We thank them for their services. And then difficult to treat patients were either medically managed or eventually boarded. So I observed that in terms of tachyarrhythmias, most were managed with medications, high usage of amio, for example. There was prolonged hospital stay, prolonged duration of therapies. For bradyarrhythmias, there was lack of joint clinic between the pacemaker checks and echo data. So there was disconnect between the EP or the device check and the clinical data. And then most critically, inherited arrhythmia conditions were very unrecognized. There was almost zero genetic testing. There was no family screening. There was MRI and specific ECG, stress test, modified ECG protocols, and provocation testing were almost never done. So immediately we wanted to establish a pediatric EP clinic, of course, with regular cardiology echo clinic. We established pediatric exercise stress lab. We established inpatient EP services, and we started genetic testing both locally through our genetic center and through private labs. And most importantly, we wanted to educate our pediatric cardiology team in the country by establishing protocols for SVTs, for JET. We started to do regular virtual EP conferences. And all our conferences are uploaded in our YouTube channel so that it's easily accessible to learners. And we tried to build a team. We don't have it. We have one junior pediatric cardiologist who's interested in EP that is helping, and we have 2 EP technicians so far. Anyway, so this is our SVT protocol, and this is our JET protocol that we took from UCSD. And we wanted to document, first of all, we wanted to document the knowledge among our pediatricians and cardiologists. For example, we did a survey, and we surveyed around 125 pediatricians with 10 common ECG findings, and the brown color is the correct scoring. And as you can see, there is not great response. The scoring of the pediatrician were not the best, and even the cardiologists did not recognize many common ECG findings. These are textbook ECG, findings. So anyways, we did document the local suboptimal knowledge among our pediatricians and pediatric cardiologists, and we tried to improve that. So then what we do now in 2025, we usually do most of our devices, if less than 20 kg epicardially, through help of our pediatric cardiac surgeons. And then, but we are very involved. We do intraoperative lead checks, of course. We guide them where to place the leads. We guide them what devices to choose, whether single or dual chamber, and so forth. And we're trying to get to narrow paced QRS by pacing the, the apex of the systemic ventricle as much as we can. In terms of EP implantation, we do obviously loop implants, we do pacemakers, and most recently left bundle pacing is our standard of care. And this is an example of a left bundle pacing in a 12 years old congenital complete heart block patient. And this is the resultant QRS, narrow QRS that is a result of the left bundle pacing. We obviously do transvenous subcutaneous ICDs. Again, examples of subcutaneous ICD in a dextrocardic patient and transvenous ICD. And we tried, because we're in Kuwait University, we tried to publish some of our interesting cases. And in terms of invasive EP, we do regular SVT stuff, AVNRTs, and all the way to complex procedures like double switch flutters and Fontan intra-atrial tachycardia. Sometimes we do very young individuals. This is a atrial flutter ablation for a 9 kg, 1.5 years old patient with significant sinus bradycardia. This is why we had to ablate the patient. And this is a complex Fontan patient, TET patient with intra-atrial tachycardia. We mainly use Insight, but we have all Carto Insight and Arrhythmia. And to jumpstart the program, we initially did multiple workshops, and we invited people from the region. This is Volkan from Turkey, Ismail from Oman, Phil Saul from the US, and Jazz Veer from UK, and Javier Moreno from Spain. By having such experts, we definitely jump-started the program. And then we also, created database for our pediatric electrophysiology patients or invasive procedures, and these are our results to date. So we have 94% acute success rate for like regular, pediatric arrhythmias, and then obviously less good for congenital heart patients. But we're proud to, our numbers are resembling, the largest centers in the U.S., like for example, Boston Children's, and then we're doing zero fluoro radiation in pediatrics, and this was the first time done in Kuwait. And then slowly the adult team are also now doing more and more zero fluoro procedures. And then of course it's a team effort, like it's a group of cardiologists, ICU, cath people, echo people, and EP people that resulted in such good results. Again, we tried to document, some of our, some interesting cases. And for our inherited arrhythmia conditions as well, we started a database. We have many long KT families, and I imagine you guys will have many long KT families in Egypt with multiple family members and very often very sick family members. We have other non-long KT syndrome patients, families as well. And then we have arrhythmogenic cardiomyopathies and hypertrophic cardiomyopathy and so forth, of course. And because of our unique genetic background, we do have many interesting cases that we were able to publish, so that we share our unique genetics to the world. And then I'm involved in many registries as well through PACES, like what Dr. Peter mentioned, and many of them are very rare genetic mutations that are not rarely found in the U.S. So now we have, we run once a week EP clinic and once a month stress test clinic. We mainly do our cardiac genetics locally. Once in a while we do send out labs through Centogene or Inviti. We do have collaborations with Dr. Andrew Landstrom and Dr. Cecilia Gonzalez with complex genetic cases, especially Brugada for Cecilia, but with everything for Andrew Landstrom. And then in return, we do give the EP lectures to their fellows just to return their favor. We have MRI collaboration with Pablo Garcia, and just to measure the burden of the scar and so forth. And we do EP invasive procedure once a week, once per week. Like we have the lab once a week, and then we sometimes do provocative testing, and then we do routine conferences as speaker and attendee. And then I'm also, like Dr. Peter was mentioning, I joined the heartbeat sessions, children's heartbeat session often, and I was speaker in a couple of sessions, and I encourage, because you guys have so many interesting cases. I know Dr. Balaji would love to, for you guys to present at this conference, a virtual conference, so I would recommend that. But I'm also part of, many WhatsApp groups and Twitter and, SATS Foundation and Hero Foundation in Canada. Obviously, there are limitations. We don't have specific drugs, like, for example, procainamide, maxilitine. We rarely use ECMO for severe tachycardia-induced cardiomyopathies. We don't have home monitoring. Epicardial ICED implant is challenging. Extraction is a little bit challenging. Sympathectomy, we don't routinely perform. And then, CPR training and AED purchase, it's difficult to convince the families to pursue that. There are some challenges, of course. You should be available 24/7. We did not have mentors when we first started. We don't have a proper electronic medical records like in the US or Canada or other places, but it's improving slowly. And then for the diseased individuals, there are no usually DNA samples that are saved. We have very large families often, and with genetic testing being refused. And this is an example of a pedigree that we have with, like so many affected, members. But it's a large family. It's very difficult to track and, and assess each and every individual at risk. We are improving our services. We have plans for leadless devices, extravascular ICDs, PFA for our adult congenital community, and epicardial ablation. It's not yet routinely done in pediatrics, but we do have selected cases, and we are planning to perform such procedures in the near future. This is an example of an epicardial, accessory pathway from the right lateral, right atrium, right lateral side. So, if I think we establish an EP program, it's in order to establish an EP program, you should first of all have develop good relationship with your adult colleagues, like in my case, EP adult colleagues. Especially if there's no pediatric EP, you need their help very often. You want to have a good relationship with your department heads, ministry officials, and you want to reach out to experts in the field, like for example Pete, and you want to try to form a community like with nearby countries. For example, in my case, we have a Gulf EP WhatsApp group, and I recently joined there's African HRS WhatsApp group as well. You want to be available for international consults. I receive consults from Egypt, from many countries, and try your best to help people, and you learn by trying to or discussing international cases. Through emails and Twitter and so forth. And you want to try to share your knowledge, and obviously try to do research, publish your work that you're doing locally, and participate at conferences and speaker. And use the industry to support workshops, support like catheters, patches, and so forth, and they will be very helpful. So these are like just a couple of pictures from my fellowship and residency. So in conclusion, we are happy to have a pediatric EP program in our country. We believe all services are available, and I would like the Egyptian EP community for the invite, and thank you very much.
Thank you, Dr. Mohammed, for your lecture and for your experience in Kuwait in your center. And actually, we are looking forward for more collaboration with Dr. Peter, Dr. Maria, and all international team next year, more and more. And of course, with your center, And I think, as Dr. Peter said last year, we have many proceeded difference from last year and this year from EBAC. And I wish for next year we will have more and more international speaker and international collaboration. Many thanks for all the chairperson and all the attendee. And I will thank now to proceed to the next session.
I have just one question. Yes, thanks a lot, our dear presenter, for this elegant presentation. I have one question to Dr. Peter. I don't know if he can see me. Yes, is there any currently available or in process international certification related to the PACES, like international board examination or something like this? Is there something like this in process?
A board examination, was that the question?
Yes, to be available for international fellows.
Yeah, there's no board certification in the States for pediatric EP. There is a certification through PACES and Heart Rhythm Society where you take an examination essentially that covers adult and pediatric EP topics. I took that maybe 4 or 5 years ago, and I found the pediatric portion very easy and the adult portion very difficult. But I think it's worth thinking about just to standardize the training that we have. I think that's a really important piece of it.
Okay, and there is structured educational courses available through the PACES?
It's a written exam. Yeah. I'm sorry, what was the question?
I'm asking if there is structured educational courses preparatory for this exam available through the PACES?
No, the only thing is the outline from what I recall. That may be different now. I can follow up on that and let you know.
Okay, thank you.
Yeah, thank you.
Thank you for everyone. And any question again? That's okay. So we can, okay?
Dr. Wael, I think, yes.
Yes, Dr. Wael.
Can we please bring the mic?
I believe, I'm commenting on Dr. Peter's talk, is the question of sustainability in our country. I believe, and I need your feedback, that we need to have something that is income generating for this particular subspecialty. In our country, in our practice, even our fellows, our professors, we cannot even provide for them. So many of them had to be part-timers because they have another something to generate their income. So I would believe, seeing the figures you presented, that we have to move into a central station for all Africa. Some of the activities should be for free, some would be paid to support growing the team, growing the activity. I feel this is the only solution for this branch to develop in Egypt. I'm not sure if you agree with me, but I believe it's the only way to support our younger generation. Hussein, for example, is sitting against me. We need him to stay in Egypt first and to continue. We have to give something for these fellows, for the branch to continue. Thank you.
I obviously agree. I would love to hear from your colleagues here in Egypt and see what their thoughts are.
Thank you, Dr. Peter. I think there will be a lot of issues regarding this subspecialty, especially in Africa, and whether we need more and more in the charity work and in the support to sustain such a great start for our team. I think it's time to close this session and call for the other sessions. Thank you.
now it's my pleasure to introduce my dear professor, Professor Dr. Sahar Shaker, Professor of Pediatric Cardiology, Cairo University, and the head of the Pediatric Cardiology unit at Cairo University Children's Hospital. She's going to brief us about the Pediatric Arrhythmia service at Cairo University Children's Hospital.
بسم الله الرحمن الرحيم. Just to keep time on track. أشكر السادة الحضور على حضور المؤتمر في يوم it's supposed to be a national holiday. فأشكركم جدا حضراتكم على الاجتماع معانا لليوم العلمي ده. I'm presenting this talk as the head of the Pediatric Cardiology Department at Cairo University, and we refer to it as Abu Rish Hospital. And we are a leading team in the Middle East, in the Gulf, and in Africa. So it's really brings me a lot of joy وسعادة إن يكون تيم من عندنا بالمستوى الانترناشونال ده. A very dear team to me, the electrophysiology, for their hard work, dedication, and a long trip, which I will show now, around 25 years of having a vision and reaching their dreams. I would like to thank Dr. Hussein for providing me with the slides, just because we have international colleagues here, which is very, very thrilling to us all, from the Gulf, Dr. Mohammed, from Africa, Tunisia, Algeria, Morocco, Europe, Germany, Turkey. So we are very happy to welcome you here in Egypt. And we are coming from a university or a medical school of medicine that's around 200 years old. It's 198 years old, and our pediatric department now, the general hospital is in the campus is around 4 premises. So we are quite a big unit, and the pediatric cardiology members are reaching 45 now, even more. So it started when? It started with very early in the 2000s, when Professor Wa'il Lotfi was the first one. We were colleagues at that time. He was still young, and he had a dream and a vision. He wanted to go into the electrophysiology. And then he was given a clinic, a very primitive clinic with an ECG machine. And he used to go and open his clinic, attend it every Wednesday. Correct me, Wa'il, if I'm right or wrong. And he used to have maximum 5 patients. There wasn't even an awareness of pediatric arrhythmia. Sometimes he would come and say, it's only one patient that came to me. 2001, he was able to get a Holter monitor and started the Holter monitor service. And this is a timeline for us. When he started the initiation of the arrhythmia clinic, actually it was even in the preventive medicine building. And then he got the first Holter and ECG and started challenging himself, and we had a lot of support from the adult department, Dr. Tamer Fahmi, and they did the pacemaker insertion. 2006, they started the electrophysiology program and started ablating. Turning point was the renovation that happened at 2019 when they were upgraded to a CARTO, three-dimensional mapping system, and the conventional ablation. They started doing more and more. They became more renowned among the country, national-wise, and they started their first CSP and pacing case, which was around 2022. 2024, we had Dr. Peter Aziz, and I would refer to him. He came to us 2023, as we were just talking, did a couple of cases with us, and we were very impressed, and he was a very good educator for our team. So 2024, we said, let's benefit the doctors more, and when Peter comes, we let him give 2 to 3 lectures, together with the workshop and the ablations. And then it turned out to be a conference last year, and this was their first international, or the Egyptian Arrhythmia Conference. Very thrilled and very happy to have their second arrhythmia conference with this international gathering, with them being renowned among all these international organizations, among Africa and among the Gulf area. And from here, Peter, if I have a dream that our department be the leader in Africa, and our team to go missions and educate more and more people in Africa. We have a very high capacity of doctors, knowledgeable, expertise, financial part, as Wael just mentioned, is a hindering point in this country. So what they reached now, from a 1 day per week on Wednesday by Professor Wael, seeing 5 to 10 patients by 2022, and now we are having a 3-day clinic for the arrhythmia. We have serving our kids around 60 patients per week. For device Holter, around 13 patients that are read per week, and device programming around 25 patients per week. The first implantation of the pacemaker was in 2001. And then they started introducing the conduction system pacing in 2022. Our statistics is 40 to 60 pacemakers per year, CSP 15 cases, and ICDs around 9 cases. Going into the invasive EP study, which I would take the opportunity and thank the sponsoring companies that had this conference to come alive, and the organizing committee for choosing such a brilliant idea of having us here in the museum. But they started doing it in 2019, and now average of around 50 to 60 patients. I think one of the secrets of their success is the partnership and the collaborations with different people. It started by the help from the adult cardiologist from the intensive care, Dr. Tamer Fahmi, and then we had 2 very special people with us, Dr. Ahmed Mustafa, coming routine every Thursday to help or collaborate now with our team. Cleveland Clinic, of course, Peter, we would never say enough thank you for updating, and Dr. Shady, of course, Nakhla, And Dr. Shady, he's Egyptian background, so he knows all the tips and tricks for the low-income countries. So he can manipulate things because we're not rich countries and can use it only once. So he always gives us the tips and tricks, very highly expertise. PACES, of course, would be lovely if the whole team can join, and the adult cardiovascular system department. Now it's been 3 years. Dr. Peter, Dr. Shady are with us doing the yearly workshop, and they are looking forward to come to us, helping us all the way through. And this year, Dr. Tawfiq with us, thank you so much. The last 2 days, they did 9 cases, stayed up till 11 p.m., waking up at 6 a.m., serving our kids, 9 Peter and Shady and Dr. Tawfiq, 2 cases that were very difficult. Yesterday, we were just saying, before they used to prepare them a list of moderate cases, 2 extra difficult cases, and like a balance. Now, Usama's giving them a hard time, giving them 11 impossible cases, and they were able to do it. And thank you very much for helping these kids, because they were very much in need and very poor to go to any other service in the country. Other people that I would like to thank for collaborating with us, Dr. Amir Abdul Wahab, Dr. Moreno, and Dr. David Chan for helping that team. Now, our wonderful expertise team, the electrophysiology people, we have 2 elegant ladies among them, Professor Rania Hgazi, Professor Rudaina Subhi, and I can't thank enough Dr. Ahmed Mustafa, Dr. Ahmed Tahir, Dr. Tamer Fahmi for initiating وحقيقي وقفوا الوحدة دي على رجلها مع طبعا our team that's now moving forward. They have a dream and they have future plans. They want, and I think we need to build a national registry, research, collaborations, and I was just talking to Dr. Usama, make it a reference place in Egypt, so you can have, Rudaina was just telling me, they get a lot of consultations from different places nationwide, so they can do this on a system. Expand, of course, the fellowship, training, and the programs, and maybe get them another 3D EP lab, and expand the application of the CSP. I think one of the things of the parameters of how much the arrhythmia group is doing well, I had a resident, she was in year 2 pediatrics, and I remember at 2 a.m., she treated an SVT all by herself, giving adenosine, proper dose, and the patient was cardioverted, a general pediatric fellow, a general pediatric resident, which I think is a good measurement for how much this team is educating everyone around them. And thank you, because we are in the museum, so it's in Pharaonic. Thank you so much for giving me the time.
We'll be opening the official opening of the conference and inviting Professor Omar Azam, the Vice Dean.
Morning. It's a great honor for me to be here today, and a pleasure to be here today also, because I was very close to becoming a pediatrician myself, but then I switched to dermatology, which is a very strange switch. However, coming here today makes me maybe a bit regretful, because I see a lot of very eager and passionate faces, and I see people who are achieving a lot actually on the ground. Before I begin, I would like to thank the distinguished panel for being here. Professor Addah, head of the pediatrics department, Professor Shahar Shakir, Professor Wa'il Lutfi, for being here, and I'm very sorry if I'm missing. And Professor Tamer for also being here with us today, the organizers and the presidents of the conference, esteemed guests from outside of Egypt, esteemed colleagues, and dear sons and daughters, as I'm approaching 60 years now, so there's a big age gap between you and I. I'm here today on behalf of the Dean, Professor Hussam Salah Murad, and I'm also here actually on behalf of myself, because when the Dean asked me to give the opening speech, I was very excited for many reasons. The first one is that the pediatrics department has always been a very generous department to Qasr Al-Aini. Qasr Al-Aini is approaching its bicentennial, its 200th birthday in 2027. And the pediatrics department has always been one of the leading, can I say, if not the leading, but one of the leading departments in the fields of research, medical services, and medical education. And this is something we take pride in, to participate as an administration in any event which helps to highlight and emphasize the importance of this department. Pediatric dermatology, pediatric cardiology, see, as you can see, I'm minded with my own specialty, because we have in dermatology, pediatric dermatology, as you have here pediatric cardiology. The science of pediatric cardiology has expanded immensely. And actually, to me personally, I am Vice Dean for Community Services. And I see pediatric cardiology as maybe the most, or one of the most important specialties for a very important reason. I'm not going to be able to address any technical issues, but I mean, if I can prevent or intervene early to treat a child with a heart problem, I will be not only giving new life, I will be saving a lot of money for the country, for the insurance system. I will be helping his achievements in the future, his donations to society, because if we begin to treat early, I think the cost, and you might correct me if I'm wrong, the cost of treatment will be much less than waiting for that child to reach puberty or go beyond into adulthood and not be able to be treated properly or not at all, and if so, then with a much, much higher cost. So for this reason, in particular, I think that pediatric cardiology is of paramount importance in helping the country as a whole to sustain a better health system. As regards Professor Shaker, when she was saying she has a dream of going to Africa, Egypt has now turned its face towards Africa, and we have a lot of projects in collaboration with African institutes. So if you don't mind, I would, if Professor Lutfi or you or yourself, if you want to really have this dream come true, I would appreciate if you pick up contact with us, and we can help you in trying to facilitate this dream, make it much easier to be happening. It is possible now. It is much more possible now. I think you have the calibers. I think you have the know-how. I think you have the expertise to be better than anyone else who's ever been into these countries to help them out. So we would be very happy. Professor Hussam Salah, our dean, is always advocating any collaborations with abroad, with other countries. It doesn't matter if we are going to gain experience. It doesn't matter if we're going to give experience. The main thing is to always have the bridge between the different specialities, the different countries, different institutes, because I think that's what propagates us. Lastly, I would like to thank you for an enormous effort in the aspects of research. I think I've had a chance to recap and talk to Professor Addah, and I've heard that this unit has had really a great deal of international publications, which signifies the value of Qasr Al-Aini, signifies the value of the pediatrics department, signifies the value of Cairo University, and hence signifies the value of this country. Once again, I thank you very much. I hope you have a very fruitful scientific day, and I hope to be here again next year with you to see what we have achieved from what your plans are, and maybe, hopefully, we can even have achieved some of the things outside of the country, such as the missions to Africa. We will try to begin that as soon as possible and hope that we can make your dream come true. Once again, on behalf of our Dean, Hussam Salah Murad, I thank you very much for having us today, for the invitation. On behalf of myself, I wish you a very, very fruitful day, and I thank you very much for your hospitality. Thank you.
May I invite Professor Ahmed Addah, the head of the pediatric department, for his word.
Bismillah ar-Rahman ar-Rahim. I'd like to thank you for participation in such a great conference. I have a dream was a quotation first said by Martin Luther. You know, Martin Luther King, 1962, in United States. And actually, when we start this dream in pediatrics, it was a global dream, not only for pediatric cardiology, pediatric nephrology, actually dividing the body into systems. We found this as a sign we cannot separate system, subspecialty, and forget about the whole picture, the whole body. When we start this dream, we need to elevate the quality of education and the quality of health service. The quality of education, we started for electrophysiology, especially. We invited Professor Dr. Wael Lotfi and Dr. Rania for making ECG for the first time as a part of data interpretation test for the postgraduate. And we made a series of lectures for this purpose. We focus in certain important things in electrophysiology. Dr. Wael Lotfi started the first ablation for WPW. We thought WPW is a treatable disease. Any general pediatrician that cannot diagnose WPW is not suitable to take the certificate for general pediatrician, MD, or master even. This was something new. The dream of Martin Luther started here. And also, we are a hospital. We are not a unit. We are not isolated land. Dr. Wael actually shared with me the idea there are certain pitfalls that must be put in lecture for the whole Egyptian seeker for knowledge. Ordinary YouTube and Cairo University tube also as well. He started with a certain problem that people with minimal thinking would think, for example, cardiomyopathy. Cardiomyopathy was a major problem because the idea of fluid-sensitive cardiac muscle actually caused dehydration of many children and renal damage for many children. And he focused on this, and we made it as a pitfall that must be learned for everyone. And this is the idea. We are not talking about isolated organ. We are talking about whole body. Also, multidisciplinary. He made very important lecture, I remember it very well, about persistent pulmonary hypertension neonatal. He made a note that it is overdiagnosed too much, and too much sildenafil is given for this pulmonary hypertension without any need. Cases with meconium aspiration, for example, does not need any sildenafil because pulmonary hypertension will decrease by itself if we treat the cause, proper ventilator management. Actually, I like Dr. Wael's way of thinking. It was very coordinated with my thinking. It was 100% evidence-based. This is very important. 100% honest. ما يلفظ من قول إلا لديه رقيب عتيد. It means that lying is a shame. And honest doctor like Wael Lotfi is a very good example for each one of us to follow. This is very important. So honesty, evidence-based, and following the most recent guidelines. Following the most recent guidelines, updating himself every now and then. Actually, I forgot to welcome the great Dr. Omar Azzam from Qasr Al-Aini Administration, Vice Dean. He needs a special lecture for himself, Dr. Omar Azzam. The way he seeks for knowledge, the way he is following every detail about recent guidelines is an honor for all of us. General pediatrics needs cooperation of all subspecialties. We don't have any criteria of isolation, and the criteria of isolation of any subspecialty is not fulfilled in our section. So we must know one hospital equal one guideline equal one administration. Thank you, all of you.
May I invite Professor Tamer Fahmy, the colleague and the helper and the sharer in the success.
Thank you very much, Professor Wael Lotfi, for such a nice introduction. And I thank you all for inviting us for this lovely conference. I'm hereby just to state behind the scene at the beginning of the inauguration of such great EP department in Abu Rish University. Back in the early 90s, we used to do in our EP division in the critical care department, we had lots of pediatric cases. We started like back in the early 90s doing EP study and ablation for like cases 2 years old and maybe 4 years old. These were the youngest peds that we have done. At that time, we did not have that much of a knowledge of the guidelines, as Professor Addah just mentioned, guidelines for ablating those patients. And here was the role of Professor Wael, who came and helped us at the beginning in, actually he was trained in our department early and continued, of course, his training with back in France. But at that time, he did help us a lot in dealing with those very large population of kids that we still actually do nowadays in our EP division, the critical care. Professor Mukhtar, Sharif Mukhtar, at that time was a guide for us to start the inauguration or the help for Professor Wael and Dr. Fadia Mahmoud to start the EP division or EP department in, or the cardiology department in Abu Rish. And there we started, maybe with very few equipment. I remember we had the GE machine at that time. It was all manual. Back in the 90s till maybe early 2000. I don't want to take much of your time saying the history. I'm just saying the hidden side of the share of the EP division of the critical care. And then we had the dream, but we didn't see it coming through, to tell you the truth, until I went to Cleveland Clinic and maybe Dr. Michael followed me in helping the department, and then came Ahmed Tahir and Dr. Ahmed Mustafa with the whole team. And now with the follow-up with Dr. Peter and Dr. Shadi and the great help, I see the dream is coming true, doing very complex cases. That I remember those cases we had a couple of cases that we didn't know what to do with them back in the early 2000s. And we had to transfer those patients to our department, critical care, to do a 3D mapping at that time, maybe in 2005, 2006, until Professor Wael told me one day, we will be having a 3D mapping, maybe in 2006, 2007. I couldn't believe the dream may come true, and here we are. Thank you very much, my colleagues, and especially Professor Peter and Shadi, who I really believe they did a great job in the learning curve of such department. Thank you very much. I don't want to take much of your time, and have a great day.
And now the last talk from the head of the electrophysiology team, Professor Wael Lutfi.
Bismillah ar-Rahman ar-Rahim. I want to thank you all. Thanks God first for letting us complete or work through our dream. The Faculty of Medicine, Qasr Al-Aini, as represented by Professor Omar Azam, the head of the department, the head of our unit, the audience. I cannot start before thanking my professor, Professor Fadia Mahmoud, who was the one to guide me through this branch. She had the idea of that we need pediatric arrhythmia. We are having problems, particularly at the time, 1980s, it was the postoperative heart block, where we did not have anything to do for them. Sometimes the epicardial pacemaker, sometimes nothing. We send them home, and if they die, it's just a mishappening. Professor Fadia Mahmoud took me from my hand, as they say, to Professor Sharif Mukhtar, the professor of the professors. And I was trained at the unit of critical care, Cairo University. It was a difficult thing. The branch was difficult, and there was no, let's say, given time for this training. I had to do this training all over the pediatric residency. And then Professor Fadia Mahmoud helped me with the starting the first clinic, pediatric arrhythmia clinic, because I had the patients coming all over after me whenever I go, wherever I go. And then came the good phase of the 9/11, where Professor Rania Higazi joined the team. She was due to travel to the United States, but because of the 9/11, she joined our arrhythmia team, and this was a great help. And then the breakthrough, Professor Osama came. It was a breakthrough because he was so much dedicated, and before he came, I used to take the on-call for the arrhythmias 24/7, 7 days a week for the whole hospital, the NICU, the Asr al-Aini, everything, until Osama came. And then we started by dividing the workload, and then I was relieved. One of the major problems we had all through is that we did not have any financial support for the branch, the machines, the personnel. We started by donations, charity programs. We are lucky at Abu Rish to have these charity programs. All our starting cases were done like this. It was extremely difficult. It was extremely difficult to get the equipment because nobody was using it in Egypt. Even the small pacemakers, the small leads, the things like this. But bit by bit, the things went on. This is why I want to stress on the financial thing to promote the branch and promote the activity of our unit. We need, with the faculty of medicine, with our department, to work it somehow to expand our services in Africa, in Arab countries, and in the whole world, as Professor Omar was saying and Professor Tamer was saying, because we can provide, let's say, world-class service with less than 1/10 of its value outside Egypt. Even in Arab countries, not to compare with the USA, not to compare with Europe. Professor Ahmed Addah always remembers that he had a case in Saudi Arabia that to do a WPW ablation, a simple thing, straightforward thing, a manifest WPW, not in a dangerous location. The patient, who was originally an Egyptian, it was cheaper at that time, 20 years ago, to come to Egypt with the travel, with the air ticket, with the hotel accommodation, with the operation done, and coming back. This was much cheaper than doing it in Saudi Arabia, not to say in Europe or in the USA. So compare it now with the actual dollar to Egyptian pound ratio. We can provide world-class services for less than 1/10 of its value in the surrounding countries. So we started by charity from, let's say, Professor Sharif Mukhtar, Professor Tamer Fahmy, who was coming to our department, our unit, our cath, working for free in his free time to promote our services. Now, Professor Ahmed Mustafa, Professor Ahmed Taher are doing the same. This made us progress a lot. With Professor Peter, Professor Shadi, and all our collaborators, We are much advanced, we are world class, but we need to sustain this for getting newer equipment, maintaining our personnel, including our professor to continue in this branch, and to get younger fellows for the service to extend. Thank you all. Professor Tamer, please.
Just taking a moment, a big applause, هنسقف سقفة كبيرة قوي to behind the scenes of organizing all the sessions, doing the conference work, Professor Usama Abdelaziz, our elegant electrophysiologist, Professor Rudaina, Dr. Hussein, our dynamo, I cannot see, and welcoming back Professor Rania Hgazi.
Okay.
Professor Hussam Salah Award. Professor Omar Azam will take it.
اوكي. ايوه خليك جاهز بقى. اوكي دلوقتي الموسيقى بتخلص. اوكي. بروفيسور دكتور عمر عزام، وكيل الكلية لشؤون البيئة، Faculty of Medicine, Cairo University. Now, Professor Dr. Ahmed Adeh, the head of the Pediatric Department, Cairo University. Professor Dr. Tariq El-Gohari, head of the Critical Care Department, Cairo University, and هيتسلم عنه Professor Dr. Tamer Fahmy, head of the EP unit, Critical Care Department, Cairo University. And finally, Professor Dr. Fadzia Mahmoud, professor of pediatrics, pediatric cardiology, and former head of the pediatric department, and the inspiration behind initiating the pediatric arrhythmia service. يتسلم عنا Professor Dr. وائل لطفي, Professor of Pediatric Cardiology and Electrophysiology, Cairo University, and head of the Pediatric Arrhythmia Service, Cairo University. Now calling for the session number 3, Ask the Experts. Chairpersons, kindly come forward. Dr. Shady, Dr. Tamer Fahmi.
الفاكولتي يقعدوا فوق بقى. الدكاترة كلهم هم.
لا ما خايف معانا. طب الدكاترة.
So we'll start our third session. Dr. Peter Aziz will talk about should I implant an ICD for every child with long QT syndrome and family history of sudden cardiac death. Please, Dr. Peter.
Thank you, Dr. Osama, for the introduction. Thanks again for the invitation to be here with everybody. So we're going to talk about whether we should implant defibrillators in patients with long QT syndrome. So we'll start with a case presentation. This is an 11-year-old female that had syncope. She was previously healthy, was running in gym class and had sudden onset syncope without a prodrome, described as jerking movements according to her gym teacher. She fortunately awoke spontaneously. This is her electrocardiogram, shows a QTC of 480 milliseconds. Her family history is notable for her father, who had seizures and syncope as a child, was treated initially with anti-epileptic medications, not knowing, of course, that he had long QT syndrome. And his ECG is presented here. He also had a QTC of 480. And the patient had a brother, a younger brother who's 9 years old, was asymptomatic, and his ECG showed a QTC of 475. So we referred this patient for genetic testing, and we found a pathogenic variant in KCNQ1. Looking at the topology of the gene, the yellow mark is where this gene defect was. So if you look at the leucine, the 342 denotes where in the protein the gene defect is, which is where that yellow dot is. That is in the poor region of the gene. Often gene variants there are pathogenic and cause disease, which is not surprising in this clinical case. And of course, this same gene was found in the brother and the father. So what is our next step in management? We'll take a vote. Do we discharge and return to play, discharge and exercise restrict until outpatient follow-up with an electrophysiologist, start a beta blocker, admit for an ICD, or do stress testing to assess for arrhythmia propensity? So who would discharge this patient and have them return to play? Raise your hand. Nobody, okay. Who would discharge the patient and exercise restrict until they're followed up with an electrophysiologist? Raise your hand. Okay, a couple of people. Who would start a beta blocker? All right, some more people. Who would admit for placement of a defibrillator? Okay, and who would do a stress test? All right, there's a fair amount of variability in the answer. So let's see what a treatment pathway should be. So this is the treatment pathway that, in my opinion, is universal for every patient that has long QT syndrome. You start with a beta blocker. The beta blockers that we typically use are the non-selective beta blockers, propranolol and nadolol. This data from JACC in 2013 shows that patients that are on selective beta blockers like metoprolol have a much higher incidence of breakthrough. I know nadolol is not available here in Egypt, so propranolol is a perfect drug to use for long QT syndrome. As a matter of fact, in some ways better than nadolol. Medication avoidance is very important. We counsel our families very specifically to refer to this website and cross-reference any medicine that they're going to be prescribed for any reason, as it may prolong the QT interval even further. So that is the standard of care for every long QT patient. What about the treatment pathway for the patients that are higher risk? So if you look at long QT syndrome, of course, the long QT syndrome is not a single entity, but really divided into the genotype. And the genotype largely drives, the phenotype largely drives the triggers, treatment efficacy. So taking a look at that further, higher risk patient characteristics involve age. So males that are long QT1, for example, males after adolescence and long QT3 can be a troublesome cohort. And the response to beta blockade also varies based on genotype. In long QT1, which is a very sensitive gene entity to exercise and sympathetic tone, fortunately, they're also very sensitive to beta blockade. And beta blockade is very effective in long QT1, perhaps a little less so in long QT3. This is the risk pyramid published by Mike Ackerman, showing the top of the pyramid being patients that are extremely high risk of cardiac events, and then so forth to the bottom, which is the lowest risk patients. So we look at the top of the pyramid, the entities that are at the top, if you can't see, are TS, Timothy syndrome, Jervell and Lang-Nielsen syndrome, any autosomal recessive long QT1 form, or patients that have had multiple cardiac events as children. And then if we look at the low risk group, those are patients with a QTc less than 500, patients with long QT syndrome type 1, males with long QT2, patients without cardiac events are, of course, in the lower risk group. So what are the indications for defibrillators? It's pretty finite, and they're as follows. Survivors of a cardiac arrest. So if you've had a cardiac arrest that was resuscitated, you get a defibrillator. If you've had syncope while on a beta blocker, so while being treated, you have breakthrough syncope, that is a risk factor. And patients that are higher risk, as we discussed, patients with QTCs that are above 500 and certainly above 550, genetic conditions like Timothy syndrome and Jervell and Lang-Nielsen syndrome, and then a QTc greater than 500, as we talked about. And then electrical instability, I think Rodina, you showed, where is Rodina? You showed the ECG, hi. You showed the ECG of a patient with a QTc of 700 with T-wave alternans captured on a 12 lead. That is an incredibly high-risk patient. And I wondered, as you showed that ECG, if that patient had a defibrillator or not. But T-wave alternans is a pretty high-risk finding. This is a genotype of a patient that I follow with long QT syndrome, a different patient. And this patient's paternal uncle, so you see by the slash in the left side of the screen, died suddenly after his alarm clock went off when he was attending university. That patient's sudden cardiac death history has nothing to do with anybody else in the family's sudden death history. This is something that I've seen a lot in terms of people making mistakes. Family history is not an indication of a risk factor for long QT syndrome. And this is because in long QT syndrome, the genetic penetrance can be variable. The same KCNQ1 gene, for example, in one patient may have a very different effect in a family member. So just having a family history of sudden death does not mean that somebody should get a defibrillator. I wanted to share with you what our long QT syndrome database looks like. These are all the long QT syndrome patients that I follow at Cleveland Clinic, and they're broken down by genotype. You see long QT1, there are 101 patients, 68 long QT2, and so on and so forth. And the patients in orange are the ones that have defibrillators. And it's a very small fraction of the patients that I follow. I should also mention that most of the patients that have defibrillators that I follow, I did not implant, nor do I think they should have gotten implanted. I inherited them with a defibrillator already. I'm not sure I would have made that decision. Having said that, these patients got their defibrillators often 20 or 30 years ago when it probably was appropriate at that time to put a defibrillator. And I'm not certainly judging that. I'm just saying the times have changed, and the threshold to implant a defibrillator for long QT syndrome has also changed. How do we program the defibrillators? This is an important part of the process, of course. There is no role for anti-tachycardia pacing in long QT syndrome, and that should be programmed off. And the reason why is because Torsades is the arrhythmogenic propensity in long QT syndrome, and you cannot ATP torsades. What you can do is have a device misinterpret a rhythm, sinus tachycardia, for example, think that it's VT and ATP sinus tachycardia into torsades. So you can really cause harm by programming ATP in these patients. We use very high rates for therapy zones. Again, you're not worried about VT, you're worried about torsades, which is going to be very, very fast. And in kids in particular, you want to make sure that there is a huge safety margin between what a child can achieve in sinus tachycardia and what torsade is going to look like to a defibrillator. So our therapy zones are never less than 220 beats a minute. And we employ long detection times, particularly in patients with long QT syndrome. Often their torsades can be non-sustained. So somebody with syncope that has long QT syndrome, oftentimes they wake up because their torsades terminates on its own. We don't want them to get shocked for an event that may terminate. Though, of course, if it lasts for 30, 40 seconds, we want the device to intervene. Additional therapies that are worth mentioning, the first is the video-assisted thoracoscopic sympathectomy. This is something that our surgeons do at the Cleveland Clinic. Let's focus here on the picture on the right, showing the cartoon of the process. What they do is deflate the left lung, and they insert 3 probes into the heart, or into the left chest, excuse me, and a camera. And
it is crucial to resect away from the spine, because in the event of transection of a blood vessel lying close to the spine, the vessel can retract, making it difficult to identify the source and establish hemostasis. We then identify the stellate ganglion, pull on it to see the entire structure, and ligate its distal half. This is another advantage of resection, that is, it provides downward traction to be able to see the entire stellate ganglion for precise resection of the bottom.
We typically keep them for a day after sympathectomy because rarely, though it can happen, they can get ventricular arrhythmias the first several hours after the sympathectomy. Who gets a cardiac sympathectomy? People with beta blocker intolerance, which is common in the pediatric population, beta blocker noncompliance, which is also very common in the pediatric population, symptoms despite maximal therapy, or patients that have discharges from their ICD frequently. Another adjunctive therapy is pacing. This can be very effective in preventing pause-dependent torsades, which we'll see down in that graphic below. I find it useful for long QT2 patients, which are oftentimes pause-dependent. And typically we pace at a rate of 70 or 80 in the atrium. Oftentimes a single atrial lead will suffice. This graphic below shows a patient with a PVC, a post-compensatory pause, then that sinus beat has a very long QT interval associated, and any PVC in that vulnerable period can cause polymorphic VT. So back to our patient with exertional syncope, a QDC of 480, and a pathogenic KCNQ1 variant. This patient falls into the people that would be very responsive to beta blockade and a low-risk phenotype, given that he has long QT type 1, would fall into the bottom part of our risk pyramid as well. Treatment for this patient was Nadolol. At a weight of perpetuose, we advised them to avoid QT prolonging medications, kept them out of sports for 6 months, and the patients had no symptoms. It's been 3 years since we've diagnosed that patient, and no defibrillator, of course. So key takeaways: start with risk stratification. Consider efficacy of conventional therapy first, and conventional therapy, particularly given the subtype, can be very effective. And IC indications are relatively narrow. We need to keep that in mind. That's all. Thank you so much.
Thank you very much, Professor Peter. Can we, I think we're open for one of two questions. We'll start with Dr. Lamia Allam.
Hello, Dr. Peter. Thank you for your elegant lecture. Indeed, it's very informative for long QT syndrome. And I have just two questions. The first one, when the child or the athlete can return to exercise after controlling of long QT on medical treatment with low risk with low phenotype, as you said, 6 months. It is your rule in your center, and what are the parameters or tests that you can do before you allow for your patient to do exercise again?
Thank you for the question. Yeah, the guidelines actually say so. So the American Heart Association published the Task Force 10 guidelines in 2022 that guide us to say that if somebody's a long QT patient, if they've been asymptomatic as an athlete for 6 months on therapy, they can return to play. The decision is not that simple. Practically speaking, what we tell our families is they can return to play if the coaches are aware of their condition, there are CPR trained providers on site, and there's an AED. I don't know about the landscape in Egypt as much, but in the States, AEDs are becoming more and more ubiquitous. And there's legislation now that mandates that AEDs are in environments where kids are playing, playgrounds, sports venues. So that access makes the equation a bit different, and I think changes our threshold for saying that somebody can return to play. But that's generally speaking what we do. There's one important exception. This came up, Rodina, and the patient that we consulted on yesterday, the day before. The days mixed together now, right? But the patient was a long QT patient that had syncope with exercise, much like the patient we presented. And the family asked me, can they do anything? And we said everything except for swimming. So swimming is a very powerful long QT1 trigger. Not only is that the case, but the probability of resuscitating a child that might be far away from you, that might be in water where you can't see the bottom and recognize that they've had a syncopal event or a cardiac arrest, that adds a little bit to the complexity of it versus somebody that's playing in front of you in a playground where you can see them. Getting somebody out of a pool, drying them off, getting an AED on them, and using therapy appropriately just adds steps to the whole process. So we have a little bit more caution with swimming because it is such a powerful long QT1 trigger.
Do we need the provocative test, for example, stress ECG
right.
before return to play?
You asked me that and I forgot to answer that question, sorry. We don't have any routine tests that we do pre-participation, no. I often will do an exercise test after they start beta blocker therapy to make sure that they have adequate chronotropic suppression, meaning that their sinus tachycardia rate now is lower. The only evidence that I've seen is something that we just published, and the reviewers of this paper were not very happy with what we were talking about, I'll admit. So it's controversial, but I think that is a good surrogate for catecholamine suppression and beta blocker efficacy. If you could show that on exercise, their maximum heart rates are a lot lower than they should be.
Thank you.
Bear in mind, though, that long QT patients have a lower maximum heart rate at baseline. So getting a baseline, then starting them on beta blocker therapy is probably the better way to do it if you can.
Thank you, Dr. Peter.
Thank you.
Thank you.
Just a very small question, because I saw in one of your slides a very interesting notion, having a family history of sudden cardiac death is not an indication for, I agree on this notion very much, but even if I have a patient having long QT, having syncope, and his mother has had long QT and VF, and then, she was a survivor of sudden cardiac death, and she put an ICD, and this guy, when he was like 10 years old, and Osama put him on beta blockers, and he significantly improved, but still, I had a Holter monitoring before and after with a QT. Before the beta blockers, it was in the late 490 to 500s, and after the beta blockers, it significantly decreased. But unexpectedly, this syncope was not related to the QT at all, to any form of arrhythmia. So at all, I mean, we put a long term, he had very frequent syncopes, like every few days. So we put long stand, like a week or so.
Yeah.
And at that time, he did not have, he had multiple syncopes with no single arrhythmias.
Huh.
So what's your take on this?
Yeah, it's hard to know why he's having syncope. It's good that it's not arrhythmia.
It was neurological, and he was given, it was seizures.
Yeah.
But he has a family history, very strong family history, and his mother put an ICD.
Yeah,
so we had a debate about this, so
this is
we
hard.
want your take about it.
It doesn't always feel good to have these conversations with families, especially when the parents had an arrest, like you were saying. They're worried about their child having arrest, of course. And I think we have to support the family's autonomy to some degree, too. And if a mother looked at me and said, I want my child to have a defibrillator, then that's a conversation we have, right? We can't say absolutely not. But this is just what the data shows. In every other disease that we know about, almost, a family history of sudden death is bad, and you put defibrillators in people for that if they share the same phenotype. Hypertrophic cardiomyopathy being a great example, because that works. I've seen, right? We've all seen, if somebody has hypertrophic cardiomyopathy in the family, the probability of a family member having an arrest is very high. But in long QT, it doesn't always add up that way. I'll tell you that the seizure piece of long QT syndrome is real. There is a cross phenotype of channelopathic brain activity. So there are some ion channels that exist in the brain just like they do in the heart. And in long QT2, for example, we see bona fide epilepsy that is totally separate of arrhythmia in patients with long QT syndrome type 2. So it can be very confusing, but yeah. Right. And I think a monitor is the right thing to do. We even implant monitors for that reason, to make sure that a long QT2 patient really doesn't have arrhythmia, but in fact has seizures.
Thanks, Dr. Peter, for this elegant speech. I have one question regarding the type of the ICD, I mean the vascular access. Do you find, from your experience, putting something to spare the vasculature like the extravascular ICD in this patient helpful? I know that pacing to avoid bradycardia is important in this patient, but from your clinical experiences, which is more worthy, to preserve the vasculature or to provide a transvenous ICD lead?
Yeah, the sub-Q is of course an option. I think some of the troubles with the sub-Q in this disease is they may not screen in for it. The T wave and the QRS ratio and the width of the T wave can make them not qualify. So we have to be very careful about that. And sometimes the T waves will change with exercise too in a long QT2 patient or a long QT patient in general. So we have to make sure the sensing is perfect for a sub-Q. And I was saying that there are sometimes pacing indications. So obviously, if there's pacing indication, you're going to do a transvenous system. I shouldn't say that. You could do a leadless in the atrium and a sub-Q device, but that's a lot of hardware. I'm not sure that's the most practical thing. But this is the reason why the threshold to implant a defibrillator is really as high as it is in long QT syndrome. All of these things are very troublesome problems for pediatric patients, and we have to make sure that their risk of sudden death is higher than the risk of all the complications from a defibrillator, which we didn't even really get into, but for a pediatric patient, it's a very important thing to think about, of course.
Thank you.
Thank you.
Dr. Peter, can I ask a question about, sometimes we evaluate the patient at the beginning very risky, and then we put an ICD. But after following, let's say, 10 years to 15 years, patient didn't get any episodes of VF and shock. So in such cases, would you think to explant ICDs after 10 years?
Yeah, we've actually done that. Well, I'll first say, it's easier for me to say because I send them to a colleague that Dr. Shaddy works with, and they do the extraction. So I don't have to do the extraction. So it's a different equation, right? But some of these leads are very old, and if you leave them in and they're not doing anything for a patient, getting them out later is going to be even more troublesome. And I think just about for every patient with a defibrillator that I've seen that got it 20 or 30 years ago, again, for well-intending purposes, if there's not an indication anymore and they're on beta blockers and they're not symptomatic, then I think it is the right thing to do is to at least present that as an option. Because having a defibrillator in forever is probably not the right thing either, lead fractures and such. Thank you.
I have one question. If this patient is assumed not to be inside the States, North America, he's outside, and you don't know his genotype, whether he's 1 or 2 or 3. How you would approach management of this case?
Yeah, many of the cases that I've seen here are just like that, where you don't know the genotype, and a defibrillator comes into question. I think even if you don't know the phenotype for sure, you could still risk stratify them with everything else that you have, like their ECG, their symptoms. I think those are 2 important things. Is their QTC less than 500, and have they had symptoms despite being on beta blocker therapy? The role for primary prevention is pretty small, but I would say a long QT2 female with a QTC above 500 or 550, you could really consider a primary prevention. And maybe a long QT3, and then we talked about Timothy syndrome and Lang-Nielsen syndrome. Outside of those very specific examples, it's pretty uncommon that somebody's going to need a defibrillator for long QT. As long as they're, so propranolol, obviously they have to be compliant with and use and avoid medications that prolong the QT interval.
Okay, thank you very much. Very presentation. My comment or question regard positive family history of sudden cardiac death or syncope. Actually, for us as biologists, the history is very important. For me, I have a family with 2 previous babies had sudden death during sleep without any complaint. The heart was normal. The 3rd baby, I suspect to have arrhythmia, and it was long QT. So how could I neglect this positive family history that is key for me for diagnosis? Or shall I put it in my mind and look for further investigation? Thank you.
Sure. This is a patient, your 3rd patient has long QT syndrome. What is their QTC? Do you know? Yeah, I mean, that's how I would think of the conversation. Of course, having 2 patients that have already died is suspicious, but perhaps they have an autosomal recessive form of long QT syndrome. Maybe they're so young that it was Dravet-Lang-Nielsen syndrome, and we didn't know because we couldn't tell that they're congenitally deaf yet. So there might be a little bit more to the story that tips them on the risk scale to be higher risk. But again, just the family history in that situation isn't enough to say that the risk is higher, but there probably is something else in that story that does. Whether it's genetic, whether it's the QTC being very, very long at baseline.
Thank you very much, Dr. Peter Aziz. We're sorry to keep you standing all this time, but discussion with you is very interesting.
Thank you very much. Thank you for the questions.
Thank you. Now we move to the next speaker, Professor Tawfiq Karagos, Professor of Pediatric Cardiology and Electrophysiology in Hacettepe University in Turkey. Is going to talk about cryoablation in pediatric arrhythmia. And by the way, I grabbed this opportunity to thank you very much for the lovely case that you did yesterday for one of our patients with mid-septal. We really enjoyed it. Thank you very much. Thank you.
Dear chairs, dear my colleagues, first of all, I would like to thank to my colleagues who is organizing this wonderful meeting here in Egypt. I'm happy to be here. And I would like to apologize for my poor English. I hope I can express my feelings about my topic. So my topic is cryoablation in pediatric arrhythmias. Here's my disclosures. if you look at the septum area, we have to admit that it is not a simple anatomy because it has a conduction system there, coronary sinus, membranous septum, aortic root, crestal part of the ventricles. Especially anteroseptal area is very mobile anatomy. And because of the variation from person to person, it might be very risky areas when ablating some arrhythmias in such areas, I can say. And also the accessory pathways may vary from patient to patient. The course of the accessory pathways usually are oblique, and the insertion site to the ventricle and the atrium may change from person to person. And the QRS morphology may change according to the insertion site to the ventricle. And you may sometimes have crestal or true Parisian accessory pathways in such patients. If you look at the literature, to the systematic reviews or meta-analysis about the RF and cryoablation, the results shows us in children usually cryoablation is the option of is mainly used. The acoustic success rate is comparable when you compare it with the RF. Recurrence rate is somewhat higher than the RF, but you can decrease the recurrence rate by modifying the technique, I think. And we have to admit again, there is a certain risk of AV block in the RF group in such anatomy. And if you look at the literature, there's no reported case, any AV block with the cryoablation, I can say. So if it comes to the mid-septal and anteroseptal paranodal areas, RF ablation for me is very difficult and very risky procedure. I have to admit that. If I use RF in such cases, I usually having very stressful, and I'm sweating with my severely sweating in such patients, I can say. So, which is also in children, which is also associated with the higher rates of first procedure failures and complications and recurrences as compared with the other locations, I can say, especially relevant when treating pediatric patients. If you look at the survey study which is done by Michael Sheffer among the physicians, electrophysiologists in the United States, they report that the cryoablation will only be utilized after mapping AVRT to the high-risk locations. However, almost 50% of the physicians were using cryoablation as first-line therapy, even for AV-RT in children. So, what are the advantages of the cryoablation? Because of its reversible nature, good stability, and the main advantage is testing wherever you want. You can test because of the reversible nature of the cryo energy, and you may end up with a comparable success rate with the cryo and without any risk to damage to the AV node, I can say. So for me, no RF, no stress, actually. So I would like to continue with one case, as in 5-year-old child, 16 kilogram frequent SVT, resistant to the antiarrhythmics. If you look at the surface EKG, you can evaluate that the QS pattern in V1 and positive delta waves in all inferior leads, estimating a Parisian accessory pathway. And when you look at the intracardiac recordings, you can evaluate a complete fusion in the mapping catheter when the conduction blocked in that area, then you can evaluate a big A, big His, and big V potential. In such area, for example,
it is, for me, it is very dangerous to use RF, but you can test here with cryoenergy without any hesitation, and you can, if you find it successful, you can continue by checking AV interval. If there's no prolongation or block in the AV conduction, you can continue and complete your cryo lesion there, and you can give some extra additional lesions, and you can end up with a successful procedure without any risk to the conduction system here. As you can see, in such patient, we are usually, in our laboratory, we are using combining the unipolar recordings also to find the exact positions. Here we have another case with dysynchrony at the septum, and after mapping, you can see a very complete fusion with the A and V potentials, and here there is a sharp potential between A and V. Probably it is an accessory pathway potential, and you can determine the area with cryocatheterals, and you can test there. If you find it successful, you can continue without trying to find a safe area. And you can adapt the new technologies to find the best area, like HD grid catheter, as in here, by marking the area by using also 3D mapping techniques, and you can go there easily with the cryocatheter, as you can see here, and you can ablate there easily. We can increase the samples like this. I would like to pass some of the slides because of the time limitation. Also with cryocatheter, cryo lesion, you can put a cryo lesion during the tachycardia without any damage to the conduction system. As you can see here, during the orthodromic tachycardia, we have a big His, V, and retrograde A potential completely fused, and you can start cryoenergy here without any hesitation, and you can terminate the tachycardia, and you can continue a successful lesion there. Also, although the cryocatheter a little bit thicker and stiffer catheter, you can make very nice loops in the right ventricle or right atrium, or you can use roof technique to have a stable catheter position to make a correct cryoadhesion. Some of the slides are moved because of the change in computer, I'm sorry. But there is a loop here in the right ventricle. You can make a almost 960 degree of loop, and you can approach to the crestal area, and you can make like this here. You can make a nice loop in the ventricle or in the atrium. You can approach to the crestal area to have a stable catheter position, and you can ablate there easily. If we, in the early times, we have published our parahesian accessory pathway experience in 2013. Until now, we had ablated more than 134 cases in the anteroseptal, mid-septal area, and the age of the patients are between 6 months to 32 years. Body weight is around 8 to 120. Mainly, we are putting at least 4 or 5 lesions at the same successful area by using freeze technique, and usually we are using 6 millimeter catheters. And at first attempt, we may end up a success rate around 90%. With this second procedure, we can reach to 95.5% success rate. So as a conclusion for septal accessory pathways, ablation for parahesian accessory pathways, possible even in small children, I can say. Ablation by utilizing cryo have a very comfortable success rate, very comparable success rate, and safe, and should be considered as a treatment of choice for accessory pathway located in the risky areas, I can say. Accurate cryomapping and creation of a durable, stable lesion through consolidation of the first effective lesion is important by using modified techniques. I mean, increasing the lesion at the successful area, you may get higher, lower recurrence rate, and you may have a successful, you may increase your success rate. I think for small child, using RF energy in paresthesia and accessory pathways, question mark for me. We are also using focal cryoablation in AV NRT patients. Let's say we are using 50-50% in our clinic. If you look at the success, the procedure time looks like longer when you compare it with the RF, but the fluoro time is lower than the RF group, and the recurrence rate is around 6.7%. When you compare it to the RF, it looks like a little bit higher, but I think this is acceptable for me. And you can even decrease the fluoro time by using 3D mapping, by adding the 3D mapping in these patients. Even in some patients during the general anesthesia, induction of the tachycardia might be difficult. So if you are sure about the tachycardia, and then if you have the dual AV nodal physiology, you can even do empiric ablation in small kids. Here is the a typical AVNRT, and the targeted area usually that we are is the A potential, and the B potential is like this. And after the cryoadhesion, you can test the success of the lesion, and you can end up with the successful procedure. Even in the Epstein cases, sometimes we have used cryoablation, not mainly, but in a small group of patients, we have used cryo, as in this case. There is a pre-excitation and Epstein anomaly, and the tachycardia with the right bundle branch block morphology. And by mapping with the cryo catheter, as you can see here at the posterior septal region, we have found a nice tracheus with annulus. After mapping the right lateral, we have seen a very nice fused A and V potential. And when we give energy to here, the tachycardia is terminated, and the right bundle branch block morphology during the sinusotomy is appeared. So we can increase the samples with the, ventricular ectopies, which is very close to his area. And you can ablate these ventricular ectopies with cryo energy, as in these cases. So I need to pass all this because I have finished my time. Even you can go retrogradely to the aortic root with the cryo catheter, and you can ablate, as in this case, from the aortic root with cryo, I can say. So this is one of the very interesting cases in the early times of my experience. 8 kilograms 10 mount of child with atrial flutter, and here is the cardiac catheter by mapping and testing, and the cryo catheter. You can create a cavatricuspidismus line by using cryo energy, and you can terminate the tachycardia. So if you compare it with the radiofrequency, cryo has a, for a child has a many advantages that we can use it, which is reversible. By using cryo energy, you have a good stability, and you can test the area, and you can determine the successful point and ablate it safely, I can say. As a conclusion, cryo energy for me is safe, has a comparable success rate, somewhat higher recurrence rate, I have to admit it, but it's okay. In addition to the septal arrhythmias, we can use VT, PVC close to the risky areas. We can treat all these patients. And if you can reach to the middle cardiac vein area, you can use it also safely in these areas. In patients, especially with complex congenital heart disease, with a probable conduction system abnormalities, you can use it also safely and effectively. Thank you very much.
Thank you very much, Professor Tawfiq. Now, any questions? I personally have a very small question. Has it ever been used in or more safer to use in if we have coronary sinus pathways?
Yeah, sometimes I mean, you know, the cryocatheter is a little bit stiffer. Sometimes it is very difficult to proceed to advance the catheter into the coronary sinus. But if you manage to go there, you can ablate. I have a few cases like that.
Yeah, and there is no problem with the...
No problem, yeah.
Okay. Of course, تفضلي دكتور.
The radio frequency technology, have you used the cryoablation to treat hypertrophic cardiomyopathy in children? And is it safer than radiofrequency?
You mean in hypertrophic cardium?
Subaortic, like a localized area of hypertrophy causing SAM and causing obstruction. Can you use the cryo?
I didn't try it in any of my
because
cases.
I found one publication saying that, so I wanted to ask.
I don't have any experience with that. I'm sorry.
Okay, thank you.
Dr. Sonia, I have an experience with RF at this location. I've done a couple of cases, one of them with RF, and it was, I remember, with Dr. Amal Khalifa at that time during ECHO. I think Michael was with me at that one of the cases, and it was during procedure, immediate drop of
so I'll send you my patient. All right?
Okay.
We have one patient. Come and do it.
Oh, sure.
Yeah, for me, instead of cryo, RF lesions might be more successful than the cryo, because with cryo it is, I mean, you are putting a very small lesion to that area. To be successful in such patients, probably it will take so much time to get.
Thank you very much, Professor Tawfiq. And now we move to the following speaker. Professor Maria Gonzalez, Senior Consultant Pediatric Cardiology in Mainz University in Germany. She's going to speak about arrhythmogenic pediatric Brugada syndrome.
Thank you.
And thank you.
Thank you very much for the nice introduction. First of all, I want to thank the whole organizing team, especially the EP team in Cairo. You are a very nice group. It would be a pleasure to work here, I think. And especially my thanks to Asama, I don't know where he is, to invite me here. Oh, sorry, to invite me here. It's really a great honor for me. So I want to start with, oh, this is the wrong slide, but it's the second talk. Should I switch or should I talk this? I talk this, okay. The management of arrhythmias and risk prediction in pediatric cardiomyopathies. Please note I don't have any disclosures. I want to start with the risk of sudden cardiac death. That's rare in children, but it has multiple causes. And this table shows you that most common cardiac etiologies of sudden cardiac deaths in young victims. And the autopsies revealed that cardiomyopathy, especially hypertrophic cardiomyopathy and arrhythmogenic cardiomyopathy, as well as some electrical disorders, were the most common causes of death. And for this reason, I will focus my talk on hypertrophic cardiomyopathy and on arrhythmogenic cardiomyopathy. And since last year, there are new guidelines from these take into account the special features, in particular the risk factors for children, and they define hypertrophic cardiomyopathy. It's characterized by predominantly left ventricular hypertrophy in the absence of another cardiac or systemic or metabolic diseases, and for which disease-causing sarcomere or sarcomere-related variant is identified or genetic etiology remains sometimes unresolved. In asymptomatic children with no family history, LV hypertrophy plus a Z score plus 2.5 is pathologic, but in children with positive family history or positive genetic testing, a Z score from +2 is pathologic. So the estimated prevalence in hypertrophic cardiomyopathy in adults is one of 500, and in children it's much lower. The mortality is in the age range from 8 to 16 years higher than in the older group. And the sarcomeric gene mutation is identified in 60% of the patients, and most affected genes are myosin binding protein and myosin heavy chain. And if you have this variance, they have higher and earlier incidences for adverse outcomes. It is the leading cause for sudden cardiac death in children after infancy and in young athletes, and due to ventricular and supraventricular arrhythmias. And there is an interesting retrospective cohort from Boston, and they identified 345 patients with hypertrophy cardiomyopathy, and 8% of them had ventricular pre-excitation. And they performed EP study and revealed that 5 patients had a very high risk AP. And it's due, like in this patient I will show you, it was a patient from us with pre-excitation and hypertrophic cardiomyopathy, no symptoms, no tachycardia, never. And in the cath lab, he spontaneously went to atrial fibrillation with fast conduction, and we had a SPERI of 164 milliseconds. So the challenge remains to identify the relatively small group of patients with the highest risk of sudden cardiac death. So, and these are data from the European Observational Cardiomyopathy and Myocarditis Registry, and they enrolled more than 600 patients. Mean follow-up was 12.5 months. And hypertrophic cardiomyopathy was the most common subtype, followed by dilative cardiomyopathy and restrictive cardiomyopathy, and arrhythmogenic right ventricular cardiomyopathy were less numbers. And ventricular arrhythmias, prior the enrollment had about 8%, 51 patients, and 27 of them had sustained VT, and which was more common in patients aged between 10 to 18 years compared to those in the younger age group. But 24 patients were resuscitated because of VF, and there were no difference in age groups. So the end of follow-up, about 13% got an ICD, and mostly due to for primary prophylaxis, and most likely due were the patients with arrhythmogenic ventricular cardiomyopathy and hypertrophic cardiomyopathy. But you see there that most likely the older age group from 10 to 18 years got an ICD, not the younger one. what was very interesting is that in this registry, more than 50% enrolled hadn't had an ambulatory ECG monitoring before. If you would perform an ECG monitoring before, you have a detection rate of about 5% for detecting NSVT. Also, about 40% had no documentation of LA diameter, and we know that both LA diameter and NSVTs are risk factors. So there should be, we think that there is a potential gap in recommendations for the pediatric cardiomyopathy patients management. So when we look in adults, age is risk. In children, age is not a risk factor, and this could be explained very nice by this study it's an international consortium study, and we had 1,200 children below the age of 12 and older, 12 years, and they showed that sudden cardiac death was the most common cause of mortality regardless of age in both groups. So the pointer, you don't see them, right? In both groups, you see here that there's, in blue, the sudden cardiac death is the same as in the older than 12 years. And when you look for resuscitated and really the proportion of sudden death and resuscitated cardiac arrest, then you see that in the younger age groups here, the amount is much larger than in the older age groups. And this is because that younger patients receive less ICDs for primary prevention. So the conclusion is that younger patients should not be considered really different for risk stratification. There should be a similar management strategies as in older hypertrophic cardiomyopathy patients. The assessment of the individual's sudden cardiac death risk in the pediatric hypertrophic cardiomyopathy patients is complex, and actually there exist two pediatric risk prediction models. The risk kits and the primacy model. The latter need more validation due to small patient numbers. So I will focus on the risk kits model for patients up to 16 years, and risk factors are NSVT, unexplained syncope, LV wall thickness, and low LVOT gradient, and the LA diameter. Not included are age, family history of sudden cardiac death, genetics, and the ECG features. The risk kits prognostic model was developed from a retrospective multi-center study. From these cohort, more than 500 patients were evaluated and calculated for the 5-year sudden cardiac risk estimation, and they were classified with complex algorithms according the risk factors into 3 risk groups. And the result was that a 5-year predicted risk of 6% identified over 70% of events. And the figure demonstrates that the numbers of observed and predicted events were very close. And this risk model may help the clinician to evaluate when there are concerning for ICD implantation. There is a position statement of the AAPC working group for indications and management for ICD therapy in children with hypertrophic cardiomyopathy, and they reviewed the risk factors for sudden cardiac death. And they defined the major risk factors that were the same as in the risk kits model. And they recommend to take additional risk factors into account before ICD implantation. And although there are not really data for some of them, for example, there are conflicting data for LVOT obstruction, and there are no clear definitions for the extent of LGE and MRI or echocardiographic parameters. Nevertheless, these additional factors should help the clinician to make an individual decision for ICD implantation. In patients with hypertrophic cardiomyopathy, first-line therapy is a high-dose beta-blocker medication. None of the antiarrhythmic drug is 100% effective. Alternatives are sotalol and amiodarone. Combination with verapamil or disopyramid should be started with caution. Drugs to avoid are vasodilators and stimulant drugs for ADH disorder. Exercise with moderate intensity is possible, and we should consider ICD implantation after individual evaluation. And in patients with SVT or with documented pre-excitation, EP study and ablation should be performed. The European guidelines for the management of patients with hypertrophic cardiomyopathy recommend an ICD implantation in patients after cardiac resuscitation and when they are hemodynamically not tolerated VT or VF. And for primary prevention of sudden cardiac death is a recommended ICD implantation in estimated 5-year risk over 6%. And I will go only short on the arrhythmogenic cardiomyopathy. That's the commonly used definition. It's a arrhythmogenic disorder of the myocardium, not secondary to ischemic, hypertensive, or valvular heart disease. And the important distinguishing factor are that there are arrhythmias like atrial fibrillation, conduction disease, and ventricular arrhythmias. The etiology may be part of systemic disorder, or infection, or genetic, and the phenotype can overlap with all other forms of cardiomyopathies. And up to now, the best characterized arrhythmogenic cardiomyopathy is the arrhythmogenic right ventricular cardiomyopathy. And there are new European guidelines, diagnostic the criteria from the last year. I don't want to go in details on that. There are 6 different categories for diagnosing right and left ventricular arrhythmogenic cardiomyopathy. And once you determined all criteria, this flow chart might help to differentiate arrhythmogenic and right, left ventricular or biventricular cardiomyopathy. The arrhythmogenic right ventricular cardiomyopathy is the most frequent form in pediatric age and in the adolescents. And histopathological, we find fibrofatty replacement of the myocardiums in the RV more than in the left ventricle, but left ventricle is possible. They lead to conduction abnormalities and to ventricular arrhythmias, and therefore to an increased risk for sudden cardiac death. It's also called disease of desmosomes. More of 60% of the patients have one or more pathological variants in the desmosomal genes. It's predominant autosomal dominant inheritant form. Also, the ARVC presents primarily in adulthood. Recent studies suggest that genetic positive patients present with heart failure and dilatative cardiomyopathy phenotype often or frequently. In 16 to 40% of the patients, the first symptoms is syncope, and that's often exercise related. It may be a challenge to make an accurate diagnosis of IRVC in children. Some diagnostic criteria are in children normal or really not evaluated. As it is a progressive disease in the IRVC, criteria might develop during follow-up time. And this was very nice proven by a Dutch study with children. They found out that during the follow-up progression was most frequently observed in ECG, followed by MRI and Holter. And therefore, the conclusion is that these things is what we really need. An MRI is much better than echo. Once the diagnosis is secured, a determination of an individual's risk for ventricular arrhythmia and sudden cardiac death is necessary, and these the risk markers include the history of VT or VF, PVC burden, syncope, genetic tests. and the gender, and myocardial function. And there's online a risk calculator for IRVC, and these are for patients older equal 14 years of age. With regard to the therapy of arrhythmogenic cardiomyopathy, so are the beta blockers established drugs. A combination with further antiarrhythmic drugs is not really recommended. The catheter ablation may reduce the ventricular arrhythmia burden, but it has no influence on sudden cardiac death. Interesting is that restriction of exercise is really highly recommended, and in ICD implantation should be considered in high-risk patients. And here there are some small difference between the ICD implantations recommendations from PACES and the Europeans. There are both say, okay, ICD is recommended in patients with hemodynamically not tolerated VT or VF, but concerning the primary prophylaxis, they have shown some differences. The Europeans also take into account the RV function or dysfunction, and not only the LV, and further the presence of inducible arrhythmias and clinical symptoms. So my take-home messages are that hypertrophic cardiomyopathy is our major cause of sudden cardiac death in children after infancy and young athletes. The pathological sarcomeric mutations have higher incidences of adverse outcomes. The risk kits model with an estimated risk over 6% may help in evaluate patients for ICD implantations. In arrhythmogenic cardiomyopathy, the most common form is arrhythmogenic right ventricular cardiomyopathy in children. It's difficult to diagnose in young patients, and ICD implantation should be combined with drugs and or ablation. For both is that's progressive disease, so it needs periodical re-evaluation, and the therapy with beta blockers are for both the basis of an effective therapy. Thank you.
Thank you. Thank you very much, and I'm sorry for the, because the first lecture was, yes, just, any questions to Professor Maria from the audience?
I have a small question, Dr. Maria.
Sure.
Hello, Lamia Alla, from Professor of Cardiology and Cardiac Physiology in Ain Shams University. My question about, we have a problem here in Egypt that the availability or the shortage of availability of genetic testing. So we meet families with a history of sudden cardiac death, and they come, the alive members for screening. You do everything like ECG, CMR, even in some cases if there is doubt, ECG, and you didn't find anything. What you can do in these cases, you will be sure 100% that they has no risk for sudden cardiac death like his family members, or how we can do a follow-up screening or additional instructions to avoid future events?
Actually, we have a amount of non-genetic hypertrophic cardiomyopathy also in Germany, so we will follow up them as normal. We do regularly Holters every half a year. Once a year they go on the treadmill test if possible. If we see hypertrophy, they got a beta blocker up to here. And this is how we manage it. When we have suspicious of some palpitations, not syncope, but but suspicious for other symptoms, then we are very easy putting in a reveal recorder.
Yes.
I forgot to mention that we are doing MRI. We are doing MRIs in the, every 3 to 5 years in our follow-up. That's how we do it.
Sometimes, as you said, the CMR findings in pediatrics is a little bit limited. In some reports, we see some changes which we be adult. For example, I have a patient who has three events of sudden cardiac death in his siblings. Died suddenly, and he is the only precious child now, 14 years old. When I sent him for TMR, because I saw ECG with inversion beyond V4, the doctor said that there is only a microaneurysm in the right ventricular free wall, and there is no fulfilling criteria of RV dysplasia. In a case like this, what you can do? The patient is completely asymptomatic. His three brothers died suddenly near this age. ECG doubt for T-wave inversion in all the precordial leads, and the CMR shows only microaneurysm, and or everything echo and other investigations are normal.
If I really don't see anything in ECGs holders and this stuff, I would wait. I would wait and see. I would really. I'm a big friend of implanted loop recorders, and often we see other things that we didn't think about that. Okay, but I because only of an aneurysm that with normal function and no rhythm disturbance, I would wait.
Okay, thank you.
That's.
I noticed also in your slides the cautious use of disopyramides in pediatrics. Yes, in adults with hypertrophic cardiomyopathy.
I tell you, I don't use disopyramide. It's
the only
like,
place
okay.
that is present is in Germany, actually. I don't know about mines, but
I don't use it. Okay. We don't use it. I'm sorry. It's written. It's always like this. Also, we don't have prokinamide and this stuff. So we use verapamil.
Okay.
Thanks a lot, Dr. Maria,
Thank
for
you very
this
much.
great talk. And vielen Dank und willkommen in Ägypten. I'd like to present our next speaker, Dr. Shadi Nahla, Professor of Cardiac Electrophysiology, Cleveland Clinic, US, who will share with us his experience regarding arrhythmogenic mitral valve prolapse syndromes.
Thank you very much again for the invitation to participate in this year's conference. I'll echo Peter's words that both Peter and I really look forward to our trip to Egypt every year. We really enjoy, thank you for giving us the opportunity to learn from you guys and work together on these challenging cases during the workshops, and the opportunity to collaborate and present today. It's really impressive, and we're really so proud of everything that you guys have put together. So congratulations. So I'm going to talk today about mechanisms of arrhythmia and management in patients with so-called arrhythmogenic mitral valve disease or mitral valve prolapse. And please forgive me, but really the focus of the talk will be a little bit from an adult perspective, and we'll see what lessons we can apply towards the pediatric population. And so I'll go through a case. This is a patient of mine. She's 52 years old. She has mitral valve prolapse that's been known. She only had mild to moderate mitral regurgitation on her echo. Her ejection fraction was normal. She went to get a sleep study. They noted PVCs on her ECG tracings. And she was given a 24-hour Holter that picked up a 19% burden of PVCs. She had runs of non-sustained VT, particularly at higher sinus rates. She was asymptomatic throughout the entire Holter recording, but endorsed some frequent stimulant use, both prescription and non-prescription stimulant uses recreationally. This was her ECG, which showed pretty normal axis, normal intervals, and then a single PVC, likely from the anterior mitral valve annulus. And then a couple of shots from her echo, you can see that she has mild bileaflet prolapse, no clear evidence of mitral annular disjunction, and late systolic mild MR at best. So not the most impressive mitral valve pathology. And this is a representative sample of the runs of non-sustained VT that she was having on her monitor. And as you can see, most of these runs are happening at slightly higher sinus rates during activity or during the day. So she came to see me. She's like, why am I seeing an electrophysiologist? Is my cardiologist overreacting? And so we had a conversation and we said, hey, let's at least stop the stimulant use, both prescription and non-prescription, and repeat an extended monitor. And then I scheduled her for an outpatient MRI. And I was waiting to see her in follow-up, but in the interim, she had an out-of-hospital cardiac arrest. This is real. She had bystander CPR from her husband. On EMS arrival, she was in VF, and she was successfully resuscitated. She was admitted to the ICU, spent a few nights in the hospital, and survived. I actually saw her in follow-up maybe a couple of months ago. On her MRI, we found evidence of delayed enhancement along the posterior wall, right near the mitral valve annulus at the base of the left ventricle. And so this is a nice case that really sets up what it means to have an arrhythmogenic mitral valve. And in my mind, there's three corners to this triangle that describe what's needed for patients with mitral valve disease to develop arrhythmia. One, and the most important, and we'll spend the most amount of time talking about this, is myocardial substrate. And so myocardial substrate, let me try to get a laser pointer here. Myocardial substrate is really one of the most important aspects of this triangle for patients to be able to sustain arrhythmias, particularly monomorphic VT. But likely there is a trigger, whether it's automaticity from the papillary muscle system, Purkinje cells in the tips of the papillary muscles, but also some transient modulator like a hyperadrenergic state, and likely in my patient, prescription and non-prescription use of stimulants. So one of the first studies that suggested a link between fibrosis and abnormal mitral valves is the study from Basso and colleagues from 2015. And this was an autopsy study where they looked at patients that, that had out-of-hospital cardiac arrest, particularly young patients. And what they found was that patients who had mitral valve prolapse with less than severe mitral valve regurgitation prior to their arrest demonstrated evidence of fibrosis in this Masson trichrome strain at the level of the basal inferolateral left ventricle at the insertion of the mitral valve leaflets. And this correlated in patients with mitral valve prolapse and no sudden cardiac death with that pattern of delayed enhancement that we see on MRI. So clearly there's some association between fibrosis and the development of arrhythmias in patients with mitral valve disease. The next elegant study that I want to talk about looked at patients undergoing surgery for mitral valve regurgitation, as well as a mouse model that explored mitral valve prolapse and described its behavior over time. And the four important conclusions from the study, and I'll show you where this evidence came from, was that there was evidence, like in the autopsy study, of fibrosis in the LV inferior wall. This fibrosis progresses over time. It's likely triggered by mechanical stretch of an abnormal mitral valve, and it's mediated by an inflammatory response that's driven by macrophages. And so in this slide, if you'll allow me to explain, what they did is they looked at patients who were going to get mitral valve repair or mitral valve replacement for severe mitral regurgitation. And at the time of surgery, they asked the surgeon to take a biopsy from the LV inferolateral wall, from the apex, and from the septum. And what they found is for every patient that there was an increased incidence of fibrous tissue deposition in the peripapillary biopsies as compared to the septum, and similarly as compared to the apex. And this demonstrates that there really does seem to be a preferential deposition of scar tissue along the base of the LV inferior wall in these patients with mitral valve prolapse as compared to other regions within the left ventricle. Here from the mouse study, in the top row you have a normal mouse, in the bottom row you have a mouse with a mutation that results in mitral valve prolapse. And what you can see is over time, 2, 4, 6, and 7 months, there's an increase in the deposition of collagen cells at that same level in the inferior wall of the mitral valve. And in this slide, you can see that there's an increase in expression of macrophage activity along that same region. So when we're seeing that there's fibrosis, when we're seeing that there's increased collagen deposition, we're also seeing that there's macrophage activity. One wonders whether there's also a role for inflammation over on top of scar tissue deposition in patients with mitral valve disease. And it turns out that clinically that's also true. This was a study from, I think, 2019 that looked at patients with arrhythmogenic mitral valve disease with very minimal mitral valve regurgitation. And what they found is that in areas where there was delayed gadolinium enhancement on MRI, if you took those patients and had them undergo FDG PET scans, those areas would light up with FDG uptake, suggesting that there's some sort of an overlap between a fibrosis-mediated disease as well as an inflammation-mediated disease, likely due to abnormal stretch of the mitral valve apparatus in these patients. And really, it turns out that my patient read the books. So this was her PET scan when she was admitted to the hospital. At the time, she was also being, ruled out for sarcoid and different conditions. And you can see here that along the infralateral wall of the left ventricular base, there's an increase in FDG uptake, and this matches the area of fibrosis seen on her MRI. She obviously went on to receive a defibrillator for secondary prevention, and this is an example of one of the tracings that she developed later. She had monomorphic VT, had anti-tachycardia pacing therapy. She ended up coming in for a VT ablation and has done very well with that. So we'll go back to the original diagram that I showed earlier, in that there were 3 corners: substrate, triggers, and transient modulators. And I'd like to add also that there's profibrotic stimuli and inflammation that are likely mediated by myocardial stretch to explain some of the reasons why these patients develop sudden cardiac death related to abnormal mitral valves. Now you might say, well, how frequently does this happen? How much of a problem is this? And this is a very controversial topic for a lot of us in EP. There was this recent study coming out of Alberta, Canada, that looked at the prevalence and characteristics of mitral valve prolapse in patients with unexplained cardiac arrest. And in their elegant analysis, what they found is that the incidence of, or finding, mitral valve prolapse in patients with no other identifiable cause of a cardiac arrest was around 6.6%. The incidence of finding mitral valve prolapse in a general healthy population is about 2.4%. And in those patients that had a cardiac arrest where there was a clear cause, but they also happened to find mitral valve prolapse, they found mitral valve prolapse in about 2% of patients. But all of these numbers, as you can see, are very, very, very small denominators. And so it's difficult from this to draw strict conclusions as to causality. But at least what we can do is perhaps understand who from our patients are at highest risk. And so this study was a multi-center international registry that looked at patients who had sustained ventricular arrhythmias or sustained cardiac arrest with known mitral valve prolapse. And they looked and said, well, what predicts their risk of having an event? And really what they found in this study was it was the younger patients who were female, who had bileaflet prolapse and some degree of mitral annular disjunction, infralateral T-wave inversions, and scar on MRI that seemed to be at highest risk. We already knew that from prior studies. The additional findings that they explained were also a prior history of unexplained syncope, as well as anterolateral T-wave inversions. The difficulty with all of this is that this is most of the patients that we see anyway. And so understanding who of this is at highest risk still poses a controversial topic. Now, interestingly, when you look further in the study, that most of the patients that had sudden cardiac death had mitral annular disjunction. Most of them actually had less than moderate mitral regurgitation and very minimal amounts of delayed enhancement, which is contradictory to some of the previous studies that suggested that you really have to have fibrosis and scar on the MRI to have some prediction of sudden cardiac death. And so a lot of this discrepant information from multiple studies really resulted in this 2022 expert consensus statement from ERA to really guide us with what we can do to help our patients with some of the decision making. And this is a very nice graphical abstract that was summarizing a lot of the expert consensus statements in this document. And really, in patients with palpitations who are symptomatic, a diagnostic Holter is indicated. If they don't have VT, understanding what their phenotype looks like based on whether or not they have mitral annular disjunction, whether or not they have non-sustained VT, whether or not they have delayed enhancement, really plays a role in understanding whether they should just undergo frequent monitoring, more permanent loop recorder-based implants, but also to skip all of that and say, hey, maybe this person is indicated for a primary prevention ICD. And so the guideline document ultimately ends up saying, and this is a very easy decision to make, if you've had a prior cardiac arrest with mitral valve disease, you deserve a defibrillator. If you have LV dysfunction with an ejection fraction less than 35%, despite GDMT, you likely deserve a defibrillator. Where things get more hairy are when you haven't had a sudden cardiac arrest, your ejection fraction is normal, but you have complex NSVT, and you maybe have one or two phenotypic risk factors like delayed enhancement, abnormal ECG, complex NSVT. And really the most that the guideline document tells us is that a defibrillator may be reasonable. And so what I find in my clinical practice is that most of these patients come into clinic, and what we do is our best effort to do a deep dive into their electrical, echo, and imaging phenotype to understand really how risky is their type of mitral valve disease. And so when I think back to the patient that I started with, she had complex NSVT on her monitor. She had scar on her MRI that we didn't get until after she had her cardiac arrest. And so she clearly presented herself as a high-risk patient up front. And it's always a case that I go back to and think, you know, maybe should I have considered a defibrillator in her early? But for every one of her, there's 20 other patients with mitral valve prolapse who likely don't need a defibrillator. And so even though I've been asked to somehow help shed clarity on this topic of mitral valve disease and sudden cardiac death, I find personally myself still somewhat lost. And honestly, like many of the diseases that we deal with, hypertrophic cardiomyopathy, ARVC, oftentimes it ends up being a very individualized discussion with our patients, with their families, about really what's the best option for every single individual patient. Thank you.
Thank you very much, Dr. Shadi, for this elegant presentation as usual. And again, we're open to discussion. Dr. Suzanne.
Thank you.
Mike, please.
Under-evaluation for it. Yes, that's true. We could make over-evaluation or under-evaluation for it.
Yeah.
So in cases of mitral valve prolapse only, without disjunction, would you recommend to do MRI? For example, the cases of fibrosis without disjunction and have arrhythmia? That's number one.
Yeah, sorry, go ahead, yeah. I don't think that we need to routinely be doing MRIs for these patients beyond quantifying their regurgitant fraction or getting a more accurate understanding of their valve pathology. I really don't think that garden variety mitral valve prolapse with no other risk factors should deserve an MRI. But once you start seeing that they're having palpitations, they have unexplained syncope, they have abnormal ECG, T-wave inversions, PVCs, abnormal Holter, that's really when I start saying, okay, maybe we need to understand whether this mitral valve is likely arrhythmogenic or not, and an MRI would be pretty reasonable. I would definitely do that. But I think routine MRI for every patient with mitral valve prolapse is likely too much. But I very much agree with your statement that with this patient population, ممكن نعمل محبة قبة. I don't know how else to explain it. Yes.
Exactly. So according to the symptoms of the patient, you go for further
symptoms and then other clinical, like I said, PVCs, NSVT on ambulatory monitoring and so on.
Yes. Because actually, from my experience, I have my colleague, a doctor, and asking me to do for him echo for mitral valve repair. He trusts me, and within 48 hours, he was in a week in sudden death. I don't know. So
wow.
I didn't see him. I don't know there is disjunction or not.
Yeah.
But sudden death within 48 hours, I blame myself, but I give him
what are you going to do,
and so on. The other topic about in mitral valve prolapse and arrhythmia, disjunction. In cases of disjunction, and that is very common with prolapse, we see now became alert for it, so we'll look for it. all cases go for MRI or according to the symptoms and complaint. I go in systematic way. If there is symptoms, I go for Holter for all of them.
Yeah.
If the Holter I have polymorphic PVCs or there is complaint, I go for MRI. But not all my patients, I ask for MRI.
Yeah,
Your opinion?
I think your approach is very reasonable.
All right.
And I think the other reason to get an MRI sometimes is, I think, at least in Cleveland, the overarching sentiment in the valve group of physicians that see most of our valve patients is that there's likely an overestimate of how much disjunction patients truly have.
Yes.
And so sometimes I think the role of the MRI is really to get a more accurate understanding of whether or not they have disjunction to begin with, or whether it's just really a floppy mitral valve that's fooling us into thinking that there's some degree of disjunction. But I agree with your approach. If you have abnormal findings, to then get the MRI and understand what's going on.
Yes.
I agree.
Because, for example, last week I have a doctor, his daughter, 12 years old, have mitral valve prolapse, moderate regurg with disjunction. He asked me, I will do MRI. He know now everything, prolapse and disjunction, and really he had MRI. Fortunately, no fibrosis and nothing.
That's great.
The last point.
Sure.
How many patients from those with mitral valve prolapse and disjunction have ICD from your experience?
Not many. Not many.
Not many.
I think the truth is that
even in the presence of fibrosis and MRI.
yeah, I think despite all of that, I would say that as an EP community, we're still stuck in secondary prevention mode for these patients. We're still very much stuck in giving them defibrillators if they've already had a cardiac arrest. And the truth of the matter is that many of those patients aren't even making it to our clinics.
All right.
For us to be able to systematically approach. And so, again, like I showed in the ERA consensus, by the way, the Heart Rhythm Society doesn't have a consensus document on mitral valve prolapse, it's just from ERA. In that patient population that you described, mild to moderate regurgitation, mitral annular disjunction, fibrosis, and NSVT, the most that they're telling us is an ICD can be considered.
Yes.
Not even recommended, not even highly suggested, or it just can be considered. So it's challenging. I don't have many patients with primary prophylaxis defibrillators. I have two, and I didn't implant them. Someone else did.
Thank you very much.
Personally.
Last point, as regards surgical repair for mitral valve prolapse with disjunction.
Yeah.
Do your opinion that this group of patients with repair and application of the area of disjunction and relieving it, the prognosis or the rhythm became not arrhythmogenic after this?
I think that it depends. I think for patients that have a lot of triggered activity from the papillary muscles, and those are the patients that end up developing VF, for instance, perhaps there is some role for surgery. But I think in patients that have already developed myocardial scar, the presence of that substrate may not be completely ameliorated by having surgery done. Those patients may continue to have a risk of arrhythmias regardless of surgery.
All right.
Yeah.
Thank you very much.
Yeah.
Thank you. Dr. Rania Hagazi, I'm sorry, first Dr. Rania Hagazi and then Dr. Maria.
Actually, دكتورة سوزان سألت السؤال اللي كنت عايزة أسأله. دكتورة سونيا عايزة تسألي حاجة؟ ولا we're done؟ دكتورة سوزان سألت غطت كل حاجة. Thank you so much for an excellent talk and a very debatable point.
Yes, Professor Maria, she wants to ask a question.
Thank you. It was an excellent talk. I have a personal question. I have a 14-year-old girl. She had father died, and she had genetically long QT type 2. And her QTC is more than 500, what was 520. I put her on beta blocker and mexiletine because of more than 500. And actually, in the echo, she had a mitral annular disjunction, and it was proven in the MRI. So now I have two entities. She had polymorphic PVCs in the holter, and actually, I have a problem because I cannot assess the risk. In combination, long QT type 2 with mitral annular disjunction. How would you proceed?
I'm thankful that I'm not the one that has to proceed with this. But I mean, basically, I mean, almost like based on her QT alone, you pretty much have
Well, now
Almost.
with Mexilitine, I'm below
You've shortened
500.
up, or yeah.
That was my first thought to minimize to reduce the QTC. So I'm about 480.
Yeah, yeah.
She has less PVCs in the Holter. I implanted a loop recorder, but I am really not really fine with it because I don't know if she has really a high risk in combination of this both
Of
things.
the drugs, yeah. That's a tough one. Does she have an MRI?
Yes, it is proven in MRI that she has mitral annular disjunction.
And then she has fibrosis?
Yes.
Ugh.
And she is 14 years old, polymorphic.
And your QT was 520 to start with?
520, and the initial, when she presented with
so
the genetic.
Yeah, I think when you add the age to all of those risk factors, I really worry about that patient. And so I wonder about the role of sub-Q ICD. I know Peter talked about whether or not those patients screen. So I think one way to feel like, okay, we didn't put an intravascular device, but we still have some protection of sudden cardiac death, knowing that most of her arrhythmias will likely be VF or polymorphic anyway.
Well, she's long QT type 2. Perhaps she will need also with high risk, with high medication, atrial stimulation.
Atrial-based pacing, perhaps. Yeah,
yeah. I didn't. Yes, I didn't.
That's a tough
know
one. Yeah, that's a tough one.
I had a 16-year-old for that. I'm really, really alert because he had mitral valve disjunction in the MRI, and he had couplets, and he was on beta blocker, and he died at home.
Oh.
Never had syncope or really high arrhythmias documented. And I didn't know if I underestimate in these adolescents or in these young people the risk.
Yeah, I mean, it's risk prediction. At the end, you know, it's not a 100% tool to rule patients in or out, but it's the best we can do. Yeah.
Thank you very much, Professor Shadi, and we're impressed as always.
I think Dr. Wael have a question here.
Doctor,
can you deliver the mic, please?
I didn't see. Sorry, Dr. Wael, I didn't see you. What are
knowledge between the synchronization of the LV, the conduction time, and the mitral regurg itself, the actual mitral regurg. Or in other settings. Yeah. Yes.
Yeah, so I think it's very patient specific, so I don't know cutoffs, but I've definitely had patients where either they have RV apical pacing or left bundle branch block, and we resynchronize them, and the MR disappears. Definitely. I've seen it in some patients over the course of months, but I have at least 2 anecdotes of overnight. The MR completely goes away. So I feel like there's 2 patterns of, the way I see it, there's 2 patterns of LV dysfunction that happens as a cause of dysynchrony. Some patients that have a preserved cavity size, preserved LV thickness, but extremely, extremely dysynchronous. And then others that as a result of the dysynchrony become dilated and cardiomyopathic and dysynchronous. In the former subgroup, I see those as the ones that respond the quickest to resynchronization. And for the same reason, that's where we see most of the MR resolution. And so in fact, in most of the classic CRT studies, the data suggests that MR resolves sometimes before LV recovery, just by resolution of dysynchrony. Even before the LV remodels and improves, or reverse remodels and improves, we see resolution of mitral regurgitation. So certainly, yeah. 100%.
Would you consider in the mitral valve prolapse patients doing them a study to see if
the problem is in most of those patients with a narrow QRS we can't make that even better. I can't imagine that we can improve synchrony beyond the narrow intrinsic QRS. But yeah, thank you. Thanks for the question.
Yes, please, another question. as we are known to be an endemic area for rheumatic fever, does the damage caused on the mitral valve has any mechanism for arrhythmia by mitral valve prolapse in such patients?
So personally, I haven't seen ventricular arrhythmias as a consequence of rheumatic MS, even in patients that were previously repaired. And it seems like it's less to do with the leaflets and more to do with the apparatus at the level of the annulus and the base of the left ventricle. And so I don't know, to be honest, specifically as it relates to rheumatic fever. I think less likely as compared to mitral valve prolapse that's a collagen disease as opposed to a deposition disease. Yeah, thank you. Thank you.
I know the discussion is very interesting. You are eminent, and so we want to talk a lot now.
I'd like to invite again Dr. Maria Gonzalez for the next talk. Dr. Maria Gonzalez, Senior Consultant Pediatric Cardiology in University Medicine Mainz in Germany. She will talk us regarding Brugada syndrome in pediatric patients.
Thank you very much. So now I will start with my first lecture on pediatric Brugada syndrome. I would like to start with this ECG. It's from a 3-year-old girl, tachycardia lasting since 30 minutes. She has a history of fever due to respiratory infection, and we see a wide QRS tachycardia with inferior axis and left bundle branch block morphology. The heart rate is 260, and during the IV access, patient vomited, and the tachycardia spontaneously terminated. And this ECG was performed a little bit later on, and we can see that there is in V1 an incomplete right bundle branch block here, a little bit curious looking like. The colleagues thought that it was SVT with aberrancy, but on the next day she had another VT, wide QRS complex tachycardia. She got electrical cardioverted, and we see now that immediately after cardioversion in the right precordial leads, we see this typical cuffed ST segment in V1 that is very suspicious for Brugada syndrome. So Brugada syndrome was first described in 1992 by Pedro and Joseph Brugada, and they published 8 individuals that were resuscitated from sudden cardiac death caused by ventricular fibrillation, and 3 of them were children. And they found an association between right bundle branch block, persistent ST segment elevation, and polymorphic VT. And they also described other arrhythmias like sinus syndrome and atrial flutter. And in 2017, this entity was first described in the Philippines, and this was the same entity with sudden deaths in apparently healthy young males, and that took place during night. And since 1997, it is so that the Brugada is the same entity that it was first described in 1917, and only anecdotal, unlike the WPW syndrome, there are other synonyms for Brugada, like in Thailand it's called dream disease, and in China it's called sudden manhood death syndrome. So Brugada syndrome is a channelopathy that's characterized by a pathognomonic alteration of the ECG and is associated with increased risk for sudden cardiac death due to VT or VF, and it's in individuals with structurally normal hearts and predominantly during sleep. And since 1998, there is an association between symptoms and loss of function of the SCN5A gene that could be found in 20 to 25% of the patients. And this gene codes for the alpha subunit of the sodium channel, and this defect shortens the action potential due to reduction of the sodium and calcium input current, confined epicardial to the epicardial layers of the right ventricular outflow tract. And there's probably also repolarization disorder with an increased outward potassium current and leading to a transmural voltage gradient. And this effect can be enhanced by testosterone. So in adults, the prevalence is 1 to 2,000, and it has been considered responsible for about 4 to 12% of all sudden cardiac deaths and 20% of sudden cardiac death in structurally normal hearts. It is 8 to 10 times more prevalent in men than in women. And in the pediatric population, the prevalence is unclear and low. It is also responsible for sudden cardiac death in children and adolescents in an unclear extent. And there is no sex difference, and fever is most important precipitating factor for ventricular arrhythmias. For both, the symptoms are the same: syncope, seizures, nocturnal agonal breathing, palpitations, and in adults, sudden cardiac death is the first symptom in more than 4%. In a survey of a pediatric electrophysiologist that was published by Harris, the most common initial presentation was due to positive family history and because of incidental ECG findings, so that more than 70% of the children with Brugada syndrome were at diagnosis asymptomatic. The symptoms could be syncope in 14%, arrhythmias, and aborted sudden cardiac death in 1%. Other observed arrhythmias were sinus node dysfunction, atrial arrhythmias like focal atrial tachycardia and atrial fibrillation, and interventricular conduction disturbances. The diagnosis of Brugada syndrome is based on the ECG, showing type 1 ECG as this morning was presented by Dr. Radiana and Dr. Rana. We see a typical ST segment elevation of 2 or more millimeters in 1 or more right precordial leads, right precordial leads. And this is followed by a very straight descending ST segment that crosses the isoelectric line and is followed by a negative symmetric T wave. Patients can also present with a type 2 ECG or a type T3 ECG. Both types are not diagnosing Brugada syndrome, but it's highly suspicious for Brugada syndrome. In type 2, we have ST segment elevation of more than 1 millimeter, and here a saddle-shaped flat, and it's followed by a positive T wave. And in type 3, we only have a small ST elevation in V1. So that the RVOT is the pathophysiological substrate. So you can make this the ECG more sensitive by higher lead placement, and from the V3 and V6, and this is now from this year from the European recommendations. They call it to make it uniform, place now V3 and V4, one above V1 and V2, and V5 and V6, especially two above, in the second intercostal space. So this ECG, it's I think more than 8 years ago. That's from a 9-year-old girl. She had syncope during sport, and she had here in V1 is very suspicious in V2, but if you look at V5 and V6, you have a really clear Brugada cuffed ST segment, and this was placed one intercostal space above V1 and V2. So the criteria for diagnosed Brugada syndrome is when you have spontaneous type 1 pattern, you have Brugada syndrome. If you have a type 2 or type 3 pattern, then you need and it converts in with a pharmacological provocation test in type 1 ECG. Then it's important to know if the patient have symptoms. If you had symptoms, then you have a Brugada syndrome. If you have only conversion in type 1 without symptoms, then you only have type 1 Brugada pattern. In children, the type 1 pattern is more easily induced by fever. It also reduces the function of the sodium channels and can unmask the Brugada ECG pattern, like in this case. So when you're suspicious of a Brugada syndrome and the ECG seems to be normal, well, it's here not really normal. We have slow conduction, ventricular conduction delay. You say that when the patient has fever to document an ECG, and this is the same patient with temperature over 38 degrees, and we see in this form a fever-induced type 1 ECG. To perform the pharmacological provocation test, there are sodium channel blockers that can be used with this specific protocol. We use usually ajmaline because of the short half-life time. And you can here see the ECG of a 12-year-old boy with a syncope and a it's a type 3 ECG that converts into a type 1 ECG after 0.4 milligrams per kilograms ajmaline very nicely. There are these completely new recommendations regarding the implementation of pharmacological provocation tests. If possible, you should perform an ECG during fever with high precordial leads. It's actually not indicated in patients with family history when the patients are asymptomatic or don't have any ECG abnormalities. But if you do this provocation test at the age below than 16 years, and if the test is negative, but you are still suspicious of Brugada syndrome, you must repeat this test with 16 years of age. So there is the Shanghai score that is also used for diagnosis, and the diagnosis necessarily requires one ECG finding, which is evaluated with different points. And there are points for clinical history, family history, and for the genetic tests. And if the sum of the points are greater or equal to 3.5, then you have most probably definite Brugada syndrome. Pathogenic variants of SCN5A genes has been found in about 20% of Brugada syndrome patients. In 40% of familial Brugada syndrome patients, the penetrance can be incomplete, and non-carriers of the variant may show positive provocative drug challenge due to this complex heritability of Brugada syndrome. In the pediatric Brugada syndrome patients, the variant carriers is a higher proportion. Brugada syndrome in absence of SCN5A gene variant is largely polygenic, and pre-symptomatic genetic testing in children with familial known pathogenic SCN5A variants can be performed, and the result can guide the recommendation for the follow-up. But the main problem is still always to know who is at risk and who really needs an ICD. And there is now a scoring system that was developed for the pediatric patients into different risk levels, and this clinical score algorithm shows a high predictive power, The high-risk markers in children include syncope or cardiac arrest, sinus node dysfunction, atrial tachycardias, and conduction abnormalities. And children with a high-risk score of more than 6 points had almost 50% of recurrence of potential lethal events within the next 5 years of presentation. But this algorithm needs validation in extended cohorts. But how should we proceed with children with possible increased risk? Does the implanted loop recorder perhaps help us? I already told that I'm really friend of implanted loop recorders. And this is an interesting case. From 13 countries, they implanted in 147 children a loop recorder. 80 of them were asymptomatic, and 67 had symptoms, and from them 46 had syncopes. And they had a median Shanghai score from 4.5, and after a median follow-up of 3.5 years, they saw that about 22% had arrhythmic events, and these arrhythmias, however, were bradycardia and atrial tachycardia, and only 4 patients had really ventricular tachycardia. And they concluded that the 4 patients with ventricular tachycardia that were symptomatic before and had spontaneous type 1 ECG, so these are risk factors for it. How it's the therapy, the main problem is the fever suppression, in-hospital admission for rhythm monitoring, avoidance of Brugada syndrome inducing drugs, and avoidance of large meals with high carbohydrates and excessive alcohol. And when Brugada syndrome patients present with ventricular arrhythmias, only rhythmic treatment is isoprenolone, amiodarone, and sodium channel blockers are contraindicated. In monomorphic VT, beta blocker may help. ICD implantation is, as the guidelines just told before. As a 2A indications, it is when patients with type 1 ECG present and had definitely arrhythmogenic syncope. Shinidine is, the data in children are very small, and for the ablation therapy, we don't really have short and long-term results in children, but it may help, like in this case. This is a 6-year-old boy with fever-induced monomorphic VT. Always when she had fever, he has this. And he had a positive Ashmolean test, and we went into the cath lab, and we had a perfect their pacemaker, and we were 36 milliseconds local preceding the QRS, and we ablated in the RVOT outflow tract, and he had an implanted loop recorder. Since then, he didn't have any other event. It may help to be for a while asymptomatic. He has genetic testing, and he has multiple polymorphism in SCN5A genes, but multiple. I think it was 5 different types. So we are highly suspicious that is something, but he's doing at the moment fine. So my take-home messages are that execute ECG with high lead position and in situations with fever to see the Brugada type ECG types. Early fever treatment and hospital admission for ECG monitoring is mandatory in Brugada patients. Brugada patients with symptoms and spontaneous type 1 ECG have higher risk for ventricular arrhythmias. An implanted loop recorder may help to identify arrhythmias in this population. And children with negative pharmacological provocation tests before puberty need to be retested after the 16 year of age. And it is important to continue the follow-up over time, especially after puberty. And in Brugada syndrome patients with increased risk for ventricular arrhythmia, the indication for ICD implantation should be made individually and by experienced pediatric cardiologists. And I want to show you, this is the map of Germany. I am coming here from Mainz. Mainz is over here. That's a region with nice wine, red and white wine. And the city where I come from, I think it's 100 from your mega city here. You know, it's very, very small, you can see here. And everybody who wants to visit me is welcome. Thank you.
Thank you very much for all the interesting discussion today and your interesting 2 topics. We are very short of time, overdue, so we can postpone the question for the next session. By this, we can conclude our session. And thank you very much for your generous offer, by the way, to visit you. We conclude our session, and we're open for the next session. I think it's coffee break now. Thank you.
We will have a 20-minute coffee break on the right side of the hall, and you can find also a gift for you in the first floor in the registration desk. Thank you so much.
will invite moderators and chairpersons to this session. Okay. Okay, our first talk in this session for my friend, Dr. Michael Sobhi, Professor of Critical Care and Electrophysiology in Cairo University, and now is consultant EB unit Qasimi Hospital in United Arab of Emirates. Talking about leadless pacing in pediatric and adult congenital heart disease.
Good afternoon, dear professors and dear colleagues. Thanks a lot, Dr. Mohammed Salas, for this generous introduction. And thanks a lot, dear honored professor, chairing this session. And I'd like to thank the scientific committee of the EPAC for inviting me to chair in the scientific agenda. That gives me great pleasure. Well, despite its intended initial application of the leadless pacemaker system for a special patient population, which are the elderly or those who have multiple associated comorbidities or vascular challenges. However, the increased familiarity and the increased confidence and reliability in terms of efficacy and safety from application of this system over a wide range of population over the past few years has led to opening new horizons and new scope for expansion and extension of the application of leadless system in other patient populations. Over the next few slides, we are going to try to focus the light about what is the current evidence we have so far regarding application of leadless pacemaker system in the young, pediatric, and other congenital heart disease. So our agenda will be why do we need leadless pacemaker in the pediatric? What is the pros? What is the cons? We'll go rapidly through the tools and techniques, and finally we'll go with the evidence base for leadless pacemaker in the young. Where do we stand currently, and what does the future promise for? As we all know that the leadless pacemaker have entered the market in the middle of the last decade, and it was initially by the generation of the nanostom, which was shortly recalled. However, this was followed by multiple generations from different manufacturers, including the Micra series by the Medtronic, Micra VR, Micra AV1, and the Micra AV2, as well as from about the Aver VR and Aver dual chamber, the wide CRT, and lately by the Boston Scientific, the Empower system. And as per 2023, there was over 200,000 leadless pacemakers that have been implanted worldwide, according to the literature. And despite that, the guidelines limit the use of leadless pacemaker for this type of patient who are challenging vascular or have high risk of infection, like hemodialysis patient or elderly. However, physicians all over the world have adopted the use of the leadless pacemaker over a large number of patient population and beyond this indication, and the increase of this system was markedly progressive over the past few years, with multiple randomized control trials that has showed and proved safety and efficacy of this system. But what about leadless pacing in the pediatric? Of course, children are not adults. However, leadless pacing may be particularly attractive in this patient population in order to avoid the risks that's associated with complication of the conventional transvenous system. And here comes a feared equation. You start early life, implant pacemaker in a child, and this is multiplied by expected long lifespan. This all augment the risks and complication that could face this child over his lifespan from the system generation and the presence of the leads transvascular. Lead-related complications include vascular compromise. As we know that the leads can induce mechanical stress and endothelial injury, especially in a small growing blood vessels, and this risk, of course, increases with increasing the length of the duration that leads remains in the system, with incidence up to 18% over 10 years follow-up in the literature of venous obstruction. Second risk of the conventional transvenous system is lead-related tricuspid regurg and lead failure, which is particularly important in this patient likelihood to happen due to the nature of this patient being highly physically active, more active lifestyle, and increased risk of exposure to trauma. And in a large Italian registry that was done over 292 patients that were followed with conventional transvenous lead system over a period of 12 years, it was found that the lead survivor for the endocardial lead approached 0.75 at 12 years, and for the epicardial 0.5. Last but not the least, complication of the conventional transvenous system is infection, which is related to the leads itself or the generator, and of course this risk of infection increases each time the system is replaced. Such infection risk is much less in the leadless system, of course, given to the, we can say, the innate protection of this system being already no handling, it comes already loaded to the system, delivery as well as small size and no generator, and it's present within the turbulent blood flow and the encapsulation. All these factors make the risk of infection in the leadless system much less than the conventional transvenous system. Despite all these advantages of the leadless pacemaker system, however, leadless pacemaker system also have cons. And the other option would be to do for extraction for this leadless system, which is possible. However, it's a complex and risky procedure. However, there is available literature which show successful retrievability of this system. And a fact is that this challenge for the leadless pacemaker is the noticed longer longevity of battery lifespan of most of the leadless system. Was in some generation it reached up more than 20 years. So the need to do repeated intervention is much reduced with the leadless system as opposed to the conventional transvenous system. The second challenge is the limited ability of this system to do proper synchronous AV synchronization. In the initial generation by Micra, it was up to 115, the upper tracking rate, and in the newest generation, Micra AV2, it reached up to 135, thanks to the auto PVAB algorithm. A third challenge, of course, which is important, is anatomical challenges. Unfortunately, we don't have dedicated leadless systems that is manufactured for the child or pediatric, and use such large different size of leadless pacemaker in a small vasculature and small RV cavity puts some challenges. What are the tools and techniques pre-procedure? Apart from ensuring the proper patient selection indication, imaging has important role for implantation of leadless pacemaker among the children and adults, especially CT. You must have a good knowledge about the anatomy of the patient, exclude any associated congenital anomalies. Duplex ultrasound assess the size of the vascular axis, whether it will accommodate the teeth or no. Intra-procedure, you have approach or femoral approach, and whether you are going to do this through a venous cut down or through percutaneous graduated dilatation. During the procedure, fluoroscopy, of course, is a real-time visualization gold standard to show you the proper site insertion. Also, it's advised to do right ventriculography to make sure you achieve proper mid-septal position in order to avoid the risk of perforation. I'd like to show this case. We implanted jugular approach because, as we know, this jugular approach is the most common in the children and young patient population. You go with gradual dilatation through the jugular approach, starting by 4 and increment by 2 to 4 French each time. Important to do this movement very cautiously by a rotatory movement in order to avoid any vascular perforation. And then you insert the Micra delivery system at the junction between SVC and right atrium, and you replace with the Micra deployment catheter, just to this gentle unsheathing to avoid any perforations. In an RO projection, you have to check crossing the tricuspid valve, which will be through gentle counterclockwise movement, and you will be directly opposing the septum. You should confirm by doing ventriculography to make sure you are acquiring a good mid-septal position, and of course confirm in LO projection that you are opposing the septum properly. And once you are confident with the site, do delivery for the system, and you then, after ensuring proper electrical parameters, you will do test for stability, the tug test. You have to make sure that at least 2 of the tines are properly fixed with this nice opening and closing movement with the tugging. And finally, you cut the tissue and the system is implanted. What is the evidence base for leadless pacing in the young? Unfortunately, exemption of children from most of the clinical trial, this has created some sort of uncertainty about the efficacy and safety in this patient population. However, there is available case series, and the large to-date case series that's followed child, patient, and pediatric with leadless pacemaker system, where it included 15 centers with 64 4 patients implanted by the Micra system among below the age of 21 years old. 30% of these patients were below the age congenital heart disease, and 8 patients were under the age of 8 years and below 30 kilogram, and 80% of those who are less than 8 years were implanted through a jugular approach with good performance and good results and low incidence of complication as low as 4.5%. Another case series looks for the AVER system implantation in the young children population, where 10 patients less than 21 years old have successfully implanted 90% of them through the jugular approach, 10% the femoral approach, no complication reported, and happy to say that the battery longevity in this patient population is approaching up to 23.5 years. Of course, it depends on the percentage of pacing, but this is good battery longevity results. In a recent UK expert consensus statement published by the British Heart Rhythm Society regarding leadless pacemaker indication, 100% of the voter voted to use leadless pacemaker in special patient pediatric who have special congenital heart disease, and 78% has voted to consider leadless pacing in those who are under 40 years of age. What is the evidence regarding jugular approach for this patient? Initially, it was just case report reporting about successful implantation of either the Micra or the AVER in young patient population, pediatric 19 kilogram or 18 kilogram, and this was followed by case series where this case series from the United States, it showed that 8 patients below the age of 30 kilogram, they were all successfully implanted using jugular approach, 5 by right jugular and 3 through the left jugular, with just 1 case of pericardial effusion, which is, of course, a risk perforation is high in the pediatric and children. So the evidence so far is that leadless pacemaker in the pediatric is particularly suited for those patients, of course, who have anatomical constraints, whether hemodialysis or vascular stenosis, and special patient population of the pediatric deserve considering leadless pacemaker. Those patients who require infrequent pacing, but they were required for many decades of life, including the cardio-inhibitory vasovagal syncope. And of course, management of this patient is a little bit challenging. I guess my colleague, Dr. Ahmed Tahir, will discuss the next session. These patients have the problem that most of the studies have excluded patients who are under the age of 40 years, who don't have solid data. However, pacing in this patient is important because it prevents profound episodes of bradycardia or asystole, which may be associated with severe morbidity and bad quality of life. And another issue is that this condition may improve or resolve with time. So leadless pacemaker offer a golden solution for this patient, offering longer battery longevity with expected low percentage requirement. And condition also may improve or resolve with time. So you have the option to just program the pacemaker off and leave it in place without need for extraction. And all of this with preserving the vasculature in such young population. In a trial that looked at 12 centers, 32 patients below the age of 40 were implanted with Micra for vasovagal syncope, and over a period of up to 3-4 years of follow-up, 87% of the patients were free from symptoms. Another special patient population among the young that deserve going for leadless pacemaker is patients who have neuromuscular disease, where guidelines recommend going for a permanent pacemaker in this patient who have associated second degree or third degree, even if they are asymptomatic. And again, leadless pacemaker offer a good solution for this patient, being asymptomatic and young, and just having the system for backup pacing in case of profound asystole. Third special group, of course, is adult congenital heart disease, and this patient may have relative high need for pacing as a result of complication for the surgical correction for this patient or as a part of the natural history of the disease. Pacing may be challenging in this population due to precluded vascular access, and there is also a consideration regarding the risk of infection in this patient who have usual prosthesis or synthetic graft. So again, leadless pacemaker in this patient population provide less risk of infection and possible inferior approach away from the superior approach on those patients who have precluded vascular access. Multiple trials have looked for leadless pacemaker implantation in adult congenital heart disease, or both Micra and the AVER system. I'd like to present this patient that we managed to implant for him, leadless pacemaker transfemoral. He's 47 years old, adult congenital heart disease, surgical collected fallow. Patient have intermittent AV block. We went through the transfemoral, and after crossing the junction between IVC and the right atrium, the micro deployment catheter has passed through the tricuspid valve. Initially, this was a rather apical position, so we tried to search for a more higher mid-septal position. Make sure you have this gauze neck that you have good force over the septum, checking LO, and after making sure that you are in a good position, system is deployed. Again, check for electrical parameters, and if everything okay, you will go for the tuck test to make sure for the stability of the tines. More than 2 tines is fixed to the endocardium, and you can take this position. What is the future for leadless pacemaker is to go beyond just limited patient population to make it more. Just a couple of minutes. Okay. In order to improve quality of life, as well as less physical constraints that's associated with leadless system, preserving vascular patency and mitigating infection risk, the expected longer, better life, as well as the cosmetic aspect, being having no surgical scar on the chest wall, all this may make leadless pacemaker attractive to all ages, including those young population. I'd like to share our experience, but it's mainly in adults. However, some data can be projected about the efficacy and safety of this system. With more than 400 cases implanted since 2015, we have a rather accepted rate of complication about 1.5% between DVT as well as in rising threshold with need for system retrieval. So to conclude, ladies and gentlemen, despite recent technical progress, pacing leads remain the weakest link of the permanent pacing system, particularly in young and growing patients. There are several perceived benefits of leadless pacemaker, which include avoidance of long-term leads in the vasculature and across the tricuspid valve, reduced generator change, absence of visible device in the chest wall, and low infection rate, particularly attractive in the young population. Experience with this system in the pediatric is still novel, whether the femoral internal jugular venous approach. However, it's growing. Special patient populations that may be considered for leadless are those with cardiac inhibitor syncope or other congenital heart disease or neuromuscular condition with conduction abnormality. And finally, remains the challenge how these systems are going to be managed at the end of the battery life. I'd like to conclude my talk with this literature about pacing in the infant and children dated 2010, before the era of leadless pacemaker, where the author were writing about the problems that's facing the conventional transvenous system, and he was looking at the future, saying that the holy grail for pediatric implanters, however, is a reliable leadless device, with the hope that ongoing development in wireless communication may make the leadless pacemaker reality in the not too distant future. Thank you.
Thank you very much, Dr. Michael. It's always a pleasure seeing you, and very excited to accept our invitation. For the sake of time, we will postpone questions till the end of session. Thank you very much for the presentation, Dr. Michael, again. So it's my pleasure to introduce the next speaker, Dr. Shadi Nakhla. He's already becoming a very dear friend of ours and renowned expert in the field of pediatric arrhythmia and electrophysiology. He's going to give us a lecture about updates on conductive system pacing. On to you, Dr. Shadi.
Thank
you very much for being here.
Adult electrophysiology. Me, I'm not a pediatrician.
And adult.
Okay. Yeah, I'm only adult. That's okay. So, every year we've been talking about conduction system pacing as a modality of pacing, both in adults and pediatrics. I want to spend some time reviewing some of the concepts we previously discussed, but then also review some of the newer evidence and pitfalls related to this type of procedure. And so this is a 31-year-old patient with congenital AV block who did well for most of his life. He had a dual-chamber pacemaker implanted in his 20s. He developed pacer-induced cardiomyopathy. He had a prior infected epicardial system, and then locally he failed a CS lead addition and was referred for a CRT upgrade. As you can see here on his echocardiogram, he has kind of apical rocking and clear evidence of dysynchrony. His ECG looks like RV apical pacing. And so what we did is we added a conduction system pacing lead. His LV chamber shrunk in size, and you can see his apex is beating in a much more synchronized fashion with a nice narrow QRS and evidence of conduction system capture. And so really, I think that there are three keys to a successful implant. One is that there's still a conduction system to be captured. Another is a technical and procedural aspect. And then finally, adjudicating that we actually have capture of the conduction system, I think, is the most important aspect of conduction system pacing. And I want to spend most of the time today covering that topic. So there are, like I said, a lot of technical considerations intra-procedure, but the most important is looking at your paced QRS and understanding whether you truly have conduction system capture. And this is important. So we published this study out of the Cleveland Clinic this year, where we looked at the incidence of pacing-induced cardiomyopathy in patients who had attempts at left bundle branch area pacing. And it turned out that your chances of developing pacer-induced cardiomyopathy were higher if you had an attempt at a left bundle branch area pacing lead, but you didn't end up capturing the conduction system and you were only capturing the deep septum. And one of the biggest predictors of that was whether or not you had stim to peak in V5 and V6, your LV lateral wall activation, that was greater than 80 milliseconds. And so really it becomes clear that capturing the conduction system when you're attempting to implant a left bundle branch area pacing lead is of critical importance. This was another study that was published this year that looked at patients with LV dysfunction. So this was a group of patients that either had pacing-induced cardiomyopathy or left bundle branch related cardiomyopathy. They had conduction system pacing leads implanted and they recovered their EF. And they followed them over time to see if their ejection fractions decreased. And what they found is that about 4% of patients in the study, despite achieving resynchronization and improvement in their ejection fraction, subsequently had a decline in their ejection fraction in the future. And this happened because of a variety of reasons. And so you'll look on the side here that in some patients there was suboptimal AV delays, and that means that conduction down the native right bundle beat their conduction system pacing, and so they never actually achieved adequate cardiac resynchronization. They had atrial fibrillation that preempted pacing. They had other reasons like coronary disease that resulted in LV dysfunction. But really the most common reason why those patients developed recurrent LV dysfunction was loss of conduction system capture. And there's several reasons why this could happen. We don't have an exact explanation, but the biggest predictor of loss of conduction system capture in the future was the lack of multiple adequate confirmatory steps at the time of the index implant that suggested conduction system capture, whether that was program stimulation, whether that was threshold testing to demonstrate that you had selective conduction system capture, being the biggest predictor of loss of conduction system capture in the future. So I hope so far I've convinced you that adjudicating and confirming that you have conduction system capture is a very, very important part of this procedure. So how do we do that? Over the past several years, there have been multiple proposed criteria to try to adjudicate conduction system capture. Some of them are very fancy, like this. Some of them are very complicated, like multiple, measuring deflections and the onset of the stim to the slope of the V6 and this and that and the other, which I'm not very smart. I have a hard time remembering these types of criteria. And then other people that set their patients up with ultra-high fractionated ECGs. And so I think from a practical standpoint, a lot of these criteria are nice for research, but difficult in clinical practice. And so I'll tell you kind of what I do on a day-to-day basis. So this is an example of a stylet-driven lead that's being advanced from the RV septum toward the conduction system. And we're pacing as we're advancing the stylet-driven lead, and we see multiple things. I'll draw your attention to lead V1, where you initially start with this typical W pattern. Then that R wave starts appearing on the far end of the screen, suggesting that we're starting to get close to the conduction system, and perhaps we're already there. The other thing that you notice is that this beat is actually not paced. This beat is a fascicular PVC that is triggered by the tip of the lead as we're advancing it into the septum. So this is sort of like a capture beat. So now a couple of criteria we're already seeing that suggest that the morphology is changing as we're advancing the lead. We're seeing a capture beat here from the lead as we're advancing it into the conduction system. Then I'll pause and check measurements. Before we advance the lead, the LV activation time along the lateral wall is about 120 milliseconds. At our final point, we have about 78 milliseconds from stimulation to the peak in V5 and V6. The QRS is narrow. It has a QR pattern in lead V1. In certain cases, but not all cases, on intracardiac recordings from the lead, we can see a type of conduction fascicular potential that precedes the local QRS during ambient sensing. The other thing that we see during threshold testing, so from left to right, what happens here is we're going down on the output of the paced lead, and we see a change in morphology from QR to RSR prime. What also happens during that change in morphology is an increase in the time that it takes from the stimulus to the peak of the R wave in V1, with no change in the time that it takes from the stimulus to the peak of the R wave in V5 and V6. And so what this means is that as I'm lowering my output, I'm still selectively capturing the conduction system. I'm still able to get out to the lateral wall of the left ventricle very quickly, but it takes me a longer time to depolarize the septum to develop this R prime, because I'm going out of the lateral ventricle because I'm selective in the conduction system, and then coming back cell by cell to depolarize the septum. So this is another method that we use to ascertain selectivity. What you also see during threshold testing is that as you lower your output and you go from this QR pattern to this RSR prime pattern, there's a jump of the local myocardial EGM, because we're only capturing the conduction system without the local myocardium. You can further leverage the differences in conduction properties of the myocardium and the conduction system with different pacing drivetrains to demonstrate whether or not you're truly capturing the conduction system as an additional method for us to adjudicate conduction system capture. So far we've demonstrated that there are several criteria that we can use to adjudicate conduction system capture, but several questions remain. Is this feasible? Does it provide adequate CRT? And how does this compare to conventional CRT? And is there a role in patients with congenital heart disease? And so from a feasibility standpoint, this was a study that looked at pacing in patients with a normal ejection fraction, but having some evidence of conduction abnormality. And what they found is over a 90% success rate at achieving conduction system capture in this patient population with successful narrowing of the QRS. But does it provide adequate CRT? So this here was a prospective study, multi-center, that looked at patients with traditional pacing indications for cardiac resynchronization, so either pacing-induced cardiomyopathy or left bundle branch block. And what they found is that indeed you're able to resynchronize the ventricle, you're able to improve the ejection fraction and to develop a sustained response in LV ejection fraction improvement. Now, how does this compare to conventional CRT? Several studies are now suggesting perhaps superiority to conduction system pacing over CRT, but this has yet to pan out in multiple large center prospective clinical trials. Now, more recently, this has been studied in patients with congenital heart disease. All of the patients in this study had biventricular systemic left ventricles. Most of them had tetralogy of Fallot or septal defects. And in this patient population, achieving left bundle branch area pacing was indeed successful and seemed to do better than conventional CRT over time. And so in summary, what I'd like to say is that left bundle branch area pacing is feasible, it is safe, and it is effective. It's really, really, really important to obsess over parameters and pacing maneuvers that confirm selective capture of the conduction system. I think this is an important pacing modality to consider in patients with left bundle branch block, patients with pacing-induced cardiomyopathy, a narrow QRS, and a normal EF. So the classic example from a pediatric standpoint would be congenital AV block. I would consider pausing or reconsidering in patients with infiltrative cardiomyopathies, patients with septal scar, ischemic patients, certain variety of congenital heart disease, but also patients where based on the QRS you could be suspicious of both conduction disease and myocardial delay. Those patients may benefit from what's called LOT CRT, so conduction system pacing and CS pacing at the same time to overcome their conduction delay and their myocardial delay. And as we just showed, that pediatric patients may benefit from this in limited case series. And with that, I'll say thank you.
Thank you very much, Dr. Shadi, for the presentation, excellent presentation. Again, we are still under pressure of time. So again, we will postpone. Please, if you have any question, write it down. We will open questions and discussion at the end of this session.
Okay, it's my pleasure to introduce Dr. Mohammed Al-Maghawi. He is going to talk to us about lead extraction, team, training, and equipment. Originally, this was Dr. Amir Abdulwahab's, but he's unavailable for now. So please, Dr. Maghawi, تفضل.
مساء الخير. Good evening, everyone. I haven't really changed the title of my talk because it was kind of overarching the three main themes, which are the ventricular arrhythmias, which is the next session, and the channelopathies, which was the last session, and the lead management in this session. So I would like to thank Dr. Ahmed Al-Siheli. He actually helped me in preparing these slides, so thank you. And we just go for a case, we're just going to discuss a real-life case of a Jervell-Lange-Nielsen syndrome patient. And as we go through the case, I would like to have your opinion of what to do next, and also we will come across the lead extraction points. So Jervell-Lange-Nielsen syndrome was first discovered or coined by Anton Jervell and Fred Lange-Nielsen in 1957 as a prolonged QT interval congenital deafness and high incidence of sudden cardiac death in early childhood. And it's a bit different than what I like to call the Western long QT syndrome because it's more we will find it more in Egypt and in the Middle East because of the consanguinity, although it's rarer in worldwide. However, it's actually not very rare in Egypt, and we should all be quite aware of it. And we actually, as Egyptian electrophysiologists, we can claim that we actually have a bit of experience regarding this particular type of long QT syndromes. So it's usually caused by a KCNQ1 mutation, and again, as it's quite common in Egypt because of the consanguinity, the disease is unfortunately largely unrecognized by ENT specialists, and usually the children will present first to a neurologist, as the main presentation would be fits and seizures. And usually after two siblings that die because of seizures, someone would say, okay, let's do an ECG and see if that patient has something related to the heart. However, that actually, as it creates challenges, it also creates opportunities because as it's an autosomal recessive disease, it has about 100% penetrance, and it has extracardiac manifestations, so it's actually easy to screen. You don't need fancy equipment to learn that your child has deafness. So, and it's also monogenetic, so it's easy also to trace the genetic linkage. So it's actually, we should be doing more research regarding Jervell-Lange-Nielsen syndrome, and that's what Dr. Tariq and myself used to do in Aswan Heart Center, where we used to work there. I did this research about 10 years ago. We collected about, totally so far we have about 25 families, but at night time we had only about 14. And you can see the complexity of the consanguinities, cousins marrying cousins, and then their sibling, their offspring marries their cousins, and then their siblings marry their cousins. So you end up with significant genetic mutations, and you have the longest QTs that you can actually see. As Peter has mentioned, you will see QT intervals of 600, 650, 700. And in Peter's in Peter's presentation, he was mentioning the importance of recognizing T-wave alternance, and you can see in this patient, he has actually T-wave alternance. Can I I'm not sure if this pointer works. Yep, so you can see here, or in V2, you can see this positive T wave. This is actually the T, not the P. And you can see this is a very long, very, very long QT. And then you have a positive T here and then a negative T here. Anyway, so I'll just move on because we need to focus on the lead extraction bit. So again, very long QTs. So we had this program where we collected the patients and we started to actually look at the natural history of these patients. So we have learned few things through the years, Dr. Tare and myself. So what we learned is that all patients had, of course, profound congenital bilateral sensorineural hearing loss. That cochlear implant, the fact of implanting the cochlea was actually associated with higher risk of arrhythmias during the time of the cochlear implantation, and that's important. Because if a patient comes to you after the cochlear implant, and I believe Dr. Rania and myself, we shared this patient who already has the cochlear implant and her QT is about 500 and she's doing quite well. She does not need an ICD anymore because she passed the difficult part of having the cochlear implantation. So she's kind of already, we know that she has a low risk because of that. And that not all syncopes are associated with cardiac arrest. And usually some of the ventricular fibrillations are self-terminating, as we see from the defibrillator interrogations. We also have learned that if you put an ICD in a child, just give the maximum joule. It doesn't really help of giving a 10 joule or 25 joule instead of the maximum joule. The patient will feel the 10 joules as badly as he will feel the 35 joules, however, or the 40 joules. However, he may not benefit from the shock. So it just delays the shock or delays the effective shock without actually reducing any of the pain for the patient. And the most important bit, what we learned is you really need to educate your patients regarding basic life support for the family. And don't underestimate the social status or the education status of your patients. Everyone is keen to learn about the basic life support. We have very underprivileged mothers who actually made their kids survive because they haven't done basic life supports for their kids and then they brought them to the hospital. So please just focus on the basic life support. This is the most effective life-saving intervention that us as an electrophysiology community and pediatricians can help can provide to our children. Moving on to that patient, where now we get to that lead extraction bit. So we have a 17-year-old male who presented to us in a NAS hospital. He had he survived sudden cardiac arrest, and he had an ICD fitted about 10 years ago or 12 years ago, and he had the battery exchange in 2019. Last shock was given, I think, in 2015. So after he implanted the ICD, by 3 years, he never had the shock. And that actually was the question of Dr. Tawfiq. Dr. Tawfiq. He had this question to Peter, what should we do regarding patients who had the ICD for a while without having an intervention? Should we if the device finishes or we have an infection, as in this case, should we re-implant an ICD or not? Anyway, the patient presents to us with this very long QT, and he has a device infection. The pocket was completely infected and the device was like half out. So we opted to do a lead extraction for this patient. So, and also, there was an eccentric tricuspid regurg, most probably related to the ICD when we did the transthoracic echo for him. You can appreciate the extent of the tricuspid regurg. What we do, and this is, I think, how we manage our patients regarding lead extractions. First thing, I call Osama. This is the most important bit. We need as many experienced operators as possible. You need all the equipment that you can have. You need people with structural intervention background. What we do is that in Al-Nas Hospital, we have a hybrid room. So we prepare the patient for an open heart surgery preparation. We have the consents that at any point we may need an open heart surgery. We present for all patients 4 units of plasma, 4 units of blood, and we drap him as we're going for an open heart surgery. And with the surgeons preparing, there's a surgeon on site. There is the heart-lung machine on site. The surgeon is not in the building. He's actually on site. He can jump in at any point. The heart-lung machine is not out in the building drinking coffee. He's on site. I think these are the most important things, at least for us. We are still learning, and it's important to build up our experience as safe as possible. We have all the possible tools, which are the lead locking stylets, the Cook dilators, and the Spectronics mechanical rotatory device. And we usually inject dye to see how the lead looks like and how fixed on the wall it is. I'll just run a few points so you can appreciate. So this lead, we managed to dilate all through till with the mechanical rotatory gun, but it's not the Cook gun, it's the Spectronics gun. And we stopped here, and you can see this is the loop from the previous implantation, which is accepted because he was a small child and it was a big lead, so you expect a lot of loops. However, when the loop goes into the IVC, you can appreciate that this loop is into the IVC, so that kind of keeps the lead stuck to the wall of the IVC, and that makes it very difficult to extract, and it can be very dangerous as well, because if you tear in the IVC, there's no way that this patient will survive. Because if you tear in this SVC or in the IVC, the bleeding is very quick, and you will not be able to, the patient will just lose all his blood before the surgeons will be able to cut open and do something. So we had to stop from up, and we decided just to see if we can grasp it from down. So you can see that we have a sheath from under, from the femoral vein, and we tried to grasp it, or we tried to loop it, and it just we couldn't loop it because it was really stuck on the wall of the IVC. So we tried to we called our GIT friends from the endoscopy, and they have this nice grasper, like it's like an alligator grasper, where it can grasp something and try to pull it. However, it was stuck, and there was no loop, no free part of the lead that we can grasp on. At that point, we decided to stop. And we decided that this patient anyway will need surgery because of his tricuspid valve perforation. And we thought at this point, okay, what to do next? We have 2 options at this point, or 3 options. The first point is, should we, and I really need your opinion about it, should we just remove this lead surgically and fix the tricuspid valve, and that's it? That's option number 1. Option number 2, to do the same thing and put an ICD, either subcutaneous or subepicardial surgically. Number 3 is to remove the lead, fix the tricuspid, and wait and see if the patient needs a second ICD. We do it either subcutaneous or transvenous according to the tricuspid valve anatomy. Option A, just remove and do nothing. No. Okay. Option B, should we put an epicardial ICD at the same time? Yeah, okay. Okay. And option 3, remove in view of putting either a subcutaneous ICD or transvenous. Okay, so that's what we did. Also because we don't have the epicardial system, or we don't have also the subcutaneous system. We know that we do like we have invented an epicardial ICD system in Aswan, where we wrap the ICD around the shock leads around the heart, but I'm not as convinced as I was 10 years ago, because I'm worried about cardiac strangulation. Anyway, so what we did is that we decided to stop and send him for surgery. And I would like you to just appreciate how
بس في حته كالسيوم محترمه حواليها
That's the surgeon's voice. So I'm just, as all surgeons, he's quite loud.
بس في حته كالسيوم محترمه حواليها هنا ولازق جدا في الار في. وعامل بقى ديسبيسمنت للتراكاسبيد هنا، يعني عامل خارم التراكاسبيد. وريني كده دبيكي.
You see that chunk of calcium? That chunk of calcium was on the IVC. So if you imagine if we tried to pull any further, that patient would have died on table. So I think we did the right thing of not trying to go overconfidently and try to snatch that. And the surgeon did a marvelous job regarding the tricuspid valve. There was no regurg afterwards, and he had a nicely put ring. And then we decided, I was trying to find a subcutaneous ICD for this kid. I think everyone would agree that would be the best option in order not to try to avoid the tricuspid valve. However, it was pre-registration in Egypt. We waited for 2 months for the company to register it, but unfortunately they didn't register it on time. So the second question was to put an ICD or not to put an ICD altogether. Given that this man he's now 17, he has Jarvin-Lang-Nielsen. We know that these children, they do worse before the age of 5, but we don't have a lot of data about them after the age of 10. And we don't know, and he had his last shock about 7 years ago. Any thoughts?
I would vote for keeping him on beta blockers until you get the ICD done, because we know that long QT responds well to beta blocker.
But would you not put an ICD again?
Definitely will put one.
Will put one, yes. So anyone would not put an ICD, given that he has theoretical no risk. You would not put an ICD, but you are protected. You would put. He had one appropriate shock 7 years ago. Yeah, QT has slightly improved while he was in the hospital. I'll show you. Slightly improved. We put an ICD anyway, because again, this just shows us, and the reason why this presentation was actually given three different time allocation, either in the channelopathy or in the VT or in the lead extraction, is because we have a knowledge gap, a real knowledge gap in the Jarvin-Lang-Nielsen syndrome patients. The biggest publication is only 164 patients. In Egypt, myself, I have seen 30 patients. And I think among the bigger group in this room right now, we most probably will be seeing about 70. So the Egyptian knowledge is actually almost as big as the whole international knowledge in the Jarvin-Lang-Nielsen population. And there has never been a long-term follow-up of these patients long enough to really understand the natural history of these patients, because these patients usually die very young, and they have a very aggressive disease at the young age. But no one really understands the arrhythmic risk after, when the patient is like 15 to 20 years old. Tariq knows we have a patient who's in Aswan, she's 25 years old. The family refused to put an ICD for her, and she's doing she's doing fine. And she has 4 male siblings that died suddenly, but because she's she's a woman, the family does not want to put an ICD for her. That's like, anyway. It's a true story. But again, that lady is she's doing very well. So again, we have a knowledge gap. because of that knowledge gap, we had to err on the side of caution, and we put an ICD for this patient. And alhamdulillah, the ICD is doing well. I tried to kind of hook it a little bit higher than usual, so we did it with TE. Unfortunately, we don't have the image of the TE. I tried to go like right in the middle of the tricuspid, so it does not affect the ring. And he had no regurg. And with that, I conclude. And sorry for the time.
So I want to ask you, Dr. Maghauri, for your marvelous presentation as always. Did you put the ICD at the same situation?
No, two months later.
2 months.
2 months later.
Okay.
At that time, the patient stayed in our hospital for 2 months. He's a lovely boy. We brought him a PlayStation, and he stayed for 2 months playing PlayStation. He's deaf mute. He's quite quiet. He understands the lip.
Mouth.
Yeah, the mouth, like the lip movements. Yes. So he was one of our long stayers, but we waited for 2 months. The reason why I waited for 2 months, initially I wanted to wait for 6 weeks for the infection to be completely resolved, and his CRP was negative, TLC was negative, bacteremia there was no bacteremia. But the reason why I waited a little bit longer, because I was hoping that we get the registration for the ICD, the subcutaneous ICD from Boston Scientific, but it didn't come on time. So at a certain point, we had to make an executive decision, and we decided to go for the regular transvenous ICD.
This is amazing hybrid technique extraction, by the way. I want to hear just one, Dr. Maria. Dr. Maria, I want to hear your opinion about reimplantation of ICD for this patient. You want to say something, but you didn't. Yes.
I always do, when I see QTC above 500, I would put him on Mexilatin. I like that when they are very large. That shortened the QTC intervals. And then I would look, while I'm doing that, having him with a vest, with a defibrillator vest, and I would wait and see how it works with this medication on.
How long do you keep him on the vest?
For a half year.
Okay. We don't have the vest in Egypt, so what we did is that we kept him in the hospital for as long as we could.
Okay.
So
it's easier when you have the vest and you can let them go home and control under widening of the medication. I agree that they have really, really high risk, but as you said, they are off the risky time.
Yeah. Yeah, it's.
Yes, I are a big fan of loop recorder. In this patient, you could use a loop recorder for him? Thank you.
Hey, Mohammed. Thank you for the presentation. I just had a couple comments. I think the first, your experience, you mentioned the JLNS experience here, and you're right. The fact that you follow that many patients, that's going to be the richest experience I think any one clinician has had. I imagine the barriers to publishing your data are that the medical record is probably elusive. There are details that you may or may not have. Even with the information that you do have, though, I strongly encourage your team to publish it because there is a gap there. Yeah.
Most of the data is from Aswan Center.
Okay.
We now have in NAS three families, but in Aswan, because we did we had a proper program, so we have, I think, to the last of my knowledge, 25 families, maybe with 30 programs. So we have.
Yeah, it's there.
Yeah.
That's great. Yeah, please do that.
Genetic data for most of the patients, so it's becoming a complete project.
And I appreciate your comment. Maria and I were having a conversation about this earlier today. The Timothy and the Dravelli Nielsen, I feel like have this very high propensity for arrhythmias when they're born. And like you said, the ones that make it out of that, I feel like have self-selected and perhaps their risk decreases. I follow 2 TS patients that I've inherited that don't have defibrillators, and it's always made me nervous. But they self-selected.
They grow themselves, like they become like the natural selection.
Exactly.
Product of the natural selection of the
Yeah.
So if they survive after 4 or 5 years, really the risk is becoming significantly low.
They're okay. Yeah.
Well, I think just for, because I know most of the pediatricians in this room will be following at least 2 or 3 patients at least. I think the most important arrhythmic event that this child will have in their life is having the cochlear implant. So I would really be careful at that time. I'll make sure that he does the cochlear implant in a facility where there are cardiologists that are capable of following him up, because this is very important. I have seen one patient who had 6 strokes in 1 day after the cochlear implant. So that's the most arrhythmic trigger that he will have in his life.
So you have to initiate a project. Yeah, so we have to initiate a project with cochlear implant surgeons.
It's not that it's not of course it's not contraindication to have the cochlear implant, but just to make sure that he's well followed.
I'm talking about to make a project concerning young patients with cochlear implant.
That's what Aswan are doing right now.
So just one comment on the extraction component of the talk. So I think historic extraction community has always been very anxious about SVC and IVC tears during the procedure with outer sheath and laser and extraction tools. I think over the past couple of years, a lot of the conversation in the extraction world has been about tricuspid valve involvement during extraction and severe tricuspid regurgitation. A couple of months ago, we had a case of complete flail of a septal leaflet of the tricuspid valve post-extraction. And I think that the best way to avoid the tricuspid valve issues is actually from the implant. And so when you were describing about, threading the lead through the middle of the valve to make sure that you're not entangled in any of the leaflet apparatus, I think particularly in pediatric patients, one approach to consider is prolapsing the lead in the right atrium, and that way it crosses the valve completely prolapsed, and you're not, you can guarantee that you're not threading through any of the tricuspid valve apparatus. And I also do that with conduction system pacing leads. I advance a pigtail type wire into the ventricle, and through that I advance the sheath and then the lead to avoid entanglement in the tricuspid valve. So I think the hygiene at the time of implant is very important to avoid these types of problems at the time of extraction.
It's a good trick for implantation, but we have, for the sake of the time, to go through the next session.
Next session is challenging cases in pediatric pacing, presented by Dr. Rodayna Sobhi.
Good afternoon, everyone. Okay, hope I will not be boring or long. Actually, I think my preceding speakers, very interesting lectures. I'm going to talk about challenging in pediatric pacing. Actually, some were mentioned in some presentations. Actually, we have a growing population of children requiring permanent pacemakers, and while more or less pacing in adults is standardized and algorithm driven, every child presents a unique anatomical, physiological, and long-term challenge. We have many issues. We have starting the vascular issues, the vascular access issues, small veins, so basically smaller children, we prefer to go for epicardial pacing. We have the risk of obstruction because our patients would have to need multiple lead replacements. Actually, we have an congenital venous system anomalies, and that we started noticing very, very long time ago when we started device implantations, and that's why we routinely do venography very early as we started, and we found some patients, they had venous anomalies and obstructions even before we placed any leads. Sometimes we have the LSVC to the coronary sinus, which is a challenge that obliges us to put a lead on the right side. Okay, these are patients without a lead, and they have a very narrow venous system. A patient, okay, patients with persistent LSVC, so we put it on the right side and we don't have the left axis. Other issues, children are smaller, they have small body size, and they grow. Two problems. So we have limited space for the generator and the leads. We tend to put our generator submuscular, in a submuscular pocket, not a subcutaneous, which makes the procedure more lengthy and a little bit difficult. The generators are heavy, so sometimes we see problems with the fixation of the generators, even in epicardial pacemakers. And we've seen some cases where the pacemaker, although was fixed at the beginning, it migrated later. The growth of the children, there is the problem of lead stretch, insulation failure, and fractures. And that's why we routinely do an RA loop, giving time for children to grow. As they grow taller, these loops tend to become more straightened. Anatomical and technical issues, association with congenital heart disease, anatomical abnormal anatomy of the heart. As I say, they tend to have multiple devices implanted throughout their lives, previous cardiac surgeries, patches, sutures, okay, and even patients, children who do the epicardial pacemakers and the redo pacemaker, the surgical placement even is shows some challenges because they have previous sternotomy, previous adhesions, or in the post-Fontan patients. All these are actually challenges. Some of the patients with, post-operative, and sometimes we need to do angiography to know where the ventricle dimensions are. This is a patient post-cono procedure with aortic valve prosthesis. A patient with mesocardia, double outlet right ventricle, VSD, and he has a VSD closure and RV to PA conduit. So the injections, because the lead position is ultimately looks strange, so that's now we know it's in the ventricle apex. Patients post-Senning procedure, you can see on the lateral, it's in the posterior ventricle. These patients after redo surgery, they are post-operative patients after mitral valve replacement. Patients with CC, congenitally corrected TGA, sometimes if we're not sure, we do angiography to delineate a ventricle, the RV. I'm sorry, the LV. Okay, and this is the final lead placement. Looks abnormal, not like the one we're used to in normal anatomy. Dextrocardia patient. Okay, this is has a congenitally corrected TGA and dextrocardia. Sometimes patients have anomalies that can be fixed percutaneously, so we do multiple procedures same time. Like, for example, this patient, he had a PDA device closure and a permanent pacemaker insertion. In addition to that, we have the physiological and some electrophysiological consideration. They have an immature myocardium, so changing and different capture thresholds. And of course, the long-term RV apical pacing can lead to ventricular dyssynchrony and long-term LV dysfunction. Now, the left bundle area pacing is offering, I think, a better chance for those patients where we started to see good results with patients. But we should be very careful, as Dr. Shady said, about the capture parameters. Also, there are considerations as regards the pacing modes. Our patients need the rate responsiveness, and we need to adjust the rates to be appropriate for their age. Sorry. Long-term challenges. We see our patients since infancy or childhood till they are teenagers, so we always have concerns for the lead longevity, the venous occlusion, the infection risk, the multiple reinterventions, and of course the psychosocial aspects. Our patients are active and immature. We have the accidents, a lot of accidents among our patients, trauma accidents. They are concerned about their body image, sports. They all want to play sports, and we just keeping a balance between playing sports and never to be, having a lot of bumps. Emerging technology solutions, the left bundle branch pacing, we have, I think, the pediatric experience is growing, and in some of our patients, so far we have good results. We opt for smaller devices, MRI compatible system, and as Dr. Michael said, maybe the future, the leadless pacemaker. And finally, what I want to say is that our patients, they keep following with us till adulthood, and then they are just left on the, we need, they dependent on a pacemaker, actually on our personal level and personal connections. We transit our patients to our friends in the critical care units and the adult cardiology units, but I think those patients need very good structured transition programs, handing them over, coordination between the pediatric and adult cardiologists, especially those adult congenital heart disease teams. Actually, a pacemaker therapy in children, again, I want to say finally that it involves a unique issue. We have the size, the growth, the possible presence of congenital anomalies. And I think the future lies in, we need to do more physiologic patients, miniature devices, and of course the multidisciplinary team. Thank you.
Thank you, Dr. Rodina.
Okay.
You challenging the time and challenging pacing.
Yeah, actually, we were speaking earlier. I was telling him examples of the accidents that we face. You know, playing with a bicycle, it destroyed a pacemaker once. Falling, hitting the wall, it destroyed a pacemaker once. We had 3 Twiddler syndrome, 2 Down syndromes, and 1 patient had submental, mentality was subnormal. They actually used to hold the pacemaker and twist it till they broke it. We see patients playing with, putting forks and stuff in the electricity. Yeah, so children are unexpected.
Thank you.
Okay.
For sake of time, we go directly for Dr. Ahmed Tahir session. Debates in pediatric cardioneural ablation in children with asystolic syncope. It's time to do it. Other session will be recorded and podcasted in the website.
Thank you very much for the presentation and introduction. Okay, I'll try to keep my session as quick as possible, short, and hopefully interesting as possible. Because this is an interesting topic for me. I don't know if you're familiar with cardio-neuroablation. It's new kid in the block, as we say in the field of cardiac electrophysiology. Mixed feelings about it. Some proponents, some those who are not much in favor of it. But early disclosure, I'm a proponent of the technique, but I'm also a proponent of proper selection of those patients. So I believe it works, but I also believe in strictly selecting the patients who may benefit from it. Now, what is cardio-neuroablation in children? First, we're dealing with the domain we're speaking in the domain of syncope. Syncope is a subtype of transient loss of consciousness that's associated with global hypoperfusion, something to differentiate from psychogenic, epilepsy, or other causes. Syncope itself, from the mechanistic point of view, is three types. Either cardiac syncope, something related to the rhythm, brady, tachy, things like that, obstruction, and orthostatic hypotension, and our final interest is the reflex syncope. And again, if you look specifically in reflex syncope from the response point of view, reflex syncope is three types. The one is vasodepressor or hypotensive type, the other is cardioinhibitory, asystolic or bradycardic type, and the third type is the mixed form. From the trigger point of view, reflex syncope is either vasovagal situational or carotid sinus syndrome or other rare cases. So what we are talking about is a modality of treatment for specifically cardioinhibitory syncope, the one associated with bradycardia, severe bradycardia, symptomatic, or heart block or asystole. So how is it treated? Let's skip forward to the guidelines. Once diagnosed by other tilt-table testing or evidence of asystole on prolonged monitoring, be it Holter or implantable loop recorder, the guidelines since, I don't know, I can remember as far as 2018, they separate the treatment, as you can see from this graph, something for the elderly and something for the young. And cardio-neuroablation in that, cardioinhibitory syncope in this guideline 2018, in the elderly, they were talking specifically about pacing. So I don't know if my pointers, okay, so it's not, I don't think it's visible on the screen, so it's pointless to use it. I will just use the mouse. So in the elderly, cardioinhibitory syncope is only treated with pacing. Up until that guideline 2018, we had no other option. And they, I think deliberately, they avoided talking about treatment in younger population or what to do in younger population. And the same thing was in 2021. Again, pacing guidelines, they recommended pacing for reflex syncope under 3 conditions. Okay? So the patient has to be older than 40 years of age and has to have cardio-inhibitory form of syncope and has to be recurrent and unpredictable. So once you fulfill all these criteria by the guideline, you can implant a pacemaker. Again, I'm highlighting the fact that they are only talking about patients older than 40 years of age with no specific recommendation for younger population. Actually, by extrapolation, some physician opted to implant pacemaker for cardioinhibitory syncope in younger population, although again, we have mixed evidence for the utility in those populations. So what is the options we have now? Cardio-neuroablation came into play in this situation. Now, why is it interesting? From the anatomic and physiologic point of view, we took advantage of the different arrangement of sympathetic and parasympathetic supply to the heart. Whereas the sympathetic supply, the ganglia for sympathetic supply of the heart relay away from the heart near the vertebral column. On the other side, the ganglia of parasympathetic system, they relay in the fat pad just outside the heart, just around the heart, where in fact we can, if you want, to ablate these ganglia from endocardial aspect. The other interesting thing, because we have access to the ganglia, we can induce a permanent damage to these nerves. Because if you ablate the axons, the neuron can regenerate their axons. But once you attack the ganglia, the damage is permanent. So now, under these arrangements, we can ablate the parasympathetic ganglia of the heart to treat. Now, there are certain areas of debate still around the technique, where to ablate, how to locate these ganglia, what is the best endpoint for ablation. But overall, the evidence in this area or in this regard is very encouraging. I just want to draw your attention, because my talk is about cardioneural ablation in children. The evidence in the adults, I will show you in a second, is almost now established, okay? But most of the studies for cardioneural ablation included patients who are usually older than 18 years old. I mean, in strict terms, they are not pediatric population, except this one study that included patients that are older than 14 years of old. And actually, last year, just 2024, the European Heart Rhythm Association published a consensus statement on cardioneural ablation. You will find exhaustive review of the techniques, endpoint, and ablation strategies, but most importantly, an advice, an algorithm, a flow chart for selecting the patient for cardioneural ablation. Again, they've stated that the patient needs to be old, okay, so we're still talking about patients older than 40 years of age, okay. Patient that needs to be younger than 60 years or 40 years in this publication. So it's a technique for younger population, not for older. And you have to document cardio inhibitory response either by tilt-table testing or prolonged or monitoring. And if you fulfill these criteria and the patient is not responsive for conventional method, the consensus statement, I'm not saying guideline, it's a consensus statement, supports cardioneural ablation for those patients. And in our experience, the patient we have done, they've responded remarkably to this technique. But what about the evidence of pediatric population? It's very limited, to say the least, okay? Actually, I couldn't track except very few publications for these pediatric, and again, the age of pediatric population in these publications is not that young. We're talking the youngest enrolled person was like 12 years of age. Case series of 6 patients only, ranging from 12 to almost 20 years of age. The presentation was not asystolic syncope, and this is something to keep in mind in pediatric population. The most commonly presented complaint in literature is not syncope. Most of these patients has symptomatic or functional bradycardia dizziness. But when you use the same technique used for adults, the cardioneural ablation, in the same way, they respond remarkably and very well and seem to be cured of their symptoms. Another case report, only 2 cases, 12 and 14. Few things to keep in mind. First, the average heart rate in this population, you don't expect it to be as low as you think in adults. So 60 average 24-hour heart rate of 60 is considered low if associated with symptoms suggestive of low cardiac output. In these publications, dizziness was the most common presentation. And the other thing, you have to prove in a way that what you're seeing is a result of excessive vagal tone. So most of those patients received pre-procedural atropine in an attempt to increase the basal heart rate. Ideally, there's a debate about the cutoff limit that represent excessive vagal tone, but in adult, usually we look for an increase more than 25%. In pediatric population, maybe you need to push up this limit to almost 31% as these publication, but you have to show an evidence of excessive vagal tone as shown by increase in heart rate by atropine pre-procedure in order to select those patients. But again, if they are properly selected, ages as young as 12 years old benefited from cardioneural ablation. Now, again, although I'm a proponent, as I said before, of the technique, and I think it should be utilized more often, I think young patient pacing in young patient for reflex syncope should very carefully consider more than once before giving a young patient pacemaker for syncope. But again, you have to have a word of caution about cardioneural ablation. First, many cases of vasovagal syncope in younger adults, they resolve spontaneously. Actually, when you follow up those patients only with conventional method, they tend to improve spontaneously over time and cease to experience any further complaint. And yeah, we've seen that, we've proved that many large case series showed that even patient with asystole more than 30 seconds during tilt table testing, and something that would be horrifying for anyone who does this procedure to see asystole for this long time. Actually, they, if with conservative treatment and proper education, if they follow him, if he's young and you follow him long enough, many of these patients cease to have any procedure, any future events. And we don't know exactly why, but maybe one of the recent explanation in this publication that linked infection with vasovagal syncope, orthostatic hypotension, and if they found a relationship, a link between some viral infection, Coxsackie virus and Epstein virus, and this presentation. And from our experience, we know these infections are self-limiting, and sometimes the symptoms associated with them disappear spontaneously. Another explanation why these attacks of vasovagal syncope could be self-limiting and disappear spontaneously. The second thing is that we rely on head-up tilt table test to reproduce the symptoms and the syncope, and there's always a question about the specificity of symptoms triggered by head-up tilt table test. Is it that clinical? Should be completely rely? Does every person who experience cardioinhibitory syncope during tilt table test will experience spontaneous syncope later on in life? This is a question yet to be answered. And again, the long-term follow-up of patients who already underwent cardioneuroablation is still lagging. This is relatively new experience. We're excited, but we don't have long-term follow-up for those patients. So in my conclusion, that cardioneuroablation for cardioinhibitory syncope is proven effective in reducing syncopal episodes. Patient selection, again, is crucial. Currently, it is pertinent only if recurrent, frequent, severe. Otherwise, I explained asystolic vasovagal syncope, I would add in young population. Now, recent studies, although the guideline talk about younger population than 40 years, but actually recent publication suggested that even age below 60 years could benefit from cardioneuroablation. So even a patient like, say, 50s who experience asystolic cardioinhibitory syncope could benefit from cardioneuroablation before pacemaker. And again, evidence pediatric population is encouraging, but is still limited so far. Thank you very much.
Thank you, Dr. Ahmed, for this nice presentation. Any questions? Okay. Okay.
Yes, about the long term for young population, do you think that regeneration of neurons or vagal input on the heart may come again if there is any other viral insult like
Yes.
maybe corona, which make sinus tachycardia inappropriate, may be an issue if you have already aborted the parasympathetic on the heart?
Sure,
Would
sure.
you think to give medication post? In fact, the first patient that I have ever did in cardioneural, we did almost 20 now, was 14 years old, and he was only complaining of bradycardia significant, can do the usual activity, and he felt so happy immediately the second day. For what do you think about this?
Yes. So regarding the patient, we have the same experience. Once you carefully select the patient and you carefully perform the procedure, the improvement is immediate. The patient feel completely different, like 24-hour, 48-hour after the procedure, and we have very good experience with that. Now, as for your the first part of your question about the durability of response, the risk of ablating other region, I think the intricate details of sympathetic and parasympathetic supply of the heart is complex. And yes, we know if you're not careful in selecting these exact site, you may inadvertently ablate sympathetic axons, the axons of sympathetic fibers to the heart, which are responsible for the bradycardia, initial paradoxical bradycardic response, because you're ablating the sympathetic. But even if you get this response, even if you ablate sympathetic fiber, you are ablating the axons, because we know the ganglia are away from the heart. So even any initial response attributable to ablating sympathetic fiber is expected to be transient. to say the least, even if you had to give something. Now, the more annoying part is that if you ablate the axons of the parasympathetic fibers, not the ganglia. You cannot carefully select the ganglia. You cannot deliver lesions because you're not ablating endocardium as we are ablating atrial tachycardia or atrial fibrillation. It's not the wall of the left atrium. It's the pericardial fat that you need to reach to. And you have to deliver, I mean, everything about high power, short duration, or the energy forms that we use to deliver safe, you do exactly doing the opposite. You need lower power, longer duration in order to get a deep penetration to reach that. The problem of not applying that is that sometimes you ablate the axons, not the ganglia. And you will get the desired response from just ablating the axons, the parasympathetic fibers. But the problem with that is the duration, the durability of this response will be questioned because, again, axons regenerate. As long as the ganglia are not attacked, the axons will regenerate. So you have to be very, I mean, this is still an area of debate. I mean, some people use high frequency pacing to delineate the ganglia, anatomic approach, local fractionated electrograms. Some people, they give atropine at the end of a procedure. Some people completely sedate the patient and aim for complete elimination of extracardiac vagal response. Famous centers and eminent operators just aim for increase in heart rate, basal heart rate, which. There is no consensus about what is the optimum technique for that. But again, you have to be very meticulous, and eventually there is we are honing on the idea of ablating the gateway ganglia. A paraseptal could be the end of it. But yes.
Thank you, Dr. Ahmed. It's my pleasure to introduce Professor Rania Higazi. She will give the most elegant talk about sports screening in children. We're all ears. Thank you very much.
Thank you very much. First of all, I would like to say that I'm very, very proud to belong to the Arrhythmia and EP team at Abu Rish. Thank you, Professor Wael Lutfi, the founder, Dr. Usama, Dr. Rudaina, Dr. Hussein. Thank you, Professor Sahar Shakir, for supporting this conference. Actually, it's been a brilliant day. Thank you all the international speakers, the national ones. I hope you've all enjoyed it as much as I did. I know everyone is very tired, so I'm going to keep my talk as short as possible. It's a point of debate: sports screening in children, are we saving lives? Can we take a show of hands who in this room encourages sports screening for children? Who would screen their sports? Okay, so let's see after this talk who's still going to be in support of sports screening. As we all know, there is a paradox called the paradox of exercise. Sorry, this is not working. So the paradox of exercise refers to the fact that we are always encouraged to practice sports and to do regular physical activity because this would reduce the risk of premature death. But let's not forget that there is a risk of sudden cardiac death associated with performing sports. And this is what we know as the paradox of exercise. So sudden cardiac death is a leading cause of mortality among athletes during sports and exercise. And the prevention of such death is of tremendous importance because of the profound societal impact that these events have, whether on families, on communities, especially when this is a very publicized event happening in a healthy athlete. We will never forget this player from Denver. During the Euro 22 match, he collapsed during playing in a match just before halftime. We all saw him fall to what we thought at that time would be his death. They did an efficient CPR and resuscitation, and they brought him back to life. Other athletes have not been as lucky. These are athletes from our Egyptian sports activities, different activities, and all of them have lost their lives during practicing sports, and none of them we were able to resuscitate. So as we all know, sudden cardiac death is defined as an unexpected death that occurs from cardiac causes within 1 hour from the onset of an acute change in the cardiovascular status in the absence of external cardiac and causal factors. So is it common? How common is sudden cardiac death in athletes? When you revise the literature, you will find very different reports. And usually in individuals who are less than or younger than 35 years of age, you'll find the incidence ranging anywhere between 1 in every 23,000 to 1 per million athletes. However, in the US, the incidence seems to be a bit higher, 1 in 50,000 in college athletes and 80,000 in high school athletes. And when they looked at certain subpopulations, they found that the risk is as high as 1 in every 3,000 athletes in basketball division, particularly if it's a male rather than a female, and the blacks are, compared to the other ethnicities, have the highest rates of sudden cardiac death. In Denmark, where reporting sudden cardiac death is mandated, it is reported to be around 1 in every 100,000 athletes. So who is an athlete? An athlete is an individual who participates in organized team or individual sports. He requires regular competition against others, placing a high premium on achievement, and requires some form of systematic and intense training. So it's not just the professional athletes. Professional athletes are a subgroup of those. However, anyone who's participating in competitions and regular exercise can be called an athlete. And so many organizations worldwide, the American Heart Association, the European Society of Cardiology, and others have endorsed some degree of a cardiovascular pre-participation screening. This is often a requirement in many areas, both for medical and legal reasons. However, how we're going to do this evaluation is very variable from one place to another. As we are going to see, it's a matter of debate that has been going on for the past decades. Even the definition of who requires PPE is not constant among different countries. In the US, for example, they require a PPE for high school and college students. The Italian law mandates every competitive athlete to undergo this yearly. In Germany, a PPE with ECG is mandated for even leisure time athletes, and in those who are competing at a higher levels, they require more sophisticated techniques with exercise testing and echocardiography included in the routine screening. Japan, for example, requires ECG screening for all children in grades 1, 7, and 10, regardless if they are practicing sports or not. What are we looking for? We are looking for the causes of sudden cardiac death, whether they are structural heart diseases like HOCM, arrhythmogenic cardiomyopathies, electrical problems, the long QTs, the Brocadas, the Wolff-Parkinson-White, and sometimes other diseases like myocarditis. So these are the things that you need your screening to be able to identify and define. And as we can see, some of them are very challenging to just diagnose by an ECG. Of course, we have different ethnicities with different problems. The Brugada is more prevalent in those of Asian descent. HOCM is found to be most common in the US. Italy reports a higher incidence of arrhythmogenic right ventricular dysplasias, so it is not constant among the countries. And we have the history questionnaire, the physical examination, and the ECG testing. These are the basis of any pre-participation screening. However, the 12-lead ECG and its inclusion in the screening is a matter of debate that has not been settled due to its cost effectiveness, psychological implications, diagnostic accuracy, as we're going to see. So actually the question is, to ECG or not to ECG? That is the question. Let us look at those who support doing an ECG and including it, like the ESC. The European Society of Cardiology published back in 2005 its mandate that cardiovascular pre-participation screening for young competitive athletes should include an ECG. And this consensus document recommends the implementation for every athlete because they believe that it has proven its efficacy, that it has managed to diagnose people with HOCM, which is by far the most common cause of death, and it can also identify other lethal ECG abnormalities. And this came as a validation of this very interesting paper that was published back in 2008 in JAC that claimed in Italy, a region that was looked at for 26 years, that proper pre-participation screening has reduced the death by around 90%. As we can see in this graph, this is how effective their pre-participation screening was, decreasing the incidence of death by around 90%. And they endorsed this form of roadmap. If you have an athlete, you screen him by physical examination, by family history, and by ECG. And if everything is normal, just put him in his sports practice. If not, then you go for further examinations. And this is the exact roadmap that is recommended and endorsed by the European Society of Cardiology. And another very important paper by Sarto et al. That was published in the ESC in 2023, they looked around at around 23,000 young athletes. Through this proper screening, they diagnosed 69 cases with problems that prohibited their athletic participation, and they found that then they submitted the causes for which patients were not allowed to participate in sports, like long QT, hypertrophic cardiomyopathy, and other diagnoses, and they found that the ECG was very accurate in diagnosing those patients. However, others do not recommend doing the ECG, and these others include the US, where in 2014, the American College of Cardiology and the American Heart Association published that we need just a 14-element screening checklist that includes personal history, family history, and physical examination, and if this is normal, you do not need to go to other investigations. However, the cardiac examination is stressed to be an accurate examination where you auscultate the heart in two positions, in the standing and in the supine, and while the patient is doing at least 2 maneuvers, including valsalvas or deep inspiration, so you have to be able to provocate the appearance of a murmur that would be caused by HOCM. Still, studies have reported that physicians were not satisfied when they were screened, even if the screening process was done by a physician. They always complained that the medical history taking was poor and that the physical examination was restricted to blood pressure management and sometimes listening to the chest. In a 2018 paper that was published where the American Heart Association examined its own recommendations, they found that the sensitivity was very low, around 19%, specificity was 68%, and definitely removing the ECG took a bit out of the value of this screening. However, they still think that most individuals with undetected cardiovascular diseases are asymptomatic and they would not be diagnosed on an ECG. In 2025, the newer athletic, as Dr. Hussam is going to be mentioning, that one of the biggest problems with sports screening was the high false positive that results from the changes that you would normally see in a healthy athlete, and sometimes you would misinterpret them as being abnormal, like sinus bradycardia, some voltage criteria for LVH. So now, with the better criteria for the athletic ECG, these false positives are less, and we may see better values for incorporating an ECG in our screening. But still, please remember that many conditions are going to be missed even with an ECG. So these are the arguments against ECG screening. The cost of doing ECG might be prohibitive. There is not enough qualified personnel to just diagnose accurately from the ECG. The cost of evaluating a false positive and going through the echoes and the cardiac MRIs and everything else that would come from a false positive test is really prohibitive. And of course, the legal consequences of having a false negative test. But still, pre-participation screening does reduce sudden cardiac death in young athletes, as was published in this paper from Nature Reviews. Optimizing pre-participation screening is now not an option. We need to move from if to how, and this is the roadmap that was published in the ESC, where you need to optimize the history and physical examination, incorporate ECG, and better the criteria of ECG, and then determine other things like how frequently are we going to screen our athletes, when are we going to start screening them, and try to bring the cost of this screening down. I'm not going to go through the ECG changes because Dr. Hussam is going to talk about them, but still, to screen or not to screen, that is the question. This is the title of a paper that was published in ESC because not everyone is with screening. Some think that to prevent sudden cardiac death is important, but at what cost? We disrupt the, so many patients, so many athletes are sometimes put under stress because of this screening, and this paper was a call upon us to just revise our attitude. Do we really need to screen athletes or not? However, does cardiovascular pre-participation screening cause physiological and psychological distress in athletes? This is a systematic review that looked at so many papers that were examining the psychological effect of screening in athletes, and they found that there is no negative psychological impact on our athletes, except if the patient had a false positive result, and that was not many. Before we end this discussion, I just need to remind us all, we are a country that does not have AEDs in every single place of sports, especially in sporting clubs, and this is really, really important because as we were discussing with Dr. Wael, we have patients, for example, with long QT or things that put them at risk. You cannot put them back in exercise if you do not have effective AEDs and CPR trainings for the coaches. It is an power of the AED. if you have an effective automatic external defibrillator, you can bring the survival rates up to 75% after an athlete has an episode of a sudden cardiac arrest. So this is very important. Another final point is, please do not stop your cardiac patients from practicing sports. Practicing sports is very important for a child to feel normal, to feel included. This updated guidelines was published in 2025, last of March, because they wanted us to be more lenient with our patients, allowing them to practice sports. I encourage everyone who has pediatric patients with congenital heart disease to take a look at this paper. So now my final slide is sudden cardiac death does occur in healthy athletes. Pre-participation screening may save lives. Proper history taking and careful, and I put under careful and detailed cardiac examination should be a part of every screening. Incorporating ECGs in the PPS is still widely controversial. On-site AEDs will significantly decrease mortality rates from sudden cardiac arrest. Please remember, it is time to cooperate together, putting primary prevention measures and secondary prevention measures, because sudden cardiac death is still very much a nightmare in athletes. However, efficient resuscitation does save lives. Thank you very much.
Okay, for our next speakers, I'm honored to present a very dear colleague, Dr. Hussein Ibrahim, Assistant Professor of Pediatric Cardiology. He's going to present on normal ECG changes in pediatric athletes, normal and abnormal.
بس لغايه لما حسام يحضر البرزنتيشن بتاعته, I don't think ان I notice an AED in this museum. I think it's important also to have it in museums, in airports. So I just
public areas.
It should be, and we need to take a look if they have an AED or not, because it's quite important.
بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. وما أوتيت من العلم إلا قليلا. Our lecture today, our talk today is about normal ECG changes in pediatric athletic population. As Dr. Rania said before, the athlete can be defined according to European Society of Cardiology as one who participates in an organized team or individual. Sport requires systematic training and regular competition against others, while placing a high premium on athletic excellence and achievement. As we know, sudden cardiac death in athletes is a tragic event which usually and highly publicized, particularly as athletes represent the healthiest individual within the society. Sports can be classified into 4 types of sport. Skill sport, which needs a technical skills for achievement, like sailing and shooting and equestrian. This type of sport is associated with mild increase of heart rate, mild increase of blood pressure, and mild increase of cardiac output, so no cardiac remodeling. Whereas the other type is the power sport, which needs explosive power. This type of sport is associated with moderate increase of heart rate, significant increase of blood pressure, moderate increase of cardiac output, so he has a cardiac remodeling, but mild cardiac remodeling in the form of concentric hypertrophy of the ventricle. Mixed sport, which need alternating phases of dynamic and static exercise, like pole and team sport. This type of sport needs moderate increase of heart rate and blood pressure, and so the cardiac remodeling also is moderate in the form of eccentric hypertrophy of the ventricle. The most important and the most powerful sport is the endurance sport. This is associated with significant increase of heart rate, significant increase of blood pressure, significant increase of cardiac output, and also significant cardiac remodeling in the form of eccentric hypertrophy, like cycling, canoeing, rowing, marathon, pentathlon, and other sports which need prolonged and intensive work of exercise. Sudden cardiac death, as we know, is a leading cause of death in athletic population who have underlying cardiac disease. Young athletes have 2.5-fold increase risk of sudden cardiac death compared to the sedentary individuals, which may point to that physical activity can trigger a life-threatening arrhythmia. Incidence of sudden cardiac death is closer to about 6.8 per 100,000 of athletic population. As we know, the most common cause of sudden cardiac death is long QT syndrome, Brugada syndrome, hypertrophic cardiomyopathy, arrhythmogenic right ventricular dysplasia, and coronary anomalies. Pre-participation in sport screen, like as Dr. Ania said, it helps us for enable early detection of underlying cardiovascular disease. It consists of physical examination, history, and 12-lead ECG. But it's important to say that most of the athletic population who have an underlying cardiovascular disease are asymptomatic. 80% of them are asymptomatic. And the sudden cardiac death may be the first presentation of this population. So ECG help us for early detection and early electrical changes which precede the phenotypic expression, as ECG changes is present in 95% of patients with hypertrophic cardiomyopathy and 80% of cases of arrhythmogenic right ventricular cardiomyopathy. ECG also is essential for diagnosis of WBW, long QT syndrome, and Brugada syndrome. ECG changes that occur in athletic population usually occurs as a result of two important issues: electrical changes and structural remodeling. Electrical in the form is due to the increased vagal tone and sinoatrial node adaptation and AV node adaptation. Structural remodeling, as we said, due to eccentric versus concentric hypertrophy of the ventricle in response to repeated bouts of intensive training and regimen with pressure and volume overload. Incorrect interpretations of ECG in athletic population may lead to either false positive result or false negative result. False positive result lead to expensive diagnostic workup, unnecessary disqualification from sports with significant psychological and financial implication on affected individual, while false negative results lead to false reassurance and potentially fatal consequences. What are the factors that can affect the ECG changes in athletic population? As we said, the intensity and type of sport, either dynamic, static, or mixed, which lead to either eccentric or concentric hypertrophy of the ventricle. Age, as we know, athletic population before age of 16 years has a significant juvenile T-wave inversion which disappear after age of 16 years. Sex, female players show less physiological remodeling than their male peers. Race, black athletes exhibit more pronounced repolarization changes in the form of T-wave inversions, and they have a special type of ECG changes which is called black athlete ECG. About the progress of ECG, according to the ESC guidelines, the first statement who discussed the ECG changes in athletic population was in 2005, and when this recommendation was applied, about 50% of athletic population was diagnosed as abnormal ECG changes and abnormal and need further investigation. So in 2010, they defined the population, athletic population, into two groups. Group one was training-related ECG changes, and the group two is training unrelated ECG changes. The group one was confirming the basis of normal ECG changes in athletic population. In CETER criteria 2013, it's the first one who classifies the patient into normal ECG finding and abnormal ECG finding, and redefine the abnormal ECG parameters, especially with special attention to the cutoff values of long QT syndrome, and added the ventricular arrhythmias as abnormal ECG changes, and added the black athlete ECG for the first time in the normal ECG changes. In 2014, these criteria also are modified. And the first time, they classify athletic population into normal ECG changes, abnormal ECG changes, and borderline criteria, which is find one of them is not signify underlying cardiovascular disease, but two of them can signify underlying cardiovascular disease. In 2017, the international recommendations classifies the athletic population into normal ECG finding, abnormal ECG finding, and borderline ECG finding, adding for the first time juvenile two-wave inversion in the normal ECG changes, adding a complete right bundle branch block for the borderline ECG changes, and adding as the Brugada type 1 is the only ECG type which can be classified as abnormal ECG changes, and the prolonged BR interval beyond 400 milliseconds as abnormal ECG changes. When these criteria and these guidelines according to European Society of Cardiography was applied to the pediatric population, what we can find and what happened? When these criteria applied to the pediatric athletic population, pediatric athletes was like adult population have abnormal ECG changes like adult population with less false positive result, but the sensitivity when applied this recommendation and the criteria was low with a lot of false negative result. And this was explained by the underlying congenital heart disease, especially of right ventricular volume overload, Epstein anomaly, and the coronary anomalies, which cannot be picked up by the ECG changes early. So in 2022, they tried to modify the international recommendation to be applied in the pediatric population. And a lot of modification was done on the international recommendation to be applied and settled in pediatric athletic population. They redefined all the cutoff values in adult population to be applied in pediatric population, and also added the low QRS voltages as abnormal ECG changes, and removing the complete right bundle branch block from the borderline criteria to get in the abnormal ECG changes, and put the incomplete right bundle branch block as a borderline ECG changes with right axis deviation and left axis deviation. So the next slide will discuss this slide or illustration for the previous slides. First thing is the sinus bradycardia is present in 80% of athletic population due to increased vehicle tone. In pediatric population, normal if between 40 and 60 beats per minute, and as maybe associated with isorhythmic AV dissociation and resolve with the onset of exercise. And abnormal if the heart rate below 40 or associated with symptoms, or the patient has a positive family history of sudden cardiac death or underlying cardiovascular disease. This is an example of isorhythmic AV dissociation, where the both atria and ventricle are controlled by different pacemaker. Atria is controlled by sinoatrial node, ventricle is controlled by the AV node, with abnormal relationship between the B wave and the QRS complex. First degree heart block also is normal in athletic population between 230 milliseconds in pediatric population, and usually shortened with exercise. Beyond 300 milliseconds is abnormal, especially if the patient is symptomatic or has a positive history of sudden cardiac death or underlying cardiovascular disease. Sinus boost is present 37% of the cases due to increased vehicle tone, normal up to 3 seconds, and if it occurs at rest or during sleep and disappears with exercise. This is a normal finding in pediatric athletic population, but sinus boost more than 3 seconds or strain-induced poses or associated with symptom or positive family history of underlying cardiovascular disease or sudden cardiac death is considered abnormal. Sinus arrhythmia, this fluctuation heart rate occurs due to that as respiratory center inhibits the vagal tone with increase of heart rate during inspiration and decrease of heart rate during expiration. This fluctuation usually resolves with the onset of exercise, and if associated with sinus bradycardia is usually normal, but abrupt onset, abrupt increase, abrupt decrease is considered abnormal, especially is associated with symptoms. Junction escape resonance is present in 8% of the cases, but usually as a narrow QRS complex and retrograde B wave or absent B wave at all. And usually resume or disappear with the onset of physical activity. Ectopic atrial rhythm is a common finding in athletic population, and the usual abnormal atrial focus in the low right atrium, cross the coronary sinus os, and usually resume with the onset of physical activity, but if associated with atrial enlargement or hypertrophy, should be investigated. It is abnormal. Mobitz type 1 with progressive lengthening of BR interval until blocked B wave is a common finding in athletic population, and usually the patients are asymptomatic and disappear with exercise, but always second degree or Mobitz type 2, second degree AV block, and third degree is considered always abnormal in athletic population. Early polarization pattern in pediatric athletic population, we have two patterns, Caucasian pattern or Afro-Caribbean pattern. Caucasian pattern is characterized by G-point elevation, concave ST segment elevation, tall big T waves from V1, all ventricular precordial leads, but most common in V3 and V4 is the most common precordial leads, and also can be seen in infralateral walls. The Afro-Caribbean pattern is associated with G-point elevation, domed ST segment elevation, and inverted T wave from V1 to V4. Also is a common finding in plaque athletic population. This come to, and this is an example of Afro-Caribbean pattern of early polarization. And we come to important differential diagnosis between early polarization with a common finding and Brugada type syndrome. The most important parameter is the ST segment elevation. Corrado index stated that if we measure the ST segment elevation as the G point and the ST segment elevation 80 milliseconds after the G point, and if we divide the first measurement to the second measurement, if more than one goes with Brugada syndrome, if less than one, it's an early polarization. Also for the Brugada type 2 syndrome, if we measure the angle between the upslope and downslope of R dash, more than 58 degrees is considered with the Brugada syndrome. And if we draw a triangle between the upslope and downslope of R dash, about 5 millimeters below the vertex, the base of this triangle is measured more than 4 millimeters or 160 milliseconds, this goes with Brugada syndrome. T-wave inversions is defined by the inverted T-wave inversion more than 1 millimeter in 2 or more contiguous leads, excluding V1, AVR, and lead 3. It can be classified into anterior T-wave inversion from V2 to V4, lateral T-wave inversion, 1 AVL, V5, V6, and the inferior lead inversion in lead 2 to 3 AVF. The most common and pathological finding is the presence of T-wave inversion in lateral and inferior walls. But anterior T-wave inversion can be present in around 80% of cases of arrhythmogenic right ventricular cardiomyopathy, and also is present as juvenile T-wave inversion with a normal finding in pediatric athletic population. This is an example of juvenile T-wave inversion with inverted T waves from V1 to V3. And this is the two examples. On the left side is the juvenile T-wave inversion, and on the right side we can see abnormal T-wave inversion in lateral leads V5 and V6, which is considered abnormal and should be investigated. It is not a normal finding in athletic population. And also we come to important differential diagnosis in the anterior T-wave inversion. Is it a normal pediatric athletic population or a part of arrhythmogenic right ventricular cardiomyopathy? Other features in arrhythmogenic right ventricular cardiomyopathy can help us for differentiation, like epsilon waves, presence of complete right bundle branch block or complete right bundle branch block, localized QRS duration prolongation V1 to V3, especially the duration of S wave, more than 55 milliseconds, and the presence of epsilon waves and ventricular arrhythmia, which is usually non-outflow tract origin. High QRS voltage, as we know, is considered normal variant in pediatric athletic population, but usually has a normal QRS axis, no ST or T-wave exchange. But if associated with abnormal axis, it's abnormal ST or T-wave changes, it's considered abnormal.
Hussein, I just remind you of the time. Thank you.
This is an example of abnormal T-wave inversion and the abnormal QRS voltage. In this patient, we have abnormal significant LV hypertrophy, and notice that we have SCT changes and T-wave inversion in the infralateral leads. Also the example of right ventricular hypertrophy for right axis deficient, non-specific interventricular conduction delay from 100 to 130 milliseconds considered normal in pediatric athletic population. ventricular arrhythmia occurring in 20 to 30 patients is considered as a normal in pediatric athletic population if fulfilling the following criteria: less than 2 BVCs on 10-second single ECG tracing, less than 2,000 BVCs per 24 hours, monomorphic, no complex pattern, outflow origin or fascicular origin. If it can be suppressed with exercise and no other associations with ECG changes or echo, no family history of cardiac disease or sudden cardiac death. Thanks.
Thank you. Yes. Hussein, a very important topic.
Thank you so much. Now we will move to the most interesting session at the end of the day, which is competition of EPS of both champions, big names, challenging cases. Okay, thank you.
السلام عليكم. المسابقة دي تمت بمنتهى الحيادية من جميع الجامعات والمعاهد التعليمية ووزارة الصحة، شباب الزمالة، ومعانا نماذج مشرفة. أنا هطلب بس لجنة التحكيم إن هم يجوا: الدكتور محمد سامي، الدكتورة منى حافظ، الدكتور أحمد الضماطي عرفت إن هو على وصول، الدكتور أحمد طاهر، أعتقد الدكتور أسامة حضرتك معانا برضو في لجنة التحكيم؟ لا؟ طيب. احنا عندنا 13 متسابق، كل واحد هيبقى له 6 دقائق، وورقه تحكيم معايا، وفي جوائز ماليه مقدمه مني انا والدكتوره منى حافظ. ايوه، هي ظروفها معايا في شنطتي، مش هنقول ايه كام، للمتسابق الفائز الاول والثاني لحد ال 13. هنبدا بمعاذ راضي من مستشفى الناس، وهو احد شباب الزماله، اعتقد ان هو سنه ثانيه زماله. هدي لحضرتك الورقه، بس معاكي قلم؟ معاكي قلم؟ يلا. بس معلش اكتبي اسمك. وائل خلينا نكتب الورقه. المفروض معانا الدكتوره رانيا سمير اونلاين، لو ممكن حد يدخلها.
عايزين مغور.
منى. دكتوره عزه قطه موجوده؟ كانت معانا عزه قطه. اللجنه اتشكلت واجتمعنا اونلاين، والتقديم الحالات كان انونيمس، يعني كلفت حد من شباب الزماله انه يشيل الاسم ويشيل المكان عشان ما حدش يجامل نفسه يعني. طبعا انا امتنعت عن التصويت لاني انا كنت عارفه معظم الحالات، فانا ما دخلتش في التصويت ده. فاحنا اخترنا من 17 حاله، اخترنا 12 حاله، وكان في حاله الدكتور اسامه مختارها وطلع احد شباب الزماله برضو، فكان هو معاذ. يلا يا معاذ.
بسم الله الرحمن الرحيم.
لو سمحت 6 دقائق وهقطع.
تمام. طيب نبدا
عشان بس الشباب. احمد ضماطي اتفضل.
احنا بدأنا. بسم الله الرحمن
الرحيم.
ابدا يا
معاذ.
Our case today about male patient 21 years old, infant of lupus mother, congenital complete heart block.
ادي لاحمد ده.
Undergo single chamber permanent pacemaker implantation.
الصوت لو سمحت يا معاذ.
In 2011, battery exchange in 2019. Recent dizziness, intermittent loss of capture with very low lead impedance. This is ECG. When patient come to the NS hospital, there is persistent capture, but when shifted to unipolar programming. Examination was unremarkable. Transthoracic echocardiography, mild TR, labs was unremarkable. This is the X-ray of the patient, and as we notice here, this is the battery, and this is the sleeve of the lead, and this loop. All of these are implanted intramuscular. Our plan of patient. This patient is pacemaker dependent, and pacing percentage over 90. Our plan, our first question, which system will be implanted? Conducted system pacing, left bundle area pacing. Second question, the non-function lead, will we remove it or leave it? This is table illustrate the parameters, procedure complexity, immediate risk, need for surgical backup. Briefly, If we lead the non-functioning lead in place, we will have short-term outcome excellent, and a long-term outcome, venous stenosis, lead to lead interference will be higher. And if we lead extraction, the immediate short-term complications will be higher, and the future will be better. This is our protocol in our hospital. We consent the mother, and this consent takes more than 1 hour to be full oriented with the procedure and the possibility of open heart and the possibility of death. Hybrid operation room, anesthesia general from the start, blood products, imaging, transesophageal echocardiography, all through the procedure. All equipment should be available. We start with venogram and see this subclavian is patent. TBM insertion and 2 leads insertion. We start with dissection, and it was very, 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 very difficult. And as we need to see, there is a tear and loss of the lead integrity. So we cut the lead and try to insert a stylet. This failure to transmit in stylet, and we think have 3 options here. First of them, bulldog, use a bulldog to tract the lead, or shift to the femoral approach, or keep the lead inside. We shift to the femoral approach, bilateral femoral cheeses. First, we attempt with the gooseneck snare, but we failed to attract the cheese. Second, we use the loop snaring technique, Judkin Wright 4 catheter, looped around the lead, and try to extract the lead, but only succeed to remove the lead from the left subclavian into the SVC. Then we know we need another tool with more grasping force. This is the alligator jaw forceps. Our colleague in the GIT, Dr. Mauri, spoke about this tool. But we face another problem. This tool is not steerable. I can't direct this tool toward the lead, even I use the decapolar catheter to bring the lead toward the alligator. So we think about this tool. This is the Farah drive. It is deflectable cheese. It is measured inner diameter is 13 French. I can introduce the crocodile alligator jaw tool inside it and direct it to the lead. Here we start, but the lead spiral out and uncoiled down to the IVC, as we notice the right image. So we will shift to grasp the lead from a proximal end, ensure to complete extraction of the lead. This is our final complete extraction using the Farah drive, providing stability, and the crocodile grasping forceps for more traction force. This is the lead. Post-extraction assessment, venography, no extravasation, transesophageal echocardiography, no effusion, no tricuspid regurg or mild tricuspid regurg. This is the first part of our case. Second part is left bundle area basing. First of them, left atrial, right atrial lead. Then we use the Medtronic system and introduce it through the right ventricle, mid-septum. That is, we ensure our REO and LEO views. Before screwing, we modify our position and start to screw the lead. And during screwing, we observe the ECG, as Dr. Shadi mentioned, for the parameter of screwing inside the septum, starting from the W shape, then QRS narrowing, then pseudo-right bundle morphology. We use TEE to ensure we are enough or not, and not perforate the interventricular septum, and injection of the dye. This is the base, the QRS complex width. This is after left bundle area basing. This is our parameters starting. This is V6 R wave peak time. And this is V6 V1 interweek interval 62. And this is the V1 R wave peak time 111. Now we have sure we are capturing the left bundle threshold test, and we threshold test our QRS complex 130, and there is prolongation of V1 R wave peak time, and V6 R wave peak time remains the same, so we are selectively capturing the left bundle. This is our final results with the chamber basing system left bundle, our TEE, Fourier chamber view, and short axis deep transgastric short axis view. We add notes here. This خلصنا الحاله. ورسم القلب بس هنشوف رسم القلب في الاخر، نعرف بس رسم القلب وبعد كده خلاص اخر حاجه.
Thank you very much معاذ.
ماشي حاضر.
We have 2 minutes for discussion of the case on the board.
2 minutes of discussion. ماشي اتفضل.
Okay, we move to the next speaker.
زي الفل.
افتح الدكتور من الأول.
Next case will be presented by Dr. Mahmoud Al-Banna, one of the active fellows of electrophysiology at Al-Hussein Hospital.
ضمتي بيقول لازم نعمل discussion على الأقل دقيقتين، مش كده؟ ماشي. يبقى انت اللي هتدير الديسكشن بس. لسه جاي احمد فاحنا بقينا لا انا قصتكم القعده الساعه 9 بالليل بالضغط النفسي. انا عايزه كل متسابق يعرف دوره ويكون محضر نفسه عشان ما نضيعش الوقت. بعد محمود البنا ايمان سمير وبعدين اسماء عبد الحميد عشان هتجيب العيال من الحضانه. اسماء وايمان. الفيميلز والله يعني احنا بنحييهم على وجودهم معانا يعني. ودي مسؤوليه كبيره يعني انها تقدم وتيجي، وعشان كده انا حطيتك بدري. احمد رمضان، عمر ندى، حامد جابر، فاطمه الصاوي، كريم وصفي، محمد ادم، احمد الرصاصي، مصطفى ايمن، رنا ايهاب. عايزه كل الحاجات دي تبقى جاهزه، اللي يخلص اللي وراه يجي على طول. اتفضل. خليك جنبه بقى اشرف عشان ما يضيعش وقت في التكنيكال ايشوز دي. اقف شغل له المحاضره.
ماشي. Case presentation, complete heart block in patient with a Glenn shunt and biprosthetic tricuspid valve. Case history: the female patient, 17 years old, known to have Epstein anomaly. By history, she have its first surgery at age of 5 years, but no data about this surgery. Can't reach any data. And she had a second surgery at age of 16 years old. With the Glenn shunt was done with tricuspid valve replacement with biprosthetic valve. At our clinic at Al-Hussein Hospital, she complains of mild exercise intolerance and one attack of syncope. These symptoms start 6 months after or post last surgery. Tricuspid valve replacement with biprosthetic valve and the Glenn shunt. This is the ECG showing complete AV dissociation with the escape rhythm showing right bundle branch block. Our plan was to insert a permanent pacemaker. But the difficulty in this case was, first one was Glenn shunt and biprosthetic tricuspid valve. Glenn shunt is as an end-to-side anastomosis between the SVC and the right pulmonary artery. The end of SVC is connected to the right pulmonary artery, to the side of right pulmonary artery. So there is no direct contact between the SVC and right atrium or nor right ventricle. Second difficulty is biprosthetic valve and transvalvular lead is not preferred, and the coronary sinus lead and the epicardial lead is preferred according to the ACC guidelines. The choices available for this case: first choice is leadless pacemaker, second choice transfemoral, epicardial leads, fourth choice is transpulmonary valve lead. First choice, leadless pacemaker, Micra or Avier. You show the drawbacks of each choice according to our operator or our team. First drawbacks is the cost, the availability, young age of the patient. يعني, the available leadless pacemaker in Egypt is Micra, and have drawback of extraction, can't be extracted, and the reimplantation. And Micra, if battery end of life, she will need reimplantation of another pacemaker. And according to the young age of the patient and life expectancy, she will need about 5 or 6 pacemaker in the same RV. Second choice is transfemoral choice, transfemoral lead. Drawbacks is availability, no available long leads, 85 centimeter, patient comfort, lead stability, and DVT risk. Third choice was epicardial leads. The drawbacks of this choice is more invasive, longevity of the leads and the threshold issues, and the patient refused this choice. The last choice is transpulmonary valve. Drawbacks of this choice was seldom previous data, no data on the internet database, just one case report. Thrombogenicity, the lead passed through the SVC with a slow flow due to the Glenn shunt, and the choice of antithrombotic if we inserted the lead through the SVC. Difficult approach. This is the fourth difficulty. And the fifth difficulty is it have only one choice of VVI, no DDD. But we choice but this was our choice due to its available tools. This is a paper, only one paper found on database on the internet in the Indian Journal of Electrophysiology. So our decision was to insert a VVI pacemaker through the transpulmonary valve and to start warfarin with INR target 2 to 3 INR. This was a venography was done at the first visit at the clinic. Showing the SVC connected to the right pulmonary artery. CT venography. SVC connected to the right pulmonary artery. Another view, coronal view, transverse view, sagittal view, so tricuspid valve annulus.
خلص يا محمود.
ماشي. الفيديو اشتغل ازاي؟
خلص ورينا بقى الحاجة الحلوة اللي عايزين نشوفها.
الفيديو. بسم الله. We started by the conventional method using stylet of the lead and the modification of the stylet curve, but failed to approach the proximal of the pulmonary proximal of right pulmonary artery. شغال ازاي برضه؟
1 minute.
So we decided to use the coronary sinus lead, coronary sinus sheath, and trauma wire.
عايزين نشوف الفيديو بس 1 minute.
ايه اللي مش بيشتغل ازاي؟
لازم يفتح من عنده. افتح له يا اشرف، احنا مش شايفين حاجه. 1 minute هات الصوره وبس.
تمام.
ورينا الاي سي جي لو في الاخر يعني.
تمام. ده الكوروناري ساينس شيث تروما واير successfully passed to the RV. Advancement of the lead.
انا مضطر اقطع عليك.
ماشي.
انت ضيعت وقت كبير جدا في النظري واحنا يعني احنا عايزين نشوف الحاله.
ماشي.
اوكي.
تمام ماشي.
شكرا دكتور معاذ. ايمان سمير.
ندعو الدكتورة إيمان سمير. اتفضل.
كل واحد بياخد الاسبوع.
بسم الله الرحمن الرحيم. This is a teaching case presentation. 15-year-old girl, Down syndrome, with post-surgical history of multiple VSD closure, 2 apical VSD and 1 inlet VSD, small ASCD secundum, BDA ligation, epicardial VVIR for operative complete heart block. This is at age of 1 month. Then she had battery replacement to 2019, then presented to our clinic by true syncopal attacks that provoked by talking and exercise for the last month. General examination, she has Down syndrome features, weight is 50 kilogram, 103.80 in length, heart rate 80 beat regular, no signs of hemodynamic compromise, with local examination, scar of open heart and left subcostal pacemaker, murmur of aortic regurgitation. So our approach to syncoping pacemaker patients, the first consideration is this syncope is true syncope, which second thought are drugs playing a part, so Down syndrome having multiple drugs. Third matter to consider whether pacing mode is correct. The fourth matter whether attack arrhythmia could be responsible for this syncope and possibility of pacemaker malfunction. And so we exclude the rule of drugs, then did the 12-lead ECG, chest X-ray, and then the pacemaker found to be, if the patient found to be pacemaker dependent, we will done the investigation for syncope in patient, and this is an important step in our approach.
يا إيمان عشان ما أقطعش عليك.
So this is the 12-lead ECG. She had epicardial VVIR, and the morphology right bundle, and the epicardial lead was placed on the LV surface. This is her echo. It was the septum has average dimensions. Septum was 10 millimeter. No residual defect since surgery. And the coronary sinus patent. She has moderate aortic regurgitation. This is the chest X-ray at 1 month of age, and then at 15 years of age when she presented to our clinic. Next, we did interrogation. Once we have interrogation of the device, we see the patient's completely dependent on pacemaker, ventricular pacing 100%, and when we do provocation measures, we did leg exercise, which we noticed oversensing on the epicardial lead, and this noise was doing inhibition to the pacing function. So with this oversensing on the RV lead, we noticed complete loss of pacing function. So this is inappropriate pacing loss, inappropriate loss of appropriate loss of capture due to oversensing. This is the picture when we see oversensing over the RV lead with doing maneuvers. Then when we try to do maneuvers to remove this oversensing artifact, we did unipolar pacing and decrease the sensing threshold. Then we got this interrogation, V pacing all the time. But still the patient has syncope, and when we try to get her reassured, the mother said that the patient had true syncope 3 times, and the interrogation of the pacemaker, then we decided to go for stress ECG. So my advice here to interrogate the pacemaker after testing to ensure optimal pacing, and search for exercise capacity, chronotropic response, arrhythmia, and pacemaker syndrome. And in pacemaker-dependent patients, go for another testing to ensure that the patient 100% paced.
So we have 1 minute and a half.
Okay, so stress ECG revealed loss of capture, not oversensing. As we're doing stress ECG, we was putting the patient putting the wand and interrogating the device. We have true loss of capture, and the device is giving her pacing spikes, but without capture. This is a picture of loss of capture. So we tried to increase the output, but we tried to increase the output, but the patient had syncope in front of us in the outpatient clinic. So the decision was to implant a new lead and doing dual pacemaker with left bundle area pacing lead. I will skip these videos and put the last picture for the sake of time. And this is the final result of left bundle area pacing. And the epicardial VVI lead was turned to based off. And this is the ECG, final ECG. We have selective left bundle area pacing with RSR dash pattern in V1. And our wave peak time was about less than 80 milliseconds. And this is the echo after left bundle area pacing lead. And this is the programming and the epicardial lead based off. So take-home message is syncopin-based patient is a serious symptom. Pacemaker troubleshooting, you must be aware of this. I don't see what brain doesn't know. Down patients need special care regarding they are poor historian, and they need close follow-up and regarding comorbidities, and they have more risk for infection and anesthesia. They have atlantoaxial subluxation, so you must do general anesthesia. Left bundle area pacing is visible in patients in congenital heart disease on short and mid-term outcome, but less observational data. Response to resynchronization was variable and preferred to have C304 deflectable sheaths and know the level of block. Thank you.
دكتورة أسماء عبد الحميد.
هقول بس يعني two comments مش هفتح discussion ولا حاجة. Case number 1 very nice work. Who knows البروسيدورز دي بتاخد قد ايه ومجهود قد ايه يعرف ان الحالة دي مبذول فيها شغل عظيم. Thanks for the team. Case number 2 it should be reported. لو هي لحد دلوقتي is not published come on this should be reported.
محمد سامي انت من الازهر والحاله دي من جامعه الازهر. انا احب برضو اقول يعني في الاخر بقى ما نقول الفائزين هنقول جايين منين، بس الحاله دي فعلا دي اكتر حاله شدتنا كلجنه تحكيم وقلنا لا this is something يعني should be recorded and should be published.
هي محمود البنا صح؟
محمود البنا.
Case number 3 the maneuver that was excellently done demonstrate noise that speaks of a lead fracture. I would change it from the get-go without waiting for anything else. تاني حاجة left bundle area pacing it's an overstatement to say that it is selective just by looking at the electrocardiogram. It's left bundle area pacing, not sure whether it's selective or non-selective. Thank you.
شكرا دكتور أحمد على المعلومات الجميلة اللي بنستفاد كلنا منك. يلا يا ياسمين.
السلام عليكم. I'm Asma Abdel Hamid. We have sample interesting case today, BVCs in a child with type 1 diabetes. Coincidence or connections? 9 years old male patient, the patient diagnosed with type 1 diabetes 2 years ago received insulin therapy, but with poor glycemic control and recurrent attack of DKA. He presented 6 months with palpitation associated with history of pre-syncope. اللاب كان irrelevant ومعدل الهيموجلوبين A1C كان 7.9. ECG was done وshowed frequent monomorphic BVCs والlocalization بتاعها as you see here في positive QRS في V1 with right bundle morphology مع positive concordance for leads that suggest LV origin of BVCs from basal part. Positive QRS في inferior leads suggest outflow tract origin. So Holter was done. BVC's burden كان 41.8 with run of non-sustained VTAC. Echo was normal LV dimension and function. MRI was done with no fibrosis. How should we evaluate and manage a case of frequent BVCs in child? based on American Heart Association 2020 we must started with clinical evaluation risk stratification using Holter و ECG و ECHO و MRI عشان calculate the BVC's burden و identify risk factor for cardiomyopathy. واخر حاجه بعمل treatment الاوبشنز اللي موجوده الميديكال ثيرابي واللايف ستايل موديفيكيشن وانترفنشن. أنا يعني this diagram show in American Heart Association برضو نفس الجورنال 2020 هو مقسمها. هو دي الحاجة الوحيدة اللي أنا شفتها في الأطفال مثل البي في سيس بيردن، وإحنا هنا البي في سيس بيردن بتاعنا كان أكتر 10% اللي هي هتبقى المفروض أوفر أبليشن. proper management للعيان. We started the medical treatment in form of calcium channel blocker. Without improvement, patient referred to the pediatric endocrinologist for glycemic state optimization. Hemoglobin A1C can 6.8 before procedure. The patient was scheduled for 3D carto mapping and ablation. Pre-operative precautions for diabetes were followed, include fasting duration والinsulin therapy plan. Activation mapping and ablation, comprehensive 3D electroanatomical mapping was formed with carto. As you see, initial surface ECG, intercardiac EMG mapping identified left ventricular outflow as an area of interest. So 3D mapping was started. 3D activation mapping confirmed the surface ECG. 3D activation confirmed earliest activation site at aortomitral continuity preceded the surface QRS onset by 34 milliseconds. ده different view ودي البروباجيشن ماب. انا عايزه اشغل الفيديو مش
اشتغل الفيديو يا اسماء.
سوري. اوكي. successful ablation وانا عايزه اشغله was done at aortomitral continuity. انا هسكيب اوكي. السايت كان aortomitral continuity باور 25. اوكي
لسه قدامك دقيقتين ما تخافيش.
اوكي. الاي سي جي ابليشن الاي سي جي افتر ابليشن كان ما فيش بي في سيز. الهولتر افتر 3 months marked improvement in ventricular ectomy من 41.8 to 0. Let's discuss the question now. Is ablation alone enough as a definitive treatment in this patient? Does he remain a risk for recurrent arrhythmia or sudden cardiac death? What is the long-term cardiac prognosis in pediatric patient with BVCs and type 1 diabetes? Based on European Heart Rhythm Association 2019 ان لو العيان structurally normal heart والكاستر ablation of idiopathic BVCs originated from LVOT or aortomitral continuity high success rate بتاعها 90 ل 95% والlow recurrent rate. Long term prognosis is generally excellent if LV function remaining normal وال BVC's burden is reduced to أقل من 5% post procedures. There is no underlying myocardial fibrosis or structural disease. Follow up with ECG and Holter every 6 to 12 months is recommended to ensure sustained remission. Risk of sudden cardiac death, according to this journal, idiopathic BVCs in children with normal ventricular function and imaging rarely cause the sudden cardiac death. However, the coexistence of type 1 diabetes may increase the cardiac electrical instability due to autonomic neuropathy, prolonged QT interval, and impaired repolarization. Studies have reported the higher QT dispersion and the ventricular arrhythmia risk of in diabetic children, especially with poor glycemic state. Clinical implication, ablation successfully eliminated BVCs and prevent further ventricular. Okay.
ماشي كده. حلوة، شكرا جزيلا. next speaker الدكتور أحمد رمضان. أنا بس هذكر حاجة عن الدكتور أحمد رمضان، إنه دكتور من وزارة الصحة وبيشتغل في الفيوم وليه اهتمامات الكتروفيسيولوجي. يعني فعلا he is the star of فيوم in electrophysiology، وبيحضر معانا اونلاين وبيجتهد جدا جدا جدا. فهو يعني نموذج الطبيب المثابر من وزارة الصحة اللي بيعلم نفسه بنفسه وبيتخطى الصعاب. وأحمد رمضان فينومينم. أحمد.
السلام عليكم. طبعا
كومنت سريع بس عشان ما فوتهاش وارجع لها تاني. الكيو ار الباثوجنومونيك للاورتومايترال ما كانتش موجوده في العيانه دي، طبعا اللي عارف يعني عارف ان السنسيتيفيتي قليله في الساين دي، انما if it's there
كيو ار in which lead
V1 كيو ار ان V1 is aortomitral continuity. على العكس كان في سليرنج كده يخلي الواحد لما يشوف يقول دي غالبا هتتكوي صامت، ومع ذلك المسافه ضيقه قوي، احيانا بيتكوي هنا واحيانا بيتكوي هنا. شكرا.
ابدا العداد بقى.
السلام عليكم. بسم الله الرحمن الرحيم. طبعا my case is male patient 11 years old. الكومبلين بتاعته الفيرست برزنتيشن والكومبلين كانت اتاكس وبالبيتيشن بس without any documented tachycardia في الاي سي جي. فهو اثناء الاكزامينيشن كان diagnosed انه هايبرتنسيف، وكان البلاد بريشر بتاعه 150/90. كان في ايكو الفيرست ايكو كارديوجراف نزله كان في مايلد كونسنتريك ال في اتش. الهيستوري بتاعنا ما فيش اي فاميلي هيستوري، كله نيجاتيف، ما فيش اي فاميلي هيستوري، ما فيش اي ميديكال هيستوري، ما فيش غير ان هو الاتاكس البالبيتيشن، وهو ما فيش اي بوزيتيف فاميلي هيستوري لاي ريبوزيشن او اي سادن كاردياك ديس او اي حد في الفاميلي كلها. وكان البلاد بريشر بتاعه كان دايجنوزد على ان هو هايبرتنسيف، وان الكونسنتريك ال في اتش ده من الهايبرتنشن، وكان ادفايزد انه يكنترول بلاد بريشر والويت ريدكشن، ودي كانت البلان بالنسبه له. الاي سي جي ده الاي سي جي بتاعه ما كانش فيه واضح يعني ابنورماليتي تشخص اي ريبولاريزيشن ابنورماليتي بالنسبه له توضح الاتاكس البالبيتيشنز اللي كانت بتيجي، بس ما كانش فيه سينكوب، هي كانت اتاكس بالبيتيشن وما فيش اي دوكيومنت تاكيكارديا خالص. ده ريستنج اي سي جي بتاعه. عمل كده الايكو كان فيه مايلد كونسنتريك ال في اتش، ورايت سايد ورايت فنتريكولار دايمنشنز نورمال، ومفيش اي اذر ابنورماليتي في الايكو. يعني في حاجه احنا لاحظناها فيما بعد.
كمل بسرعه
يعني. ده الايكو بتاعه امبيولاتري هولتر، ما فيش اي دوكيومنت كارديا وما تسجلش اي تاكيكارديا او اي اريزميا سوبرا فنتريكولار او فنتريكولار اريزميا. عمل اكسرسايز اي سي جي برضو عشان لو في اي لونج كيو تي او حاجه تفسر اي اتاكس من التاكيكارديا او ريبولاريزيشن ابنورماليتي مع الاكسرسايز. الاكسرسايز كان نيجاتيف. هو كان ادفايزد الويت ريدكشن والبلاد بريشر كنترول، بس حقيقي في الاول احنا ادفايزد ان هو يعمل كاردياك ام ار اي عشان الاكسبلانيشن بتاع الكونسنتريك ال في اتش ما كانش بالنسبه لنا اكسبليند انه يبقى في الاي جي ده وهايبرتنسيف، يعني نوري دايجنوزد 150/90 ويبقى ال في اتش اللي موجود عنده في الايكو. فكنا ادفايزد ان احنا يعمل كاردياك ام ار اي، بس هو بوستبوند وما عملش الام ار اي. اللي حصل بعد كده ان هو جاله اتاك، الطفل وهو في المدرسه يعني حصل له اتاك اوف سينكوب، ودي كانت دوكيومنتد وريكوردد في الكاميرا في السيرفلنس كاميرا بتاع المدرسه، واتشافت واتسجلت. فلما اتشاف الاتاك بتاع السينكوب عمل بعدها الكاردياك ام ار اي. ده السي ام ار زي ما احنا شايفين طلع فيه سوبيريور ار في او تي فوكال انيوريزم سجستيف طبعا، ودياجنوستيك ان هو اي ار في سي او اريزموجينيك كارديوميوباثي. ده بالنسبه للكاردياك ام ار اي بتاعته زي ما احنا شايفينها. والليفت فنتريكولار وول سيكنس ده ما كانش له اي اكسبلانيشن في الكاردياك ام ار اي. عمل بعد كده جينيتك تيست طبعا كونفيرم الدايجنوزس انه اريزموجينيك او فنتريكولار كارديوميوباثي، وده الجينيتك تيست بتاعته. وكان طبعا البلان هو الاي سي دي امبلانتيشن اريزموجينيك سينكوب، فكان البلان والديسيجن اي سي دي امبلانتيشن. وهنشوف طبعا احنا مش معانا فيديو للفلور بتاع الاي سي دي، بس فينا الايكو اللي احنا سجلناه له اللي انا مصوره له، ده كان الايكو اللي بعد ما عمله. ما كانش معايا الايكو الاولاني، بس الايكو اللي عملناه له بعد الاي سي دي. هنشوف الاي سي دي ليد. وحقيقي يعني لاحظنا بعد كده لما بعد الكاردياك ماي الجزء بتاع الار في او تي ان في جزء صغير اللي هو اللي فوق ده يعني، بس طبعا ده ما كانش يعني حد ملاحظه في الاول خالص ان هو ده ممكن يبقى. شكلها زي صادن. هقول لحضرتك بس اللي
كان نفسنا نشوف الفيديو بتاع
ما هو
المدرسة.
الفيديو الحقيقه للاسف ما
بس كويس
لقيناهوش
إن في
بتاع
مدارس-
المدرسه. هم
ده في الفيوم ده يا احمد صح؟
في مدرسه وهم
الجمال ده؟
جابوا مامته وروها وشافت
مامته
الأتاك
دكتوره
نفسها.
فخافت طبعا فدخلت في كده. طب
هي منظره طبعا كان بالنسبه لها يعني حاجه مرعبه بالنسبه لها
بس
وعشان
الجينيتك-
كده بعدها راحت عملت الجينيتك تيست وعملت كل بقى يعني
جينيتك تيستنج في مصر؟
هي عملت على حسابها.
فين في مصر يعني؟
هو هنا اللي موجود هنا
زي
فوق هنا ده الاي سي دي ليه طبعا بعد شايفين الليد ده الايكو الاي سي دي.
وكل ده اتعمل تامين صحي صح؟
الاي سي دي
يعني
هو
طبعا
الدكتور اسامه هو اللي ركب له الاي سي دي.
مين؟
دكتور اسامه اللي ركب له الاي سي دي.
اسامه
دكتور اسامه عبد العزيز.
طب كويس في ابو الريش بقى جالك هنا صح؟ مش في ابو الريش؟ طيب في الفيوم بقى؟
لا ركبه له هناك.
طيب ماشي خلاص شكرا.
تمام. كيس نمبر 6 دكتور عمر ندى.
Assalamu
اتفضل
alaikum.
دكتور عمر.
Our case today is the cryofreezer ablation of of anteroseptal accessory pathway. This was a very challenging case. The history is 11 years old male patient, athlete with age of starting to be practice with the age of 5 years old, and he is making routine ECG, and this was the ECG. So here we're WBW, and I will proceed according to the Aruda algorithm. It was anteroseptal accessory pathway. Okay. We're starting our case by resting ECG. This is here pre-excitation. This is the cryo machine, and this is the catheter of cryofreezer. Here I will show you how it's working. By freezing the area instead of usual RF ablation. Why we choosing here the cryofreezing? Because this is very precious baby, very precious boy, and he was anteroseptal, and we are fearing from complete heart block. So we choose this catheter for this boy. Here we are starting mapping like conventional anteroseptal mapping. Here we are proceeding by 35. We are proceeding the delta wave by 35 milliseconds. Okay. Also here, we are choosing like we are doing usual conventional method. I will show you the video because the video is very long. This is live screen of what we are doing. This is here this is long sheath with a cryo You are seeing the mouse here. I will proceed the video, so I will show you how we are doing it. Can someone help me, please? I can't see the arrow. أنا عايز أعمل proceeding للفيديو قدام شوية عشان هو 10 minutes. لا ما هو كده يشتغل 10 دقايق، فأنا عايز المسطرة اللي بتبقى فيه دي. أيوه. Okay. Yes. I will show from here, no problem. No. لا I will proceed. لا مش لازم slide show عشان مش هنشوفها. The video is very long, which I will proceed because of the minutes. Here, we will choose where we will ablate. If we appreciate a good site for ablation, we will start cryo mapping first. That's what we are offering here by the machine. This we are starting here cryo mapping, not cryo freezing. The temperature here will be minus 30, so we will start counting and we will see if there is loss of pre-excitation or not, and we will see if there is complete heart block or not. Here, the accessory pathway is very challenging, so I will go next. Here we choose a good site for ablation. We were starting here, so the temperature we will check. Sorry, because the video is very long, I will minimize the time. Here, yes, we start here. Minus 90, minus 11. Loss of pre-excitation. We will change to cryo freezing. And we will proceed for 4 minutes safely without complete heart block. Okay, I will go. Here we are completing. And open timer here. We finish here and open timer. That was safe anteroseptal accessory pathway ablation without heart block. This is post ablation ECG, okay? This is, I will make full screen. Here, normal PR interval, loss of pre-excitation, no pre-excitation. Okay, so my conclusion, anteroseptal accessory pathway or parahesian and anteroseptal accessory pathway is very high risk for complete heart block, so cryofreezing offer an option for safely ablation this accessory pathway. Thank you.
Okay, comment سريع. I always look in the non-coronary cusp and the commissure between the non-coronary and the right coronary for the fear of the small risk of recurrence اللي مع الكرايو. وكنت ابقى مهتم اعرف هو العيان ده البروبرتيز بتاعت الباثوي دي ايه قبل ما بروسيد الابليشن. انا كنت مضطر اعمل كده ولا ممكن افوته as a mole in the face of the patient. Thank you. ان شاء الله الحلقه اللي بعد كده يقدمها لنا دكتور حامد جابر. اتفضل يا فندم.
Good evening. Today I'm going to present a case titled by Not All That Delta is Dangerous. And this is one of the key messages of today. We have a 17-year-old young boy presented to us by a usual history. Recurrent attack of palpitation, echocardiography normal, but there is no documented attack of tachycardia. But regarding resting ECG, we have this ECG. This is a pre-excited ECG, so we will go for localization. This is normal axis, transition V3, lead 3 AVF positive QRS. As we see, lead 2 positive, lead 3 somehow negative AVF V1. So we are facing a case of antro to mid-septal accessory pathway. This was our scenario, and this is what we're going to do. So anteroseptal accessory pathway, as Dr. Omar said in the previous case, carry a high risk for complete heart block. So we were ready by cryofreezer. And the cryofreezer, one of the most recent technique we use in ablation of anteroseptal accessory pathway, as we see in the previous case. And we have cryomab and the cryoablation. We start by cryomab by reaching -30, which is reversible if complete heart block happened. And this was our scenario. We started our study as we see the pre-excitation. The retrograde was dissociated at 410 milliseconds. The antigrade effective refractory period was 260. And we trying to map the septal region. We tried to map all the tricuspid annulus, but unfortunately we failed to get amalgamated A and V. We failed to get fusion. So we tried to induce tachycardia. Also, we failed to get tachycardia by all pacing method. What can we do right now? We started to think about this case slowly until we get this beat. The clue will be from one beat. It will solve the problem. As you see, this junctional beat, is it a usual junctional beat? It's not usual. Why? Because the junctional beat exactly matches the pre-excited beat. What does this mean? A junctional beat exactly matches the pre-excited beat. It means that the accessory pathway is close to his or fascicle. The same activation from atrial and junctional. It is a bystander accessory pathway, a fasciculoventricular accessory pathway. I think this is our diagnosis, fasciculoventricular, but we will continue our study to reach a definite diagnosis. And one important note about this accessory pathway, it is not a tachycardia sustaining tract. We will fail to induce tachycardia as it's safe accessory pathway. Now we get his catheter, and one of my key messages for this case is that his catheter is crucial. It helps us in diagnosis of many cases. We will go for pacing from retrograde. As we see, the AH is prolonged, decrement, but HV is the same in all pacing. We'll continue by atrial pacing. As we see, the same happened. AH is prolonged, as we see here, the AH prolonged. With the same phenomena, HV is the same. Continue pacing, the same. AH prolonged and HV is the same. So this is our case. Is it a fasciculoventricular? Now we can say definitely it is a fasciculoventricular accessory pathway. Now we will go for risk stratification. We induce the AF. And this is the AF. It's not a dangerous AF. As you see, the shortest RR is 332, which is safe. It's not a dangerous AF. So, is it atrioventricular? No, it's a fasciculoventricular. It's not a usual pathway that we are operated every day. And you see here the other types like Mohaim, nodofascicular, LGL, and our case is fasciculoventricular. And this is a diagram for normal conduction system and different type of accessory pathway like atriofascicular, nodoventricular. And this is, I'd like to present, put a pressure in our case, the fasciculoventricular. This is the fasciculoventricular, which is a safe accessory pathway. It's not a dangerous, and it's infranodal. As you see here, it arises from the fascicle and originates in the ventricle. The fasciculoventricular pathway, connection between his Purkinje fascicle to the ventricular myocardium. It is uncommon but benign pathway. Doesn't cause tachycardia at all, and this is one of the key features of it. It's infranodal, and this is very important for risk stratification. No increased risk for sudden cardiac death from AF pre-excitation, and no rule for ablation as it carries high risk for heart block. And my take-home message: not all accessory pathway require ablation. His catheter is crucial. I think that his catheter helped us a lot in diagnosis of this case. And recognizing fasciculoventricular accessory pathways prevent us from unnecessary ablation nor the AV node, reducing the risk of complete heart block. And thank you.
عايزه اقول حاجه ان حامد طالب امتياز في جامعه اسكندريه وهو مهتم بالالكتروفيسيولوجي ويمكن بيفهم الالكتروفيسيولوجي زيه زي اي فيلو في البورد المصري للالكتروفيسيولوجي. انا بس مش بضغط عليكم ولا حاجه يعني. ده رايي الشخصي.
شكرا جزيلا دكتور حامد. هو احنا مش محتاجين نعمل مابينج ولا نديوس تاكيكارديا عشان نثبت ان هو فاسيكولو فنتريكولار. احنا المفروض من البيز لاين ستادي اللي هي الاتريال اكستراز اول ما نشوف البري اكسايتيشن ما بيزيدش نشك ان ده فاسيكولو فنتريكولار. ثانك يو.
نرجع تاني محمد سامي. فاطمه صبري.
It looks funny. It's an anteroseptal pathway that looks funny.
Second speaker, دكتورة فاطمة الصاوي. Second case by دكتورة فاطمة الصاوي. اتفضلي دكتورة فاطمة.
نزلي لها الميكروفون شويه لو سمحتي. متحيزين شويه معلش.
السلام عليكم. معهد فاطمة الصاوي معهد القلب. بسم الله الرحمن الرحيم. Beyond the extrasystoles when the heart speaks twice. الكيس female patient 13 years old, second sibling, non-consanguineous marriage. The main complaint frequent attacks of palpitation with exercise intolerance. The condition started 1 year ago with attacks of palpitation associated with pre-syncopal attacks. ECG finding couplets BVCs outflow tract organ. Echo dilated left ventricle with preserved function and Holter BVCs burden 20%. So we started medical treatment in the form of beta blockers and trials with other anti-arrhythmic drugs like verapamil and amiodarone. And with the follow-up, the patient presented to the ER with a slow VT following a presyncopal episodes. And then we ask when to treat a case of BVCs and when to ignore. Symptomatic children with normal ventricular function and low ectopy burden can be followed without any intervention and generally assured. Children with ectopy burden more than 30% are some risk of developing LV dysfunction and should be closely followed with non-invasive imaging like echo and MRI. Development of symptoms attributed to the ectopy or signs of increased LV dimensions or LV dysfunction should be treated with medication or catheter ablation. So with this case, with trial with medical treatment and refractory to this medical, and so we decide to ablate this case. And so before ablation عملنا localization للBVCs من بالاي سي جي. كان احنا قلنا suspect الاول ان احنا عندنا negative QRS في V1 and V2 and ممكن كمان في small R كمان في V1. فقلنا وبوزيتيف QRS in V3 and V6 قلنا maybe RV or LV outflow tract. Negative QRS in VL exclude in here high lateral LV free wall origin. And positive QRS in inferior leads on in suggest in superior origin LVOT and most likely to be left coronary cusp or adjacent region. And so we started to fluoro during the mapping and ablation. هنرجع له بس تاني بس ده الفيديو بتاعه. Find confirm واحنا using start ب 3D mapping with the CARTO system and to accurate delineate the early sites of ventricular activation and this confirming surface ECG localization with previous ECG. And so the activations mapping demonstrated focal pattern arising from the left ventricular outflow tract with the earliest local electrogram preceding the onset of QRS, surface QRS by 37 milliseconds, and pattern matching can 98. وده الفيديوز، ده اللوكال بروباجيشن، بس انا مش عارفه اشتغل ازاي. نشغله. اوكي، ده البروباجيشن مابينج. And then we start the ablation, energy delivered, and at the site of left coronary cusp. ممكن أشغل ده. Delivered power 25 watt, temperature 48, durations can 16 seconds. And end point non-incubacity within 13 minutes. Follow up after ablation. The post ECG after procedure, resolution of BVCs. Echocardiography improved the LV dysfunction after 3 months. Holter ECG after 3 months, no BVCs or documented. احنا عندنا في lecture reviews في retrospective study using carto mapping اتعملت في الصين في Chinese radio frequency catheter ablation of premature ventricular contraction children under carto system retrospective study كان فيها high success rates and low recurrence and complication rates. Another retrospective study done على 72 patients in children with idiopathic BVCs and asymptomatic VT. Developed LV dysfunction is associated with higher burden BVCs and presence of SVT and couplets. LV dysfunction appear to be reversible if the burden of BVCs is decreased by medication or ablation. And also this study total على الأورتيك كاسب ablation كان إن في significant difference في الساين والrequirement on the basis of locations during the mapping and ablation بنحددها careful non-invasive test before ablation. And take home message, careful ECG analysis on the guide localization of BVCs. LVOT BVCs are often arise in left coronary cusp. Ablation with precise successful outcome. Early ablation of arrhythmia can improve LV dysfunction. Thank you.
So moving to our next speaker, Dr. Karim Wasfi will present an interesting case.
هقدم كيس عن الليفت كرونيك كاسب برضه PVCs زي ما زمايلي قدموا. It was a 10-year-old male patient. He was medically free. He has no relevant past history nor family history. العيان ده he started 2 years ago when the patient complained with irregular palpitations of sudden onset and offset, lasting for seconds to minutes. It was progressive in course and not responding to any medical treatment. حاولنا معاه كل medical therapies، ما فيش حاجة بتأثر فيه، والولد كان very symptomatic. The patient sought medical advice. This was his ECG. His echocardiography showed a structure normal heart. عملنا له 24-hour Holter ECG. Showed a monomorphic PVC burden of 36.8% burden. So العيان جه وقلنا نشوف نلوكلايز السيرفيس ECG بتاعه. زي ما حضراتكم شايفين احنا عندنا positive leads في الانفي positive في الانفيل leads فmostly the outflow tract origin. الترانزيشن كان تقريبا عند V3 from V2 to V3 فاحنا ما كناش متاكدين ده RVUT ولا LVUT. زي ما حضراتكم شايفين في الدايجرام هو it's a queer thing يعني. فاحنا قررنا نعمل نخش نعمل EP study للعيان ده because he was symptomatic despite optimal medical treatment. دخلنا عملنا في الأول mapping conventional RVOT. دخلنا بديكا بولر كاثيتر في الكورونري ساينس والابليشن كاثيتر. بس للأسف ال earliest point was very small. It was just 18 milliseconds. حاولنا كذا مرة بالابليشن. The early space got only by the activation map wasn't very early. Ablation at the relatively early point resulted in the partial disappearance of the PVCs. بس للأسف رجعت تاني واحنا لسه شغالين. Anatomically, the RVOT is anterior and to the left of the LVOT. فالمفروض simultaneous mapping is done للposterior RVOT والanterior wall of the LVOT لو الPVCs ما اختفتش يعني. فاحنا قررنا نعمل كارتو ابليشن في زي ما شايفين في الدايجرام. البوستيريور اسبكت بتاع الRVOT قريب جدا من الانتيريور اسبكت للLVOT. فقررنا عشان هو طفل صغير وعشان الريسك اوف اللي هو left coronary cusp في ريسك اوف left main spasm او ممكن نعمل انجري للعيان ده. فقررنا نعمل كارتو عشان it is the safest. فعملنا 3D mapping وكارتو ابليشن. دي صور ال 3D mapping للعيان وعملنا activation points خلاص. و ال earliest point was 31 milliseconds away من ال PVCs. حققنا صبغه من قسطره الابليشن عشان نتاكد ان احنا بعاد من ال left main. وكنا فعلا بعاد من ال left main وعملنا ابليشن الحمد لله. It was successful. The earliest point got by the activation mapping was early by 31 milliseconds at the left coronary cusp. Ablation at the relatively early point resulted in total disappearance of PVCs after waiting time of 30 minutes. ده كان شكل ال ECG بعد ال PVC ablation والولد symptomatically اتحسن drastically يعني. ال aortic cusp VTs المفروض originating from the sinus of Valsalva accounts for 20% of idiopathic outflow tract VTs, mostly from the left coronary cusp. Left coronary cusp is the most common. بعديها right coronary cusp وبعد كده right coronary cusp, left coronary cusp junction, و rarely the fibrous non-coronary cusp. The main complication from ablation within the aortic cusps is the acute occlusion of the left main coronary artery. It's therefore important to identify the coronary ostium of the left main or RCA by angiography زي ما احنا عملنا. المفروض ناخد a margin of 5 to 6 millimeters from the left main coronary artery should be observed علشان ما نعملش أي occlusion أو نعملش أي damage لل left main. Therefore, ablation should only be performed after failure of at least one class of 1C agent. And thank you.
كريم أحد شباب الزمالة أو يعني البورد المصري الزمالة سابقا ومن المجتهدين في رعاية الدكتورة رانيا سمير في جامعة عين شمس. دكتور ضماطي.
حاجة حلوة قوي يا كريم. I wouldn't have mapped the right side first. I would have gone to the left side right away. Thank you.
Thank you, Dr. Karim. I invite Dr. محمد آدم to present his case.
محمد آدم شيخ الزمالة. هو خريج من زمان وبيساعدنا في التدريس والتعليم وهو إهرا سيرتيفايد بيشتغل في دمنهور التعليمي يا محمد؟
دمنهور التعليمي ومعهد القلب.
معهد القلب ودمنهور التعليمي. ده يبين قد إيه البورد المصري للإلكتروفيسيولوجي بيطلع أجيال بتخدم في كل محافظات جمهورية مصر العربية. أنا ممكن أقول لكم كل المحافظات اللي مشتركة بس لما نقول الجوائز.
بسم الله الرحمن الرحيم. H is a 4-year-old child referred to our institution by decompensated heart failure with recurrent PICU admissions. He was kept in anti-failure measures including ACE, furosemide, spironolactone, digitalis. Amiodarone was prescribed because of incessant tachycardia. He had a negative family history of medical importance. This is the 12-lead ECG of the patient. When we saw this ECG, we can notice a negative P wave in the inferior leads. 3 important differential diagnoses will jump to our mind: the focal atrial tachycardia, atypical AVNRT, and PGERD. His echo showed a dilated LV internal dimension for age and reduced LV systolic functions 43%. He had an arrhythmia during the echo exam. So we have a presumed case of tachycardia-induced cardiomyopathy. We will see later on. So we have class 1 indication for catheter ablation in this patient. Sorry. At the start of the procedure done under general anesthesia. Regarding access and setup, we have 6 French sheaths in the femoral vein to introduce the coronary sign of catheter, and 8 French sheaths across which penta-ray mapping catheter and smart touch ablation catheter were introduced alternatively. Activation mapping of the right side during tachycardia was done using a CARTO3 mapping system. So at the start of a procedure, this is a ECG, like the pre-ECG we have seen. So we have to diagnose, we do VOP during tachycardia. Okay. The tachycardia in trained, leaving a post-pacing sequence of VEV response and slightly long PPI of 130 milliseconds. From this, we can exclude atrial tachycardia, and we cannot exclude the PGERD. We cannot prove, in this case, an AVNRT, because we have a decremental accessory pathway. Maybe we have a slightly long PPI. Other maneuver for differential diagnosis to separate the PGERD and AVNRT, and I'm sorry that tracing is not available with me, we have scanned the whole diastole by PVCs and found the his synchronous PVCs which delayed the next A. So we have confirmed the presence of accessory pathway and its involvement in tachycardia. The activation map. Earliest site of atrial activation was demonstrated at the left post-receptal region. Propagation map also. Successful ablation sites here within 5 minutes. 5 seconds. You can notice the tachycardia is running and stopped, regaining the sinus rhythm of the patient. Successful ablation site within the coronary sinus at the left post-receptal region. This is the fluoro. RF current was 25 watt with irrigated tip catheter, duration for 60 seconds. The response was termination of the tachycardia within 5 seconds, and the endpoint was non-inducibility during the 30-minute follow-up period. 2 weeks post-procedural, dimensions improved. You can notice dimensions from 5.8 to 3.9, left ventricular end systolic 4.1 to 2.7, and the function jumped from 43% to 57%. So the PGERD, permanent junction or persistent junction reciprocating tachycardia, it's a rare form of refractory and persistent SVC occurring in the infants and children. It caused by AVRT using the AV node at the anterograde limb and concealed, slowly conducting accessory pathway at the retrograde limb, often nearly incessant tachycardia with high risk of tachycardia-induced cardiomyopathy. Differential diagnosis, as we said, include this ECG with negative P wave in the inferior leads. It will include atypical AVNRT, PGERD, atrial tachycardia, some cases of sinus tachycardia or sinus nodal entrant tachycardia. It is almost always ablated during SVT, not during V pacing. And this is because of difficulty in engaging the early side during V pacing with such retrograde decremental pathway. Early sites in the registries mainly found in the right post-receptor region, next site left post-receptor region. It can be found in the mid-septal or left mid-septal region. Radio-frequency application in the CS increased the risk of coronary injury, so we must adjust our settings. So my take-home message, PGERD is an orthodromic AVRT mediated by a slowly conducting concealed accessory pathway, usually located at the post-receptor region, resulting in a long RP tachycardia with classically negative P wave in inferior leads, with high risk of tachycardia-induced cardiomyopathy. Catheter ablation is recommended for tachycardia-induced cardiomyopathy by SVT. PGERD is almost always ablated during SVT, not during V pacing. Ablation within coronary sinus needs lower energy settings, especially in children. Thank you.
شكرا جزيلا دكتور ادم. واحنا هنجي بس في اخر اللاست سبيكرز دكتور احمد الرصاصي، ودكتور احمد مدرس مساعد من جامعه طنطا، وبرده من المتحمسين جدا استطاع ان هو يشغل الجامعه بحالات. هو بقى يعني القائد مع طبعا بيومي ووليد رشدي، لكن الحماسه بتاعته والاتقان بتاعه بقى خلينا فخورين ان فرد واحد ممكن يقوم مجموعه ويشغلهم لحد ال 3 دي بيشتغلوا. رصاصي يعرض الحاله.
تمام، شكرا دكتوره ميرفت. لسه ما ظهرتش. الحاجه دي اتعملت طبعا في مستشفى شفا اندر سوبرفيجن الدكتور ميرفت ابو المعاطي ومع
كده ضيعت الحاجه خلاص. انا همتنع عن التصويت.
لا تمام. المهم ديت كانت بنت عندها 13 سنه، كانت عندها سيفير ايبشتاين انومالي وكانت بلاند فور سيرجري وعندها مانيفست بري اكسايتيشن زي ما احنا شايفين في الاي سي جي وريفيرد علشان ابليشن بيفور السيرجري. زي ما احنا شايفين ان في دبل ترانزيشن، واحنا كنا عشان كده سسبكتنج ان هو يبقى رايت بوسترولاترا او بوستروسيتا اكسسوري باسوي. هو اتطفى ليه؟ طيب امسكي ده بقى انا كده. تمام. البلان بتاعتنا بان احنا نستخدم 3 دي مابينج سيستم اللي افيلبل معانا كان كارتو برايم، وهنستخدم كونتاكت فورس سنس كاستر تو اشور اديكويت كونتاكت واجيلس شيس which is a deflectable شيس. والبروسيجر طبعا اندر جنرال انستيزيا. في الاول طبعا ال 12 في اي سي جي بتاعنا لسه فيه شويه بري اكسايتيشن. ان سبونتينيوسلي كان في اندكشن لانتي دروميك اي في ار تي وديجنريتد لبري اكسايت دي اف، وزي ما احنا شايفين ان هو فيري رابيد اتريال فايبريشن. دينا دي سي شوك وبعدها بدانا نعمل اتريال بيسنج. مع الاتريال بيسنج نلاحظ ان في عندنا تو مورفولوجيز، التو مورفولوجيز قريبين قوي من بعض، فاحنا دلوقتي قدام بوسيبيليتي بان احنا نبقى نتعامل مع مالتيبل اكسسوري باسوي، او يا اما دلوقتي يكون فيوجن ما بين الكوندكشن في الاي في نود بس احنا سسبكتنج اكتر ان ده تو اكسسوري باسوي، يبقى ديت هتبقى حاله صعبه. بدانا قلنا بان احنا نستغل التكنولوجي بتاعت الكارتو. احنا ما كانش معانا مالتي بولار كاستر، عشان كده عملنا الاول الكترو اناتوميكال ماب للرايت اتريوم والرايت فنتركل، وعملنا انوتيشن والويندو اوف انترست بتاعتنا كانت اوبن ويندو لاز ماتش بوينت از وي كان بالسمارت تاتش من اول حته الرايت بوستروسيبتال ريجون لحد رايت لاترال ريجون بتاعتنا. وده كان شكل المابينج. طبعا احنا شايفين مالتيبل جوسي سيجنالز زي ما احنا متعودين في حاله الابشتاين، وبنعمل اتريال بيسنج عشان يبقى ظاهر معانا الماكسيمال بريك سايتيشن، وده الاكسس باسوي اللي احنا اشتغلنا عليه في الاول. نلاحظ هنا بقى الجزء بتاعنا ده لو احنا عملنا ابلكيشن اكستندد ايرلي ميت سليت على الجزء ده نقدر بان احنا نلعب في الابر واللور ثريشولد لحد ما احنا نحدد المكان بتاع الجاب. ده الانفيريور سيرفيس اوف ذا هارت. نلاحظ بان احنا ناحيه الرايت بوسترو لاترال ريجن شويه. مجرد ما بدانا ابليشن في الحته اللي كان فيها الجاب اللي هي الجزء اللي فيه الابليشن بوينتس انوتيتد، نلاحظ بان على طول الاكسس باسوي حصل لوس البريك سايتيشن والاي في تايم برولونجد. طبعا ده شكل الاي سي جي بتاعنا بوست ابليشن، يعني شكله يبدو ظاهريا نورمال اي سي جي، بس ده مش اللي احنا مستنيينه في عيان ابشتاين. احنا منتظرين ان احنا نلاقي رايت باندل. قلنا خلاص نبدا نعمل ستادي بالراحه. بنعمل في بيسنج لقينا اندكشن لورثودروميك تاكيكارديا، عملنا كونفirmation بان هي اورثودروميك اي في ار تي عن طريق الانتريمنت، ونلاحظ ان في رايت باندل ظاهره ديورنج التاكيكارديا. التاكيكارديا سايكلينز بتاعتنا 420. عملنا نيو ماب اكتيفيشن ماب، وطبعا غيرنا الويندو اوف انترست بتاعنا علشان نكسكلود الفنتريكل والكيورس، ولقينا بان الايرليست بوينت كان برضه في البوسترولاترال ريجن جاست اباف المكان الاولاني اللي احنا كوننا فيه او الاكسسوري باسوي. ده كان السيجنال اوف ابليشن في تايم بتاعنا 88 ملي سكند. وانس ان احنا عملنا ابليشن حصل ترمينيشن للتاكيكارديا. عملنا في بيسنج عشان نطمن، وشايفين احنا بان في ريتروجريد اي في نود وانكباخ على 430 ملي سكند. بدانا نعمل سي اس بيسنج بس ما فيش حاجه ظهرت معانا، فكان في ديبيت هل ده كان هو فيوجن ظهر معانا ولا لا. بس احنا شفنا بان التاكيكارديا كانت رايت باندل، وبالتالي سحبنا قسطره الار في حطيناها في اللاترال وول اوف ذا رايت اتريوم وعملنا بيسنج. وزي ما احنا شايفين بان في ايفيدنس المهايم كوندكشن، وده كان هو الثيرد اكسسوري باسوي بتاعنا. مشكله المهايم بان هو بيبقى ديستال انسرشن في الار في، وبالتالي فاحنا هنتارجت الايرليست في المابنج بتاعنا. بالتالي عملنا الماب رقم 3، وزي ما احنا شايفين بان احنا عندنا الهوت بوينت فيري ديستال وفيري ايبيكال. عملنا ابليشن في النقطه ديت كذا مره، بس كان بيحصل ترانزيانت لوس للمهايم فايبر كوندكشن ويرجع تاني، وبالتالي اضطرينا ان احنا نغير البلان بتاعتنا وندور على المهايم بوتنشال. زي ما احنا شايفين في الفروق احنا وي ار ابليتنج فيري ديستال، اكن احنا يعني احنا بنأكوي في كافيتري بي في سيز. يعني ده كان المهايم بوتنشال واحنا لقيناه، وهو عند البلو بوينت ابليشن زي ما احنا شايفين ده الابليشن شويه زي مهايم ريزم كده فور 3 بيتس في النص، وحصلت ظهرت معانا الرايت باندل. عملنا طبعا الابليشن والمابنج بتاع المهايم الاساس ان احنا بنعمله مع رايت اتريال بيسنج. بعد الابليشن الحمد لله عملنا اتريال بيسنج من اللاترال وول اوف ذا رايت اتريوم لحد ما وصلنا وينك باك. مفيش الحمد لله اي ايفيدنس المهايم fiber conduction. waiting for 30 minutes and this was the ECG post dilation. البيشنت ده بقى له 4 شهور بيتابع معانا الحمد لله حتى الان ما حصلش ريكارنس يعني، وان شاء الله ما يحصلش ريكارنس. شكرا لحضراتكم.
I love the observation of if there is no right bundle there is something left. بس مش فاهم لاني المهايم ده المفروض انه decremental pathway، المفروض ان هو does not obscure right bundle، فانا مش فاهم ازاي المهايم ده كان taking over. Probably it's not mine. الحاجة التانية I wouldn't ablate looking for the early في المهايم. I would go for the مهايم potential from the get-go. مفيش ابشتاين من غير رايت باند، مفيش. انا بتكلم على الساينس ريزم يعني. وانا كده بفتح باب ديسكشن وانا مش مسؤول، ماليش دعوه.
المطعم هيقفل
يلا يا
لاست كيس دكتور مصطفى ايمن، يلا عشان يبقى ختامه مسك بقى.
مصطفى ايمن من جامعه عين شمس، من عند مدرس. انت بقيت مدرس؟
لا
لسه مدرس مساعد جامعه عين شمس تحت تدريب دكتوره رانيا سمير. يلا يا مصطفى.
Okay, today I'm gonna be presenting and بس انا مش ظاهر هنا عندكم. Today I'm going to be presenting an unusual case of supraventricular tachycardia. This was a 14-year-old female patient complaining of recurrent palpitations. Despite medical treatment, her physical examination and echo were normal. Resting ECG was also normal. This was the ECG documented during tachycardia. As we can see, it's a left bundle morphology tachycardia. So we started thinking of differential diagnosis of a wide complex tachycardia. This could be a VT, supraventricular with aberrant conduction, or maybe a pre-excited antidromic AVRT. So we started with a conventional EP study. First, we started by retrograde AV pacing, which showed retrograde decremental conduction, ventricular extra stimulation. So we excluded the presence of an accessory pathway. Now we started by atrial pacing, atrial premature extra stimulus. Our premature extra stimulus induced, as we can see, the tachycardia with left bundle morphology. And as we observe here, the HV interval First, during resting ECG, the HV interval was 33 milliseconds, but when the tachycardia was induced, our ECG changed into left bundle morphology, and the HV interval became negative 14 milliseconds. So this was pathognomonic for Mahaim tachycardia. The diagnostic criteria of Mahaim accessory pathway: baseline normal ECG, manifest pre-excitation with a left bundle morphology, progressive decrease in HV interval as was shown during our study. So we started by looking for the M potentials. We started by mapping with our ablation catheter on the tricuspid annulus, the lateral and anterolateral region, but unfortunately we failed in obtaining an M potential. So we planned the second procedure using 3D mapping and cartoablation. Our plan was to start with right atrial anatomical map, and then if we failed, we're going to do an RV activation map. This was our catheter setup. Again, the EP study showed the decremental properties of the accessory pathway, the left bundle morphology, the progressive decrease in the HV interval as was shown during the first study. Now we started our anatomical mapping. We mapped the tricuspid annulus. As you can see on the pentarray, the areas showing both A and V were marked as the annulus. We took several points. Now we have a full anatomical map of the right atrium and the tricuspid annulus. We started searching for M potentials, but again, we did not find M potentials, which in literature, it's recorded in around 30% of the cases of Mahaim, you do not find an M potential. So we shifted to right ventricular activation map so we can detect the earliest activation point where we can ablate. To our surprise, as we can see here, the earliest activation point was actually near the tricuspid annulus, not as usual where the Mahaim usually inserts into the right bundle or the right fascicle. Now, when the catheter approached the red point where we, the point where we found the earliest activation, there was a mechanical suppression of the left bundle tachycardia, which returned into normal. This mechanical suppression actually confirmed for us that this was the right point to ablate. This was the site of ablation here. Now we can conclude that this is not our regular Mahaim. This is what we call a short atrioventricular Mahaim, which is usually inserted in the peritricuspid ventricular muscle rather than being inserted into the right bundle. Maybe that's why we could not find the usual M potentials at first, and why we found the earliest RV activation point near the tricuspid annulus. This is our site of ablation. This is during ablation, as you can see here. The left bundle morphology at first. Now, after we started ablation, the ECG normalized and the HV interval returned back to normal. This is our ECG during premature atrial extra stimulation after the ablation. No induction of tachycardia. Now, during extra stimulation, we got the dual AV nodal physiology with the jump from the fast pathway to the slow pathway, which confirms now we have no accessory pathway conduction as was found during our study at first before ablation and during our first conventional AP procedure. Now we confirmed successful ablation of our accessory pathway. After 3 months of follow-up, there was no more arrhythmia, no more palpitations, no more complaints. Thank you.
نادر ده ما بيتشافش كتير. لو هو كده فعلا، هو شكله كده فعلا، ده لا يمثل اكتر من 3-4% من حالات المعايم versus 95 لللمفور. شكرا.
هنعلن النتيجة. قولي لي الرقم وانا اقول لك الاسم. دكتور رانيا ما شاء الله يعني شاطرة جدا في الحسابات.
الفائز نمبر 10.
نمبر 10 is دكتور محمد آدم معهد القلب. ده الأول. جوائز مالية عظيمة. التاني يا رانيا. يلا بسرعة بسرعة، لا عشان يلحقوا المطعم.
التاني نمبر 1.
التاني نمبر 1 معاذ راضي. التالت يا رانيا.
نمبر 2.
التالت محمود البنا. الرابع مين؟
نمبر 12.
مصطفى أيمن. أظن يعني إيه منتهى الحيادية. الخامس
نمبر 11.
رصاصي.
الحقيقة كلكم تستاهلوا جوائز حقيقي، كل اللي قدموا were perfect، مش بس الحالات الافورت والباشن. يلا نصور معاهم بقى. ممكن كل الوينرز دي كلها نصور كده. تعالي نصور مع الفائزين. كل اللي فازوا دول يجوا في النص. وانتوا واقفين كده ليه في النص؟
الغدا في المطعم يا ريت تجروا.
ثانية واحدة يا جماعة، بس ثانية واحدة ثانية واحدة ثانية واحدة ثانية واحدة. Just 1 minute 1 minute please. أحب بس أشكر كل الشركات الداعمة المؤتمر، يعني سواء بايوسنس، بوستون، أبوت، سورين، ماكروبورت، كل الشركات، مترونيك، بصراحة يعني وقفوا جنبنا وقفة كويسة. شركة ماونتينز، دكتور محمد الشاهد، دكتور محمد إبراهيم، دكتور أحمد إبراهيم، دكتور محمد، دكتورة دانا والفريق بتاعها الجميل، يعني بصراحة كانوا شايلين مؤتمر. طبعا أشكر الدكتورة ميرفت، بس هي مش شايفاني. دكتورة ميرفت أشكرها جدا على السيشن الأخيرة بجد، يعني واشتراك الزمالة المصرية ولكهربة القلب، وإضافة قوية جدا، والتيم اللي معاها دكتورة ميرفت ولجنة التحكيم والناشونال والانترناشونال تيم كلهم، تسلم ايديهم كلهم ما شاء الله. وان شاء الله نتمنى يعني ماونتينز تعمل لنا المؤتمر السنه الجايه في نفس المكان ان شاء الله. وشكرا جزيلا، ونتغدى بقى كلنا ان شاء الله. شكرا. شكرا جزيلا شكرا.
ناشفين قوي اصلا.